Good morning. Oh, I like the waves. Good morning again. Oh, thank you. How are you? I have missed you too. It was such a long evening without everybody. Yes, it's over, and we get to spend the whole day together today again. As I set the scene for today, can I already ask everybody who's on panel 6 to make your way and get comfortable in your chair already, including the moderator? This morning, we're continuing, in a sense, with part of the discussion yesterday around the role and the mandate of IHP for UHC 2030. A lot of you mentioned yesterday in the discussion the cross-sectoral nature that this alliance was meant to have in this partnership. And this first session is really looking at that this morning. Just a little bit of an announcement, because live streaming was not enough. And because we just need to remember who was there and make sure that you didn't get dressed for nothing, we're going to have a group picture. You know, all of you look so great. We can't just let that go to waste, right? So at coffee time in the afternoon, we'll have to be very orderly and go down to these stairs and just take a group picture so that you can announce that you were here on the second day of the rest of our lives. It started yesterday. And you can prove it because you have a picture for it. So without taking much time, because we're already running 15 minutes late, although I thought I was threatening enough last night, but obviously I wasn't. But we'll give you the time that you need for this session that is being moderated by Sumil Nagpal, the Senior Health Specialist of the World Bank. And we'll make no other comment than that and let you take over, Sumil.
Thank you and a very good morning. I have a great pleasure of being with you on what promises to be a very yoga-themed session this morning. And why would I call it a yoga session? It's because it's not only because yoga is good in the morning, not only because it's closely linked to the H, the health of the UHC and not healthcare. It's also because, not only because the moderator is also of Indian origin, but for many other reasons. So if you see, we are really stretching ourselves with a very, very long panel, which still manages to squeeze itself in 90 minutes, or rather now 80 minutes. It's also a stretch in terms of being able to accommodate 4 sub-themes. And finally, it is also on a very important topic that stretches UHC beyond healthcare. It takes us to think beyond, think out of the box. And by the box, I actually mean the UHC cube. So we are also talking about flexibility of the UHC cube to think multi-sectorally, to see how we are going to talk about other sectors that will play a very important role in what UHC delivers. So if you are all ready for this yoga session, let's get started. And if anybody feels a little dozy after the short sleep last night, we will also have some stretching exercises to help you stay awake. So we have actually 4 sub-themes this morning. A theme on essential public health functions, a theme on health security, a theme on non-communicable diseases, and a theme on environmental health. Now, these may seem different, but they are so closely linked to each other. None of these can be achieved without us collaborating effectively with other sectors, thinking beyond health sector, but looking at health outcomes and how we can really look at ourselves as stewards of health outcomes as we move towards universal health coverage. There's also a lot of linkages between these topics on how essential public health functions will help reduce the disease burden of non-communicable diseases, contribute to improved health security, and includes initiatives on environment health as part of those public health functions. So they are so closely interlinked, and we are really privileged to have a very distinguished panel this morning. And you will find that we will be a really memorable session because we'll be crisp, we'll be short, we'll be on time, and we will be precise, and because we will be very, very effective in our communications. So let me introduce this panel to you. We have opening comments being made by Professor Stefan Pettersson, who's Chief of Health at UNICEF, and will be making his opening remarks on the multi-sectoral dimensions of healthcare in UHC 2030 on my right. We'll also have, on the essential public health functions theme, we'll have Ed Kelly, the Director of Service Delivery and Safety at WHO in Geneva, to my extreme left. Then to my immediate left, we have Dr. Merai Chatterjee, who's the Director of Social Security at the Self-Employed Women's Association, has also been a commissioner in WHO's Commission on Social Determinants of Health, so very appropriate for the theme. We have Satoshi Izoe, the team leader from the Ministry of Health and in Japan. He's a medical officer for global health coordination, involved in the G7 health agenda. We also heard him yesterday over cocktails. So if you didn't hear all his messages over the drinks, you can now pay a little more attention with sharp minds early in the morning. We have Katie Dane, who's the Executive Director of the NCD Alliance. She's heading a network of more than 2,000 civil society organizations that are focused on NCDs. So really the network discussion that we started last evening continues now. We also have Mr. Somuni Sin, who's the Executive Director of Medicam Cambodia, which is an apex organization of all health sector NGOs in Cambodia. He is an MD and MPH from Tulane with more than 20 years of experience in the sector. We also have Professor Kausar Afsana, who's the Director of Health, Nutrition and Population at BRAC, a professor at the James P. Grant School of Public Health with more than 24 years of experience in BRAC, though she doesn't show that. We also have Ms. Hosinatu Mary Kanu, the Chief Nursing and Midwifery Officer, supervising all the nursing and midwife personnel and professionals in Sierra Leone. She works with the Ministry of Health and Sanitation as one of the 13 directorates in the ministry, and also chair of the Nurses and Midwives Board in the country. So have I covered everybody? Okay. And last but not the least, I must also mention that what you see is the front end, and at the back end we have Dr. Kamyar, who's the Senior Advisor in Global Health at USAID, who's been working tirelessly to organize this session from the USAID side. Thank you very much, and we'll get started without any ado. May I request Stefan for his opening comments on the multi-sectoral aspects of health. Thank you.
Thank you and good morning. I wanted to direct your attention to the H that you see on the screens in front of you. What does the H stand for? Does it stand for health or does it stand for health care? I think we often gloss over it and we say universal health coverage. And Professor Reddy, I think, expanded on this yesterday, saying that health is a lot more than health care. To start with, I think the outer circle, if you remember Professor Reddy's circle slide yesterday, talked about the social determinants of health, which actually in several studies explain about 50% of health gains and health variation. So that's sort of the first observation I wanted to make on the H, that if we truly mean health by the H rather than healthcare, then social determinants are a very big factor in this. But even if we interpret the H as health care, it's very easy to only think about the curative health care. But then we overlook the preventive and the promotive health care, which often fall by the wayside. And the example I wanted to give you in these brief remarks is that in UNICEF, we now have a new health strategy, which we are busy rolling out. And in fact, there we work quite explicitly over the life cycle with several of our section colleagues. Most noteworthy education that has, as we know, a very strong influence on health. Sending a girl to school and keeping a girl in school is probably the most single individual health intervention you can actually pursue. But we also work with our social inclusion and policy colleagues looking at budgetary analysis, public finance management for children, and even within, more narrowly, within the healthcare field, we work with our nutrition and water and sanitation colleagues, certainly on the preventive and promotive aspects, but also on the curative aspects. Can you imagine a safe delivery without running water? And so far we've only been measuring a skilled attendant at birth, and that midwife, if she has dirty hands and nowhere to wash them. So I think quickly, whether we mean H as in health or H as in healthcare, we need to look multi-sectorally. We must remember that most health is arguably produced in the household, but even in health services, we need to look beyond the immediate healthcare sector. So those were my few remarks, Emil.
Thank you, Stefan. And you can already see that everybody is well begun in terms of the keeping in time. Let me now invite Ed for starting the theme of essential public health functions for this morning.
Yep, thanks very much, and thanks for those opening comments. I'm also pleased to have the reference to yoga, given that traditional and complementary medicine sits in our department. And we actually had a big debate on the integrated health services resolution that came before the World Health Assembly, precisely because there was an inclusion. India requested that there be reference back to the traditional and complementary medicine strategy, also approved by the World Health Assembly. There was a big debate with our Canadian colleagues, with a number of other countries, around how it should be worded because of the debate about coverage and about does this fit with it, and essentially where does this fit within the UHC box. So I think, anyway, we don't have a section on traditional and complementary medicine and yoga here, but we can maybe do that later in the day. But I think for our discussion that Dr. Chatterjee and I will try to lead on this, I'll just provide some very brief introductory comments and very much leave the some of the detail, really, and the knowledge on this to her. But I think the reason that we're having this discussion around essential public health as part of this debate, as well as the other topics, is there is a question around where does this fit within the sort of the dimensions of the UHC box. And already we've spent a day talking about issues that are much broader beyond the cube. But when you come to questions around immunization, yes, that fits within our UHC mindset. When you come to issues like clean water, food safety, clean air, how do you start to measure the number of people covered and talk about how you're filling that cube? And I think it's operationally, our current lexicon is not well suited for that. And I think the whole issues around essential public health functions, as well as around the issues of, say, quality of health services, they haven't been part of the global dialogue on UHC, and they certainly haven't been part of WHO's dialogue until just recently. If we've talked about with our introductory comments there, the questions of talking about the H and health versus healthcare, public health, generally speaking, we talk about it as what we as a society are doing collectively to assure the conditions in which people can be healthy, and the public health functions being the spectrum of competencies and actions required to reach this central objective of public health and improving the health of the population. I'll just spend a moment talking about two recent sort of developments on these, because many of these topics we're coming back to. It's not the first time we're coming to them. We just are dealing with them in a different way. And I think we're coming at them, one, there's been some activity at WHO around this recently, precisely in support of the UHC 2030 movement, with discussions at a recent resolution that happened at the World Health Assembly. But also we're talking about it because we are now looking at a world very focused on global health security for reasons talked about yesterday quite a bit in detail, and also wonderfully illustrated by our colleagues from Liberia. that the questions of where public health sits and the public health functions in terms of an operational approach for how you improve them vis-a-vis the global health security agenda and health security, as well as related to UHC. These are three sort of circles of activity that are not the same agenda. And I think often we talk about them as if they're magically health system strengthening and health security will come together, essential public health functions are in there, but we need to now have better conceptual clarity on it. So I've just taken the liberty of putting one slide up to remind us what the essential public health functions generally are. And I have to say, unfortunately, at least within WHO, there's not 100% agreement on exactly the number of public health functions. If you look at the Pan-American region versus the European region versus the Western Pacific region, they do actually have a different number of public health functions. But generally speaking, these are the areas that, these sort of 10 areas are the ones that are included, ranging from immunization, the monitoring of morbidity, mortality, through the on community involvement, food quality and safety, safe water, health information, and evaluating the effectiveness of health programs and services. And I think one of the efforts that we have had recently has been to take those regional perspectives, gather the regional teams, and come together in Copenhagen in a recent meeting to look at harmonizing these efforts and to come up with, for WHO, a corporate list, a guide on what agreement on the essential public health functions, and also looking at these issues, the crosswalk between the current interest in health security and the linkage and how it fits within this global view of universal health coverage, and particularly our operational approach on UHC 2030. The other piece that I'll mention is this recent effort championed first by Finland, but a number of countries, looking at trying to situate this within the governing bodies of WHO with a resolution that just was put forward. The resolution itself called on enhanced international cooperation around essential public health functions, but really situating it within 2 or 3 frameworks. One around the achievement of universal health coverage, the second element being emphasized around a fit-for-purpose and responsive public health workforce, really linking it back to the recent Health Workforce 2030 strategy that WHO approved, and an effort to link specifically with the global strategies and action plans on NCDs and other disease programs as part of an integrated approach to health services management, which links back to the framework on integrated health services, which was also just put forward. So this framing, I think, provides an excellent opportunity for discussion, but it's a word of caution to say that, you know, we have at WHO strongly stated that the worldview on UHC is not one that is focused on personal health care. It's focused on personal and public health together. But, for instance, when the resolution came forward, because there was a concern by certain member states that this hasn't been part of our dialogue, even if maybe conceptually we all acknowledge it's there was no department who was immediately asked to take this forward. And partially I think that's the issue with essential public health functions. It's seen as part of everybody's work, which means that it's a little bit nobody's work. So I think there does need to be a much stronger examination of how we organize ourselves to ensure the implementation of essential public health at the country level within this strategy that we've been talking about, within the FIT strategy. Where does that fit? What are the foundational elements that need to be put? What are the institution building elements that need to be there? What are the transformative elements that need to be there? Do we need Public Health Institute mentoring programs, other operational elements? And I think that will really be where we try to make a difference at the country level. And I'll close with the idea that we will take forward next week. A number of us will be at the big health security meeting, global health security meeting in Indonesia. Indonesia is the current chair of the global health security agenda. There's been a lot of talk of the joint external evaluation tool that's out there that's being advanced in terms of assessing countries' readiness/preparedness. If you look at the 19 areas that are in that tool, we work very closely with the health security folks on this 12 of them are solidly within, at least 12 of them are solidly within the health systems and public health functions. There's work on food safety, on immunization, national legislation, monitoring, et cetera. So how we move away from tens and hundreds of assessments in countries to actually using this data and being able to use the data they gather for strengthening public health, the data we gather on health systems to strengthen health security, I think will also be an operational issue that we'll need to take forward. Thanks very much.
Thank you very much, Ed, to not only introduce the broader dimensions of UHC and what the Cube needs to be accountable for, but also giving this excellent framework that sets the stage for the rest of the session. I now invite Dr. Mirai Chatterjee for her on-the-ground experience in this, and particularly on community involvement in health from the Indian context. Thank you, Dr. Chatterjee.
Thank you very much, Somil. As Somil said, mine will be a complimentary view, I think, to you, Ed. We hadn't exchanged slides, but you'll see there's quite a lot of congruence. I'll be speaking on essential public health from the point of view of the grassroots of informal women workers with whom I've been working for some time. So if you ask them sitting around under a banyan tree or a jackfruit tree, what are essential public health? What does it mean for you? What are your needs and your wants? I think they're very clear. They know exactly what they want, even if at our level we're not so clear. The first thing is primary health care, free and at their very doorsteps, and as comprehensive as possible. I'm not going to unpack what we mean by primary health care. Everybody here knows, only to highlight one or two things that usually are just not included, including early detection and screening for mental health and occupational health. Most of the world's people are workers, working poor, and in India, just to remind you, 93% of our workforce are in the informal economy. Health education and information, which is also very much on your list, Ed, is also part of what they need, and they voice again and again. They simply don't know how to remain healthy, stay healthy, and they would like to know. They want to know. They demand to know. And also essential drugs, of course. And then a life cycle approach to comprehensive primary health care. The second is secondary and tertiary care or referral services, linkages with providers, and connected to that, some levels of financial protection. As you all well know, about 60 million Indians every year go into poverty and indebtedness because of health expenditure. The third, again very much congruent with what Ed has said and Stefan has said, action on the social determinants of health. Water and sanitation, of course, a tap and toilet at least in every home. Early childhood care so that our children get a good start in life. Access to food, and yesterday Pallavi mentioned the Food Security Act, which is perhaps first of its kind, I think, anywhere. A National Food Security Act where by law, it's a justiciable right, by law food has to be guaranteed by the government to Indians, particularly those living in poverty, social protection, and some measure of livelihood security. So all of these minimum, quite a big list, but minimum action on the social determinants of health. The fourth and very important, which we have been speaking of since yesterday, is voice and representation on matters to do with their own health. Local people involved not only in governance on health, like being on local health committees, like we heard the Cambodian example, but also actually having a voice, if you will, a place on the policy table to actually determine what are their health priorities and needs, and so that they are empowered and enabled to take action. Because just to remind ourselves, public health is also all about us, about people being in the center, and as we said yesterday, particularly the most excluded. So how are some of these essential public health functions being addressed in India? We also heard from our colleague Lima from the Ministry of Health yesterday briefly, but I think health system strengthening is underway. Much has been done, particularly in the last 10 years, but as usual, much remains to be done. In our federal system, there are some states who have made many innovations and done much strengthening and are well on the way. and others, of course, lagging way behind. Much more needs to be done, I think, on financial protection in particular, and on the issue of essential drugs. Community action, we heard again from Lima that our government has an advisory committee at national level on community action, where civil society is sitting with government as partners and suggesting ways in which communities can be enabled, empowered, to help monitor the strengthening and the changes, and hopefully also the long and slow march towards universal health care, or what in India has been now rechristened universal health assurance. I think it's important that the government of India, the last government and the present government, acknowledge the importance of UHC or UHA and are moving in that direction, albeit slowly, through the national health policy. I think there's some areas that need more work in the essential public health functions, and I'd just like to highlight them. No surprises. The first is community action in a country of 1.2 billion, which is as large and diverse, often considered many little countries. Building capacities of local people, particularly women, our indigenous, and others who are traditionally excluded, is very important. Another very important area where I'm afraid we've not made much headway is regulations. We have the largest private healthcare industry in the world, I think, along with the US, and basic public health standards, private healthcare standards. And of course, we need to do much, much more on the social determinants of health, as Stefan has reminded us already. I was also asked to speak about how UHC 2030 could help to move the national agenda forward, and I have 5 quick points. One is, very importantly, we would like to partner with all of you to put UHC back on the front burner. I think my Indian colleagues will agree that UHC which had made good progress, and under the chairpersonship of Dr. Reddy, we had a landmark committee as well, but that unfortunately is now on the back burner. So I think our policymakers and politicians have to be held to account. The promises that they made have to come into force, have to be implemented. The second thing is, I think, if you could help us unpack UHC. What does it mean to that informal woman worker who's a landless agricultural laborer in a remote village in India or any one of our other countries, or selling vegetables and fish on the streets of Ahmedabad, my home city? What does UHC mean to them, so that it's understandable to all, and so that also we can build a movement from below to demand and push for UHC. Third, underscoring the importance of primary health care. As we develop financial protection systems, there's a very real concern that these grab and swallow up all the resources, and primary health care will be pushed aside. Perhaps you can show us what other countries have done, so it's not either or, it's taking both into consideration and building both and linking them. Fourth, underscoring the importance of social determinants of health for UHC. The WHO had the Commission on the Social Determinants of Health. We have a report, we have the evidence, we have workable examples from all over the world. So why not use them? Why not take that report out and refer back to it? And last and not least, something that many in this room, including myself, have been re-emphasizing again and again, is the importance of building voice and representation. So how can UHC, how can all of us here build partnerships so that people at the grassroots have greater voice? And I'm not just talking about civil society, that of course, but I mean membership-based democratic organizations of the poor, of women, of the excluded, so that they have voice and representation in what constitutes UHC, what should be the directions, how can they be enabled and empowered to make the changes in their lives that all of us would like to see for everybody. Thank you.
Thank you, Dr. Chatterjee. That's a whole package of suggestions to IHP Plus and for bringing the grassroots experience. We now move to the second theme of our panel, and this is the theme of health security, the theme that features prominently in the framework on your screen, the theme that was prominent in the G7 agenda, as we heard yesterday, and a theme that will have a whole meeting as big as this one next week. I invite Dr. Satoshi to start with the framework and discussion around the theme.
Okay, so
First of all, thank you for choosing to wake up for this early morning session after such a fun party last night. Well, I'm tasked to talk about from the global perspective in terms of UHC and health security, what are the linkages and the relevance of those two. And so from the, if you go to the next slide, please. Or should I control something? Or, I guess I should just go. Okay, so this is a famous chart that I guess you're, by now you're tired of hearing about from the G7 health outcomes. But we all heard yesterday about great things, including the very creation of this UHC 2030 under the Pillar 2, which is promoting UHC. But I just want to quickly go over what was discussed under the bracket of the first pillar, which is health security. So the leaders of the G7 under the health security bracket talked about mainly 4 points. One is the WHO reform, and which was agreed upon in the last World Health Assembly. The process is still going on, but this was one point that was discussed there. And the second one is to finance those response to health emergencies. One is contingency fund for emergency that's already there for WHO's initial response. The other one is newly created World Bank's pandemic emergency financing facility, or PEF. This is an innovative insurance scheme for pandemic. And the third one is to formalize the coordination arrangement of large-scale public health emergencies. So in the case of Ebola or other big, outbreaks or events that WHO alone cannot handle, then we need to come up with some sort of standard standard operating procedure for those relevant partners, including humanitarian partners or UN funds and programs. So that's another thing that was agreed, and it's ongoing in New York and DC. And the fourth one, which is the most relevant point under the bracket of health security to UHC, was this piece in terms of the prevention and preparedness against emergencies. So I want to highlight that part. So the leaders agreed the importance of prevention and detection and response to public health emergencies. And to do that, we want to, at the country level, we want to strengthen the core capacity of WHO's international health regulations through such mechanisms as the Global Health Security Agenda. And we agreed that we will support 76 countries on that using the JEE tool. And then they also agreed that the partnership is obviously important, and we need to utilize existing mechanism as well as the new emerging mechanisms such as Alliance for Global Health Security. And in addition to that, we dealt with the sort of a difficult question of how to finance those preparedness. And one way would be to utilize IDA, International Development Association, by the World Bank, and this is sort of an ongoing debate, how to finance not only the response but also the preparedness. So just to say, a lot has been discussed and agreed or ongoing in terms of the health security. So this second bracket of UHC, we all agree, and we are congratulating on the great stuff discussed under this bracket of UHC promotion by the G7 leaders. But we also want to be remindful of the many things are going on under the health security bracket. So I think in the interest of time, I will just go on to my version of the conclusion in terms of the relationship between health security and UHC. So is this a new dichotomy, like a vertical and horizontal debate, like UHC versus health security? And my answer, and I'm sure you all agree that it shouldn't be like this. So it should be like inseparable couple, or indispensable, components or whatever you call. So UHC is essential for health security, and vice versa. Health security is essential for UHC. So we don't want this to be a new dichotomy, and that's already happening, as we heard from Ed, at least at the WHO. It's not like A or B, but it's A and B. So, and we want to seize the opportunity to leverage political financial attention to security to advance UHC as well. So we want to, of course, keep the momentum for the UHC itself, of course, but we also have to face the fact or human nature that people tend to react to the immediate threat. And then oftentimes, UHC or these long-term goals are like our Indian colleague said, that put on the back burner. So we don't have to sort of shy away from this health security agenda, but on the contrary, we have to leverage that political or financial momentum to advance UHC. Of course, this is easier said than done, but just to point out. And the third point I want to make is the prevention and preparedness is the key entry point or the key linkages between UHC and health security. So the big question for all of us is how UHC 2030 can sort of promote or leverage that the core linkage, which is prevention and preparedness. So that's my sort of a broad general comment. So I want to move on to our colleague from Sierra Leone for the reality check, if this is just a if this is just a broad idea, conceptual, or this is actually the case on the ground in Sierra Leone. Thanks.
Thanks, Atoshi, for capturing this very important and broad topic in such a short time, and to bring forward the sobering reality of public health emergencies and how that fits within the UHC space. And as you already mentioned, it's over to Hosinatu to give us the on-the-ground perspective on this theme from Sierra Leone. Thank you.
Thank you and good morning. Just to reinforce from the presentation of Tsushi that health, security, and universal health coverage are inseparable. And we are all aware that health security is embedded in universal health coverage. And basically, health security can be looked at as an intrinsic value of protection against risk. And we're all aware that individuals are better off when they are secure in the knowledge that if something should happen, that if they get sick or whatever, they'll be able to obtain quality health services without becoming impoverished as a result of that. And so I would want to say the resilience of a health system refers to its ability to absorb disturbance, to adapt and respond to the provision of needed services. But sadly, though Sierra Leone lacked the basic foundation when we had the Ebola outbreak, we also lacked the institutions and the transformation for us to be able to combat the infection. And I can say here that we had the Ebola outbreak, unquote, with our pants down. That is, we were not prepared and ready for emergencies. And so the country, therefore, needs to make extra effort, not only to restore how the system would function, but also to transform and fundamentally improve on the health system as a whole. And for that, we had a national agenda, and as mentioned yesterday by our sister country, Liberia, we have the political will. His Excellency the President in 2015 declared a post-recovery Ebola project, 6 to 9 months project, and we had to look at 5 MDAs, that's health, education, social services, private, public partnerships. And in health, we looked at 2 thematic areas, and one was towards a resilient zero, and also to restore and transform our services. And quite recently also, the President on Monday, the 20th of June, launched the 10 to 24 months plan, recovery plan, as a continuation of the 6 to 9 months plan. And for health, we are looking at making sure that we maintain a zero resilience to Ebola. And in that, of course, we're going to make sure we have structures put in place to make sure we are prepared for any emergencies. And most importantly also, we all know that we have unacceptably high infant and maternal mortalities. So this is the drive of His Excellency the President to make sure that we reduce 500 of those maternal deaths and also reduce 5,000 of infant deaths. In addition to that also, the ministry has gone through a lot of reforms and has reviewed its health sector strategic plan and also the basic essential health services so that it can reflect on the emerging issues. And 5 thematic areas were developed, and one is that of patient and health worker safety. And of course, embedded in that, we have IPC, infection prevention and control. We never had structures for infection prevention and control, and of course, for occupational health. And another was to make sure that we have a resilient health workforce that can stand the test of time. We're looking forward to investing in education, recruitment, and retention of fit for purpose and a responsive and motivated health workforce. We cannot talk of strong health systems if we do not put emphasis on human resource for health. And of course, there are issues on making sure we restore health services, because at that time, the community members were not confident enough to visit the health facilities thinking they're going to contract the infection from the health facilities. And so we had to restore their confidence. In addition, also, we had a thematic area on community ownership and community participation, because we saw there was a gap between the health facilities and the community. And for that, we have established a community health workforce in all the chiefdoms. And as we speak, a policy is being developed so that we can be able to respond to health emergencies even at chiefdom level. And lastly, the information and surveillance. We had challenges on data and information and surveillance. So there's a pillar that's going to be looking at data and surveillance. And for us to be able at least to get ourselves prepared for any emergencies, the Health Ministry has developed and established an emergency operations center, and we have personnel who have been trained to respond to any emergencies, because we know there is Zika, there is also yellow fever. And we've also developed harmonized financial management for health sector integrated projects, IPOW, to manage the resources and funds that are being used either by IPs or for the Ministry of Health and Sanitation. And there's also a joint fiduciary agreement, and it's being implemented to make sure that we follow procedures in terms of spending. And lastly, let me say that we are looking forward to having collaboration, coordination, and communication to all donors and all partners, because we want to have the ownership of making sure that our agenda is being followed by health partners or health donors. And we are encouraging all donors to make sure they follow our agenda and help us restore our health systems. Thank you for your attention.
Thanks, Osenatu, for sharing these detailed plans to strengthen the health systems in Sierra Leone. We now move to our next thematic area of non-communicable diseases. We saw how the essential public health functions contribute to prevention of NCDs and hopefully to be able to better manage our limited resources to address what is constituting the largest disease burden. And to set the stage and the discussion for NCDs, I would invite Katie from the NCD Alliance.
Thank you, and good morning, everyone. So we all know in this room that non-communicable diseases are a major challenge to both health and sustainable development. We know that NCDs are a major cause of morbidity and mortality around the world. They push households into poverty, and they're also a major driver of economic impact as well, with $47 trillion being the cost of NCDs over the next 2 decades. But I don't want to spend time this morning really drilling you with statistics and data, because I think you're all fully aware of the NCD burden. And equally, I don't want to spend my time saying that NCDs are the #1 issue within universal health coverage, because that's completely against the spirit of UHC. Instead, what I want to do is really focus on some of the unique characteristics of NCDs and the challenges that they pose and how that impacts upon how we're thinking about universal health coverage, and also obviously the establishment of UHC 2030. Now, firstly, NCDs are obviously inherently multi-sectoral. Whilst they end up, diabetes, cancer, cardiovascular disease, chronic respiratory disease ends up in the health system and are really straining health systems around the world, their origins lie well outside of the health system. So the 4 major risk factors, tobacco, alcohol, physical activity and nutrition, are obviously being driven by sectors well beyond health. And so therefore we need to be thinking about the agriculture sector, the trade sector, how we're actually designing our cities in order to improve health outcomes and prevent NCDs. So firstly, NCDs are inherently multi-sectoral, which really poses a challenge and questions around the role of universal health coverage for NCDs. Secondly, we know that NCDs can be delayed and prevented. So 90% of mortality of NCDs in low and middle income countries happens before the age of 70, i.e. they are premature and can be delayed or avoided. So when we're talking about NCDs within universal health coverage, prevention and health promotion is absolutely essential. The health system and management side is important, but prevention and health promotion is key here. And we know from analysis that has been done around the impact of the risk factors towards the 25 by 25 mortality target. If we focus on the 6 risk factors for NCDs, we can see that we're going to get close to the 25 by 25 NCD mortality target. So prevention and health promotion are absolutely essential. And when we're thinking about promotion and health promotion and prevention, we're obviously talking about things like taxation, regulation, legislation. And within that, we're obviously seeing opportunities for health financing for universal health coverage. Last year in Addis, obviously taxation was a key pillar of the Addis Ababa Action Agenda. And so tobacco taxation and alcohol taxation, which are key parts of NCD prevention, are actual drivers for resources for universal health coverage, so an opportunity there. Thirdly, a challenge within, looking beyond the kind of immediate risk factors for NCDs is that you can't really talk about NCDs without looking at the social determinants of health, but also the commercial determinants of health. Obviously focusing on the way that people are living, education, poverty, driving the potential risks for NCDs, but also people have gone as far as to say that NCDs are essentially industrial epidemics. And so multinationals are really driving the promotion, the production, the distribution, the promotion of unhealthy commodities around the world. And so how can universal health coverage and UHC 2030 be interacting with those social determinants of health as well as the commercial determinants of health? And then fourthly and finally, I think the challenge of NCDs really poses a question around the need for focusing on policy coherence. Obviously, what the Health Ministry is doing is absolutely essential, driving effective health systems and health promotion. But also we need to be looking at what the Ministry of Agriculture is doing, what our Ministry of Trade is doing, what our Ministry of Education is doing, and making sure that these other sectors within the government are promoting health rather than deterring health. And we can see many different examples of where that isn't happening within governments, and it's very easy to say policy coherence to governments. Actually, in practice, it's obviously extremely difficult. But again, it poses a question for UHC 2030 of how can this new partnership be promoting policy coherence, which very much ties into the whole nature and principle behind the Sustainable Development Goals of being integrated and indivisible, requiring new approaches to how we're doing health and sustainable development. So what does this all mean for UHC 2030? From my perspective, I think from an NCD perspective in general, we've always said UHC is absolutely essential, but it's not enough. And so how can UHC 2030 be interacting and looking beyond the health sector for the solutions and the answers? And I think that also links to how we're engaging with different stakeholders and different partnerships out there, working in these different areas of sustainable development. Thank you.
Thank you very much, Katie. And I now invite Mr. Somoni Sin to bring the on-the-ground perspective from Cambodia.
Thank you very much. I think my colleagues and many previous speakers have made you good enthusiasm already, so I see what can I complement to the previous discussion. However, I think Cambodia strategic plan has strategic plan 2008, 2015, and 2016 now to 2020 highlighted 4 key areas: reproductive, maternal, newborn, and child health, the communicable disease, the non-communicable disease, and health system strengthening. And I think that the last Health Strategic Plan 2016-20 has put UHC as the center for achieving these priorities. In the past decades, when the global and national effort has put tremendously to tackle the communicable disease in Cambodia, we see great achievement for Cambodia on the declining of HIV prevalence, TBs, and malarias. However, I think with regard to this declining, we also now see NCD is on the rise. I think, as my colleagues already mentioned, the other multi-sectoral factors that impacts on the increase of the NCD. I could see that, you know, although we all in this room agree that health service delivery, accessibilities and quality of that has a significant impact on health, but the other social determinants of health also has a major impacts on health and well-being of the people. I think what I could see in Cambodia, a great effort has been put very much on improving quality and accessibility of health service delivery within the health system. However, I think if we now agree that health is beyond the health system, then there is not sufficient effort yet have been made in terms of the promotion of multi-sectoral response, in particular to tackle with the NCD. So you see Ministry of Education, Ministry of Agriculture, the Tax Department, Ministry of Women Affairs, all these could have been playing a very key role. However, you know that teachers in Ministry of Education were trained about the diseases, were trained about public health. I think in the Ministry of Health, there are a good pool of public health experts and doctors. And I think if there would be proactive engagement or stewardship roles from the Ministry of Health to really engaging other sectors, using those sectors as an external strength to participate into the response to NCD, I think that would be a great achievement in terms of attaining health and well-being of the people. So now I think the world, as well as Cambodia, has a great opportunity in terms of the context of SDG, as well as the today rhetoric on the UHC 2020-30. So my question to the floor, I do not have the answer to, but I still join you on this discussion, is that how can, within that context of SDG and UHC 2030, could really help Cambodia, especially working with the Ministry of Health in engaging or stewardship roles beyond the health sector to really include and promote multi-sectoral response, especially in responding to NCD. Thank you very much.
Thank you very much, Dr. Simoni. I would like to thank Satoshi, and I know you have to leave at 9:30, so just thank you for being here and for the session. Our last theme and the last speaker is Dr. Kaiser Afsana, who will now be talking about the whole linkages between the environmental health issues and the UHC agenda. Dr. Kaiser, over to you.
Thank you very much. And I would also like to thank the organizers for inviting me. And this is an issue, I would like to speak from global perspective and also from the country perspective. And we know that especially the environmental issues is not situated at the country level. It's a global issue. So I think we should also take the responsibility that how we can work in these particular sectors. But as we know that the data is showing that the global deaths is about 22% 23% is due to environmental causes. And among those deaths, in fact, the children, 26% of the children are also dying due to environmental factors, which are, in fact, preventable. So as we can see that, many of the things, if you can translate to my own country in Bangladesh, then you can see that how the children are dying nowadays. The children's death, under 5 children, still are dying, mostly due to respiratory tract infections, diarrheal diseases, drowning, injuries. So what are the factors, in fact, causing all those things? We know about that. If you connect this to all those multi-sectoral factors, then you can see that indoor pollution, outdoor pollution, and then environmental enteropathy that causing diarrheal diseases, water sanitation hygiene, and of course the climate change issues. So Bangladesh is also a country, you can see that it's a country of more than 160 million population. It's the highest density population in the world. 1,000 people, in fact, living per square kilometer. And then 7,000 people, in fact, in urban areas living per square kilometer. In slums, 200,000 people are living per square kilometer. So look at the density. If you know that's the country situation, so you can see that how quickly the pollution could happen, even because of the people's presence, and then, of course, the other factors are there. And then if you go to the issues, there are so many issues in environment. I will touch few. I don't want to go too lot because my previous colleagues already touched some of the issues. But then if you look at the other sectors, as we are been talking about multi-sectoral, and it's easy to say the multi-sectoral, but in terms of working together, it's really difficult. And as I've been very much involved with the scaling up nutrition movement. So one of the things, in fact, we are working is multi-sectoral approach. And that's a real tough issues, not only at the global level, but even at the country level, to bringing all the ministries working together. So when we look at the road accidents, so how many people are dying in Bangladesh due to road accidents? It's more than 2,000 people dying every year. And I can say that this report is from the government, and I guess that it should be more than 2,000 people dying from road accidents, which in fact is not also accepted. And it's not only deaths, it's also disability. We don't even know how many people are suffering from the occupational hazards that's happening, especially in the manufacturing sectors. So it's the garments, ready-made garments factory, you know the story of Rana Plaza that happened 3 years back. And that has given us a huge shock in the country, that how people, especially the garments factory workers, are being treated. Even, you know, the day before, when the alert was gone to this building that people should move, the garments factory owner didn't allow to move their garments worker the day after. So the building collapsed. So there are thousands of people died, and thousands of people, they have lost their limbs and they are still suffering. So there are many issues there. So informal sectors is not only the garments factory, there are many other sectors, in fact, we are completely ignoring. We don't even have any data that how many people are suffering from all those occupational hazards. And even in people like us who are sitting in the offices, think about us, our stress factors, even the way we are sitting, even the whole day we spent yesterday. Don't you think that that's also a stress? We don't think about it. We talk about many issues, but we don't think when it comes to our own life. So it's really think about that. In the morning you spoke about yoga session, stretching out. I think this is very critical. Even when you relax, the meetings are not always relaxing. So you need to also think about that. How can you make the environment which is less stressful and not affecting your health? Because we are the public health professional who are talking about universal health coverage. We are, in fact, advocate globally and advocate in the country level. So I guess that it's very important. So there are many challenges there, but I would like to say a few recommendations that how we should work. That multi-sectoral approach, I know that this is a very critical thing, and we need to work all together, but it's not going to happen, what I can see in near future, even those SDGs are flagging out all those issues. But I always feel that integration in approach, you don't need to always work multi-sectoral. It's difficult. But even if we, from the Ministry of Labor, Ministry of Agriculture, Ministry of Health and Welfare, if you work and following our standards of care, standard operating procedure, then I think we don't need to think about all the things. We need to work in integration in approach, whether the families, whether the children, whether the women, they are getting the support from which they actually need. This is very important. But we need political commitment. We need leader in the country. So leadership is very important at the global level, and leadership is also critical at the country level. Who will be steering all those coordinated effort? So I think that I am getting signal to stop. I'll stop here now, but I have few more things to add later.
Thank you, Professor Afsana. I'm sure there'll be a chance to add further as we open it up to the audience. Also for the note that I would request the rapporteur to note that the next IHP consultation should be healthier and possibly have yoga breaks. On that note, I'll open it up. We have about 15 minutes for discussion. So I'd invite, maybe starting with you. And I see two hands there and one hand here. 3 minutes.
My name is Jan-Willem Schijgrond. I'm from Philips, private sector. I heard that you didn't have a lot of private sector in the last few days, so let me give you a slight overdose. I'm sure you'll recover. I think what we should ask ourselves in the universal health coverage is not what is broken, but how can we imagine the best system which we can, which our people deserve? What is it that I haven't heard anybody express that. What's the best healthcare we can provide? And I see a lot of contradictions in what the panelists are talking about and what we really want. So I think, Ms. Chatterjee, you started out with that people really know what they want. But we find that people really don't know what they want. They know the minimum, what they should expect, but they don't know what the maximum is they can expect. And when we show them what the maximum is and beyond, they actually want that too. Mr. Stefan Pedersen, you started out the discussion about health or health care. I'd like to call it the death agenda or the life agenda. And while we're talking about health, really what we're measuring is how many people die. And so our healthcare agenda, our universal health coverage, is really about dead people and sick people. And that doesn't really inspire the economy, it doesn't really inspire the Ministry of Finance, it doesn't really inspire the private sector, to be honest. And so I think we should be turning it around towards, okay, the health agenda or the life agenda. And as we know in the SDGs, it's not about survival, it's about transformation, it's about reaching your highest potential. It is about that maximum, but we don't measure that, we measure that. And then we talk about being multi-sectoral, but a proper functioning healthcare sector is multi-sectoral by its design. If you walk into a hospital, you expect there to be a good IT data system which actually provides the feedback, which links the security agenda to the healthcare agenda. You'd expect as a citizen that you can actually Skype your doctor through the IT system. You expect that you can wash your hands, that there's clean water. You expect there to be electricity. You expect there to be safety, a safe road leading up to the hospital and leading home when you come there with your wife to delivery in the middle of the night. What do we see? Africa alone has about 100,000 primary care facilities. The lady from Sierra Leone expressed this. 80% of those facilities don't have water, no electricity, no proper management, not even a bank account, no IT, no connectivity, no light. So are we really talking about the best quality care? How do we do that? Now, clearly, if you fix a system and you're trying to fix primary care, it means that you need to plan holistically. Now, have the donors, have the governments, have the organizations been doing this holistically? Have they really been planning around the citizens, or have they been planning around interventions? And I think they've been doing the latter. They've been vertically driven by the MDGs, of course, but not holistically driven. So if we're looking at healthcare systems itself being multi-sectoral, we are also seeing that if you're improving primary care and you bring water, you bring electricity to the communities, to the healthcare facilities, they actually are able to share that water and that electricity and that safety with the communities they support. And if you bring in somebody that trusts the care which you provide, then you can start talking about education, then you can talk about family planning and spacing, then you can start talking about food rituals. Now, finally, to my point, in the mature markets, we are working towards the industrialization of healthcare. Healthcare is the most old-fashioned industry, next to prostitution. And it needs a digital revamp. It needs a technological transformation. We're also talking about the personalization, making health personal. So if we do that, and we analyze what's wrong and how we can fix it, are you open to actually inviting the private sector to be part of that journey? Private sector has been very good. We are a multinational, which actually, as opposed to the private sector being referenced by the NCD Alliance, we don't promote death, but we promote life. We have set ourselves the targets to improve the lives of 3 billion people a year in 2025. But private sector is very good for its innovation. It's very good for its scale. And the reason why we achieve scale is because we can do this at an affordable cost. Because people are prepared to pay for it. That's how we afford scale. Now, if we bring that innovation, the ability to scale, and to make it affordable into the universal health coverage agenda, what role would you give us?
Thank you. Thank you very much. We have 3 more comments, and then we'll come back to the panel. 2 from this table and 1 here. Yes, please.
Hello. Can you hear me? Yeah, okay. My name is Rosina Mistry, and I come from Pakistan. And I organized the civil society platform there. But subsequently, I entered into a new role where I'm actually helping the government as the advisor on various programs, trying to bring in civil society and the government functionaries together. I would like to today share with you the examples. All of you what you were saying touched my heart immediately, because this is what we are doing in the area of nutrition and health in Pakistan. I've developed intersectoral nutrition strategy for 2 provinces and 1 state in Pakistan. Very recently, I finished with AJK, Azad Jammu and Kashmir. But before that, Gilgit-Baltistan and Sindh. And what was it? It was to work with different government departments, helping them to see that agriculture is not just agriculture. Agriculture is health. And their point was, oh no, if people are malnourished, this is because health is not doing its work. When I spoke to wash sector, they said, excuse me, we are already planting in all these tube wells. How can you say that this is a problem for Pakistan? Etc., etc. Today we have reached a stage where different departments are sitting together on one platform. But how did that happen? That happened because the chief secretary has got all these departments together in the oversight coordination platform. The Planning and Development Department said, we will not approve any proposal from any department, be it agriculture, be it WASH, if it doesn't pass through the health and nutrition lens, if the implication of health and nutrition are not clearly outlined in there. And then the planning, geographical coherence, and timings were all decided together. But what is very interesting is that now we are starting on the implementation of that in Sindh, and with that there is one very powerful example that I would like to share. We are now trying to reach out to people out there in the hardest to reach community. We are now getting one of the community members as the activist out there who will be our eyes and ears. Through social media and through these different technologies, we are directly in contact with them to ask them if the vaccinator had come, if the educational session was there, whether they wash, I mean, these were the plans, how many tube wells have been instituted, how many lectures have been done. So all I'm saying is that if UHC is seen as a cross-cutting agenda of every sector, then yes, this is very much possible. It took us, instead of 1 year of what was planned, it took us 4 years. It took a lot of patience from our side because people were just not willing to look at it from health side. They were just so insecure that they just department wanted to look at it from their own sector side. But in the end, today, they are talking to each other and they are seeing the effect of it. So now the agriculture extension worker is also teaching about nutrition, is also talking about health hygiene. Similarly, WASH sector is also going into school and recognizing that if in a school you do not have latrines, that if you do not have water, then the girls will drop out after grade 5 because they cannot go to a school where there is no water, where there is no sanitation. So I think that this is such a timely agenda. Intersectoral interventions are possible. It will require a lot of time, but it requires a lot of patience, it requires a lot of commitment, and on the top of it, it requires government's commitment to actually look at it and fund it and develop mechanism to actually ensure that it happens. Thank you.
Thank you, Dr. Mistry. Dr. Yadin? One there and then here, yes.
Thank you. I just wanted to share a little bit about India, probably because not much is known about what we are doing. In fact, so much is being done in the country. UHC is still our goal, and towards UHC, and it is such a happy coincidence, I think the year the UN Assembly passed the UHC resolution, we embarked on our most ambitious flagship program of the National Rural Health Mission. In the 10 years, we have been able to do a lot of measures towards strengthening our health system. As you know, in India, we have a quasi-federal system, so the health is a subject of the states. So from the center, we have been supporting the states, incentivizing them, nudging them to sort of move towards undertaking wide health sector reforms. And then over the last 10 years, we have been able to provide a host of, support the states to provide a host of services, healthcare services, free of cost. In the last 2-3 years, we have been moving towards comprehensive primary care. Yes, after the Alma-Ata Declaration, a lot of countries approached it differently. Those who had resources went for comprehensive primary care, while countries like India and some opted for select primary care because of resources constraint. But now, increasingly, now we are moving towards comprehensive primary care. So, and then we are also restructuring the institutions in place so that we are able to provide healthcare in a continuum by having effective referral systems, strengthening the secondary and the tertiary care system. And not only that, we are also not only incentivizing states, but we are also providing funds to the states to provide drugs free of cost, essential drugs, essential diagnostics, free referral transport. We also have mobile medical services to provide outreach to the hard-to-reach areas so that healthcare services are provided to those at the doorsteps of the people who need it. And we are also supporting states. 10% of the budget is given to the states to support innovation. So each state decides what they want to sort of adopt, and we support them, and we also support them to scale up if that works. And I think now the focus of comprehensive primary care is to move away from sick care to health care. And yesterday, even I was just telling a group of people here that we launched our first series, operational guidelines on screening for hypertension, diabetes, and common cancers as part of comprehensive primary care, which will be started at the community grassroots level. And besides that, we are also now supporting states to put in place an effective grievance redressal mechanism, and also developing, I think, IT systems and apps to have a patient feedback system, so that the states are able to deliver patient-centric care. And the most, I think, interesting part is we have also not only strengthened the health systems, but we are now today applying the health systems approach to the HR, so that we have optimal utilization of the scarce HR that we have. On the point of health security, I just wanted to say that health security presupposes a resilient healthcare system, which in turn calls for investment in health system strengthening. I think that is one observation, especially in the light of floods which happened in Tamil Nadu and Chennai, that proved that when you have a resilient health system, it helps you recover faster. Had the same thing happened in any other state of India, probably they may not have been such a good recovery in a short thing. So this is also, I think, this also makes a case for investment, increased investment in health system strengthening. And I also wanted to say
Dr. Adam, can you just, because your last 3 minutes in the session?
I also wanted to say our part towards UHC, we have adopted a mixed approach, which also, financial risk protection through public provisioning and health insurance. Thank you.
Thank you. Dr. Mohammed, very quick comments from your side.
Merci, Dr. Yansane de la Guinée. Je voudrais intervenir sur le chapitre sécurité sanitaire. J'ai été très impressionné par les 2 présentations qui ont été faites à ce niveau, et surtout de voir cette complémentarité entre la sécurité sanitaire et la CSU. Et notre objectif étant de garder vraiment l'unité de la santé, surtout au niveau des pays. Parce qu'avec la création de cette nouvelle unité au niveau de l'OMS ici à Genève, il faudrait éviter des velléités de création des agences de sécurité sanitaire dans les pays qui soient complètement déconnectés des réalités des ministères de la Santé. Les pays qui ont connu la crise Ebola, comme la Guinée, on a eu à créer des coordinations de lutte contre Ebola qui sont en train de se transformer en des agences de sécurité sanitaire. Et aujourd'hui, tout le financement de la santé est complètement déconnecté, parce que 80% des financements extérieurs que le pays reçoit est orienté vers la sécurité sanitaire. Comme cela, on ne pourra jamais réaliser la couverture sanitaire universelle. Donc, et les signaux que l'OMS nous envoie déjà à partir des pays nous inquiètent, parce que on va dire à l'OMS à Genève, on a créé une unité spéciale qui va faire la sécurité, qui a ses propres moyens, ses trucs, et il faut éviter que il n'y ait une certaine désagrégation des systèmes de santé à l'intérieur, et avoir des agences de sécurité sanitaire qui vont dépendre soit d'autres secteurs, qui vont être multisectoriels et qui vont échapper complètement au contrôle des différents ministères de la Santé. Donc, c'est là vraiment toute une réflexion à faire pour que tout le monde sache que la sécurité sanitaire est partie intégrante pour atteindre la couverture sanitaire universelle. Je vous remercie.
Thank you very much. I'd invite the panel for any quick reactions, particularly on the last point about not letting the health security agenda become another vertical. Maybe Ed, you want to respond?
Just very quickly, particularly since Toshi's not here, merci pour l'intervention de la Guinée. 2 quick points. I think, firstly, WHO has really engaged in this whole discussion around security and around health system strengthening. The graph that we've shown is that the work on health system strengthening and UHC lead to these 3 goals, one of which is resilient communities and health security. And I think how we operationalize that is right now being determined. So that's why, coming from this meeting, going to the discussions that will happen next week in Indonesia will be so important to take forward that message. But I think, part of the intervention, I mean, this comes back to the intervention yesterday by our colleague from Liberia about the investments coming outside of the regular budget. And this is entirely against the whole principle of the Sustainable Development Goals, and I think it's something we have to advocate for more strongly, that there needs to be stronger interventions, and we need to come up with operational approaches. For instance, in Liberia, the work on the establishment of a National Public Health Institute has been one that's been envisioned, as far as we've seen, and been able to assist on the side as strengthening health security work, but also as having an essential public health function and sitting within that. And I can say that, part of the error that we've had, which unfortunately, even in the very excellent concept that we have for this meeting, we still need to work more on, has been this supply side thinking around health services delivery. And it's very good that we had this mention about the community engagement piece on this, is that this error of linear thinking that we've had, that first we'll build it, and then we'll worry about the quality of the services later. We'll worry about whether it actually serves people's needs later. And it's been a big error that has broken down trust with communities to date. And as part of the reason why we have the troubles in some of the Ebola-affected countries when they were hit with the crisis. And just a quick point on this, on the private sector point, there's an excellent intervention, huge discussions, I'm sure you're aware of the engagement of non-state actors and the new framework that was adopted by WHO, so we could have a whole discussion on that, but I think it bears in the next day further discussions. There's obviously a role for innovation and manufacturers in this whole work. Our own group has worked. We're working on injection safety, where we're engaged with syringe manufacturers. We worked and got infection prevention work done because we worked with alcohol-based hand rub manufacturers. So I think already WHO does some of this work. We now theoretically have a way to work forward, but I think there's a role there in innovation in manufacturing, in provision of healthcare, lots of healthcare provided in the private sector, as well as in community engagement. So I think those, especially that last one, needs to be better explored.
Thank you. Thank you, Ed. Any other reactions from the panel? We're out of time, but...
Thank you. Following up on the remarks on private sector, certainly I think we need to go beyond measuring dead bodies in the way we measure the survive, thrive, and transform agenda. I think the point I was making was that healthcare is not enough to provide the thrive and transform, so we shouldn't fool ourselves that healthcare provision is the only thing that determines that. On the private sector role, we discussed yesterday that in many countries 50, 60, 70% of total health expenditure is out of pocket. So privates, and a lot of that in private sector, obviously. So I think much as the ambition is to pool a lot of those expenses for a better and more equitable health service provision, I think it will be inevitable that we also engage with private sector healthcare providers in actually making better value for money out of that total health expenditure. Certainly my many years living in East Africa have shown me that there's little trust in that pooled money will ever come back to the individual. So I think we need a two-pronged approach there. Thank you.
So if there are no other reactions from the panel, let me just make sure that we conclude on a very promising note. This panel actually represented the whole complexity of the upcoming agenda for UHC 2030, and yet the diversity of stakeholder representation in IHP, from development partners to government representatives to academia to civil society on this panel. So we really stretched ourselves across themes, across the groups that we represent, and we really have some very important takeaway messages. Investing in core public health functions, including health security and prevention of non-communicable diseases, are core to the success and sustainability of universal health coverage. It also stressed the importance of collaborating across sectors, and last but not the least, the importance of strong health systems, going beyond verticality in our approach, both as countries and as partners supporting countries. And I have a very promising note from Dr. Mistri's experience in Pakistan to end, that this is very much possible, but we will need time, commitment, and patience. Thank you very much for this very interesting session, and we can now take our yoga break. Thank you.
not going to lead us into a stretch?
Well, of course.
I'm very serious, yes.
So, everybody stand up.
Stand up.
And stretch. As much as you can. Down. Stretch again. Down. And for the final stretch. That's it. This is the palm tree asana. Thank you.
Thank you so much. And it's now time for your coffee break, so it'll take 20 minutes, and we'll be back here for the next session. Agnes? Yes. I'm just inviting you so I can... Agnes tells you this is moderate. I mean, do you have then they know. So you choose whether you want. I think it's always better if you're standing.
Then I just need a moment.
Or if you want a roving mic, you can have one of those too. It's this one. La modératrice vous dira comment s'installer. Juste vous installer. Okay. All right. Please come in and take a seat. You all had me fooled yesterday in thinking that this is a group that kept with time. I went to bed believing in all of you, that you were committed, and I will choose to believe until the end of the day. But we're running 9 minutes late. You still believe? You still believe? Okay. I will continue to believe. Yes?
Yes, Remco, Medicus Mundi International. I have a question on or remark a little bit about the process.
Right.
We're now on the second day. We ended yesterday with consultations a little bit about the directions and accountability and mandate, how to deal with the networks. It seems that in the second day we're entering in a lot into the technical content discussion. And there seems to be a feeling that it's very much sending rather than having a dialogue. So if we can open up and really also not only taking input on technical issues about how to move forward, how to take this momentum to think about innovative new ways to move the partnership forward and how we build this together. So just a request not to lose time too much on the more content detailed discussions.
Point taken, and I will share that back with all of the chairs that still have sessions to run for the rest of the day. And also to let you know that it is late in the day, but there is a session at the end of the day to sort of take back all of the things that we didn't get a chance necessarily to discuss, some of the input that we didn't get a chance to say. But I'm also going to implore or ask all the moderators today to give a bit more time in the discussion for more feedback on the process, on the mandate, and on things that you felt were not addressed yesterday. Is that okay? Yeah? Okay. Thank you all. And I will hand over directly to Agnes Souka, who doesn't need to be introduced anymore. We've seen her yesterday and this morning. So I won't take time and take on your space. So go ahead. It's all yours.
Thank you very much, and good morning to everybody, and welcome to this session, which will be a session to discuss health systems assessment and how do we measure the performance of those health systems. So for that session, we're going to have first a presentation about why and how we start thinking about this issue of health system assessment. And then we'll have a very distinguished panel that is actually quite rich, both in terms of the range of organizations present as well as the range of countries. So we, on the panel, we have three representatives of the three countries that were affected by the Ebola epidemic. We have Mrs. Osinatu Kanu from Sierra Leone, Mrs. Ya Zolia from Liberia, and Mr. Yansane from Guinea. And from the organization side, I have on my right Mr. George Saakashvili from the Global Fund on AIDS, TB, and Malaria. And on my left, Mr. Magnus Lindelow, who is the manager for East Africa at the World Bank. Mrs. Jody Charles from USAID, in charge of governance. Bob Fryatt, also from the Health System and Governance Project, funded by USAID. So we know that health system assessments are not new. Many countries assess regularly their health system performance. And what we see, in fact, is that many different partners have already developed different tools. So the question is, how, as we're talking about what could be the added value of UHC 2030, is there a role for UHC 2030 to be the place where we can together develop tools that will have the added value of being joint and allow comparability between countries and set up the rules of the game? So to no avail, I give the floor to Deepa from WHO, who is going to present a little bit about where we are today in terms of health system assessment.
Thanks a lot, Agnès. I'll be very brief. I really just want to give you a brief overview on the state of affairs, on the status at the moment of what we're doing and what various agencies have been doing on health systems assessment. But it'll be just a very brief overview, and then we would really like to give the floor to you and to the panel to discuss this a little bit. So next slide. Excuse me? Okay. Okay. So basically, I'm not going to dwell on this, but Agnès presented yesterday the FIT strategy, the three broad country categories of strengthening health systems foundations, institutions, and supporting the transformation of health systems. And I'm just putting this up there to say that regardless of the country categories, regardless of the kind of challenges countries face, we're going to need a health systems assessment. And I think most of us agree upon that at some place during the health policy and planning cycle, and at some point there is always a need for a comprehensive health systems assessment. That being said, we also know, this is a slide that we really like to use. It was done by a colleague of mine who is our resident DRC expert in the team. And a few years ago, he actually sat with his with colleagues in the Ministry of Health and in the WHO country office, and they actually mapped out the various agencies, donors, NGOs, parastatals, foundations, that all have some relationship or other with the Ministry of Health. And you can see at the time, this has improved actually, but at the time there were actually 13 program coordination committees in place. In addition to the external institutions and agencies that the Ministry of Health has to deal with, they also have to deal with their internal organizations and parastatal agencies, other ministries, other government organizations. And this is a lot of pushing and pulling. And of course, especially for the programs, there's usually some level of assessment being done at the beginning or the end, sometime in the middle. So there's multiple evaluations, assessments going on at any given point in time. And the Ministry of Health Department of Planning at the time had 15 staff. So this is really, we all agree, it's too much, it's overwhelming, and we need to think about improving that situation. Some frequent issues in practice that I'm sure many of you are familiar with is the fact that some of these assessments, or the assessments are done because they're very ad hoc and done for different objectives. They're not always that systematic. They don't always insert themselves into the planning cycle or the policy and planning cycle of the country, which means that they might be done for other purposes, such as a donor proposal, such as a research agenda of a foundation, etc. So the risk there is, of course, that it's then not going to be used for anything but that particular purpose and not really leveraged at country level for what for the value that it really has. And also, its comparability is quite difficult. We've got because the language is not the same. There's different methodologies, different approaches, different definitions of the same terms being used across the different methodologies. Another issue that we see especially when we're looking at the different assessments, as they're not always comprehensive. This is linked to the objectives of each of the assessment. They're not always participatory. Sometimes it's just really a donor-driven exercise, which of course reduces the utility level utility at country level. And all of these are linked with the issue of continuity as well and the lack of follow-up. Some of the tools that are in place, or methodologies or approaches, we at WHO, we have our health system situation analysis that's mainly used to support countries in their as a preparation of their national health plan development, or as part of their support that we give as part of to support their midterm reviews or their annual sector reviews. Another widely used tool is the health systems assessment approach, pioneered by USAID. The WHO at headquarters, we also have a health financing system review, and I hear in development is a primary healthcare assessment guide with the newly formed platform called the Primary Healthcare Performance Initiative, PHCPI, which is spearheaded by WHO, World Bank, and the Gates Foundation. Some regional tools of WHO. At Euro level, there are two tools that are widely used in that region: the Health Systems Performance Assessment and the Health Systems and Transition Series, which many of you might know because of their published books for each country, which is basically a health systems analytical profile. In the Africa region, we have the Africa Health Observatory, which basically is also a country profile. Some of the work that we do with our health systems situation analysis at headquarter levels, we link up very closely with the AHO so that the profiles are aligned or sometimes exactly the same. So here are some of these tools: the USAID tool, the CHPP, the health financing tool. Just want to say one quick word on general assessments and then something that we sometimes call deep dives. So general assessment, by that I refer to a comprehensive health systems assessment, which really looks at the health systems as a whole, the different building blocks, cross-cutting issues as well. But of course, we do see that there's a need for so-called deep dives, looking into human resources for health a little bit more in depth, or pharmaceuticals, or many other areas as well. And here, WHO has a number of methodologies in place. And so one of the things we'd like to explore in this panel and in our discussions with you as the audience is, what is the place of some of these more in-depth assessments vis-a-vis the general assessment, and how we can link them better and harmonize them better, in view of a proposition that we'd like to make, which could be a priority activity of the UHC 2030 Alliance, to develop a joint health systems assessment tool, potentially. And this sort of builds on the experience we have with the Joint Assessment of National Strategy, the JANS, which has been a foundational tool of the IHP Plus, and basically assesses national strategies and their quality. And so similarly, what we'd like to discuss with you, could we potentially do a joint health systems assessment tool as the backbone of this new UHC 2030, given that one of the key mandates of the UHC 2030 is bringing all stakeholders together with a joint approach, joint methodology, and joint vision. I would like to say as well that, bringing together all of the different approaches and methodologies, one option is this joint tool. Another option is really just ensuring better harmonization and alignment. So these are the two sides of this coin that we'd like to explore with you in this panel today. So if we would do a joint assessment tool, or even the harmonization work among the methodologies that exist in practice, that would mean potentially an interagency working group to develop the contents and recommend a process and review that process and monitor it regularly. The potential added value would be comparability and a level playing field among the different methodologies and tools. We could better leverage the complementarities that exist, and the added value of each and every tool could be brought together, hopefully avoiding duplications and contradictions, and have a better joint database or information base to analyze? So this is the question I'm throwing out at you, and which we would like to hear the panelists' thoughts on. Thank you.
Thank you very much, Deepa. I think a very clear value proposition here for UHC 2030 and a very clear deliverable that could be deliverable for 2016 or 2017. Bob, any response to that?
Yes, thank you very much. Thanks, Angus and Deepa. I'm Bob Fryatt from the Health Finance Governance Project in USAID. I was being asked to give a few reactions because we have started a collaboration, and I just wanted to give a little update on where we are before we open up the broader discussion. So we've been asked to facilitate a discussion between USAID, the World Bank and WHO around these health system assessments. Because it was timely that the three institutions were all going through a process of updating their various instruments and thinking about the way forward. So it's a very timely time to do this. Over this last few months, we've been having a few conversations about how we might bring this all together. Some of the things that have come out of these initial discussions, I just wanted to share with you. First of all, that the three institutions were in agreement that what we're aiming for at the end of the day is something, a way of working that is led by national institutions. It's country-led. It's leading to sort of building up of capacities around national institutions, both in government and outside governments and academic bodies. That any instruments that the agencies come up with should be reflect that the objectives of different assessments vary enormously across countries and at different times, as you've just heard. But even so, there may be some common principles, some common language, and common taxonomy, because without that, you can actually cause more confusion if you don't actually have a common way of talking about particular problems and issues and components of a health system. And ideally, as you heard from Deepa, that there should be some shared learning across countries, across the institutions, about some of the lessons that are coming out of these assessments. But they have to be sort of flexible ways of working to respond to country needs. There may need to be some commonalities in approach, but also there needs to be the ability for much deeper dives. So when countries want to do a much deeper assessment of the pharmaceutical sector, then that should be part of the assessment, whereas in other countries it might be more focused on workforce. So there should be ability to do a sort of a common overall approach, but much more detailed, deeper dives as countries need that. And on the way forward, what the three institutions have agreed that in the short term, there'll be a sort of like a modular approach, so where be different components of these assessment instruments are being compared and commented on across the agencies. So the assessment of health financing has been shared between the World Bank and WHO and USAID. The assessments on workforce are being shared and commented on. So doing it module by module. But in the longer term, we wanted to have obviously this discussion, which is starting today, about how there could be a more common approach built across the agencies, across countries and across the regions, so that there's a sort of a common understanding about some terminology, because even though the point was made that even some basic components of describing a health system are sometimes different across the different instruments and different countries, and we need to get to a common way of talking about a health system. But also there should be ideas and common approaches in the countries, within the regions, within countries and national institutions to do this, so there can be some common learning. But anyway, that's the start of this discussion, so I'll stop there and hand back to Agnes.
Thank you very much, Bob. So USAID has had quite some experience and has pioneered health system assessments. It has a tool already and has produced quite a few of them over the past few years. Why does USAID think health system assessments are important, and how do you see this exercise really be added value in the new era we just entered of the SDGs?
Thank you. Good morning, everyone. USAID has been investing in health systems assessments as a form methodology since around 2006. And we have found them to be very useful as a means to diagnose health systems performance and to capture really critical systems-wide information. One of the things that I think we found valuable is that it's not just sort of a macro level provision of information, but it can be a tool that really leads to concrete recommendations and action steps that can inform planning and programming. It's as a systems tool, we find them to be useful not just in looking at functions within a health system, so financing or NHRH, things like that, but also looking across the health systems functions, really capturing those systems issues. So for example, a good health systems assessment will put emphasis on relationships and interactions within the health system and captures information from both your public sector, private sector, civil society, communities, and patients, and will also capture information on formal and informal sector. So, when properly done, it really does capture not just, siloed functions, the siloed functions within a health system, but these systems-wide interactions that are so important when you're trying to improve health system performance. It's been talked about before, Bob and Deepa both mentioned this, but the flexibility of the tool is important. You want to have certain common methodologies, but it's also been useful because these tools tend to be flexible enough to allow countries to design them to meet their own context and their needs at the time. So those are all ways that we found them to be very useful. Moving forward in the SDGs, I think they can be a useful tool to tracking progress toward the SDGs, and I think within that, then UHC can be a good organizing mechanism around a health system assessment. But not just looking at UHC, but also things like resilience. How is a system performing on things that can matter toward resilience? There have been certain good practices that we've seen in health systems assessment, I think, that would carry forward and be of benefit as we move toward the SDG era. When a health systems assessment is properly done, it's very critical to get a multi-stakeholder, multi-partner approach, making sure that in most cases they are led by the Ministry of Health, but also then reaching out beyond that to other ministries, and as I mentioned before, your private sector and community partners, and really capturing that critical information. Getting the mix on the assessment team is right, too. We found that to be the absolute critical piece, right? You need to have the right assessment team, and it's not just about getting the right mix of technical skills. You need people who very well understand the context in the country and understand the political landscape and the political economy context. So I think those are all attributes that will, can carry forward. And of course, we've had conversations over the last day about the importance of health systems data and using the right data. And I think as we've been exciting advancements in moving evidence base forward for health systems, and this as well, I think needs to be part of that. I think some things that we could do more of moving into the SDGs and UHC is perhaps strengthening the piece around systems thinking, really doing more to capture in the methodology, how do you incorporate complex adaptive systems? And I think that's something that we are trying to do. And as Deepa mentioned, harmonization is key. I don't think it's necessary that you have one tool for everything or one tool for each niche, but you do want to have harmonization. And you want to be able to give countries and ministries and partners informed information about what tools are out there and what they do and what's the added value of each one. So there's some informed planning. And then the last thing I'll say is, in addition to harmonized approaches, and Deepa also talked a little about this, being systemized in how we approach doing health systems assessments. it shouldn't be, doing a health system assessment shouldn't be a one-off exercise. You do it, you're done, and now you've captured all the information about your health system, and there it is. It's not necessarily something that, you know, you can just set a timeline and you do one every year, or you do one every 5 years or something like that. There's certain contextual factors, I think, that each country would have to decide when and how they should do them. But there should be some more systematic approach to doing these and then planning for future health systems assessments to build on the previous one. And I think by developing that systematic approach, where you're sort of institutionalizing this a little bit, that can remove some of the heavy lift. So it's not this monumental, you know, heavy lift every time you do one. It should be building on the previous one. If a country hasn't done one, the first one can serve as sort of a baseline. And it shouldn't be a consultant-based exercise. It really should be people in the country leading it who know the country. And so I think the system's progress that you know, this tool can be used as a way to measure systems progress towards UHC goals, and it can be used as an accountability tool in that way as well, making sure that countries are addressing these critical systems issues. You know, are we addressing equity? Are we training our human resources, our health workforce, in a way that they're going to be able to support the achievement of UHC goals? Are we addressing issues in the financing system, and et cetera? So I think these tools can be a really critical piece to tracking that progress. Thank you.
Thank you very much, Jody. So, Magnus, how would the World Bank see how to go about this in developing a joint tool? I mean, we currently have a working group that is working between the World Bank and WHO on developing a public financial management framework that is joint and assessing the public financial management environment. How do you see the expansion of that to a broader health system assessment? What would be, in your view, the added value of that? And what would also be the risk, potentially?
Thank you, Agnes. You know, I think it's clear that harmonization on health systems assessment, it's a no-brainer in some respects, and I think there's a lot that started already. In part, as you mentioned, there's been a collaboration between the World Bank and WHO, but also with USAID and other partners on developing a harmonized approach. And I think that's proved very useful so far. I think that can go a lot deeper, and I think UHC 2030 could play a role in supporting that type of process. I would sort of just note that in terms of solving some of the problems or issues that around duplication and uncoordinated work, inconsistent approaches, I think the harmonization of a health system assessment approach is only a very partial solution. And I think it's worth thinking about some of the broader challenges, because that may also have some implications about how we think for UHC 2030. In particular, you know, one issue is really more of an internal issue for various agencies about requirements that we have for new projects or developing new financing. And if we're not addressing some of those requirements that are in many cases driving agency-specific assessments, then the harmonization of an approach isn't really going to solve our problems. And the other, and I think this come up already a little bit in talking about sort of the need for deep dives and so forth, is that I think there is, it's important to recognize that the sort of harmonization at an agency level, and including through UHC 2030, is not a substitute for strong country-level processes. And there may even be a tension. And I think we've had, with some of the health financing assessment work that we've on the bank side, where we've been trying to be more consistent and systematic across countries, the standardization often leads to very large, comprehensive, complex tools, and the exercise becomes very heavy. And although it's comprehensive, it may not go deep enough in some of the areas that are particularly relevant in a country context. And even if there's a harmonization of the approach, if you don't have a country-level process where all the partners are engaged, involved substantively, and where there's a strong leadership from the government side, then the harmonization isn't really going to get us very far. So I think those would be kind of the main points I would highlight, that I think we're making some progress on the harmonization of approaches, and I think that could continue, and I think the UHC 20 could play a role. But in order to address the problems that this panel is ultimately about, we do have to look at these broader issues of how do we stimulate very strong country-driven processes that are about solving concrete problems and addressing real issues at country level. Thank you.
Thank you very much, Magnus. So very much anchored into the experience of the bank at country level. So let me turn to the representatives of the three countries and ask you. I mean, having been in countries affected by a crisis, the Ebola crisis, having had to respond to that, and having had to manage many different partners who sort of arrived in flocks in your country with different tools, different approaches, very large number of stakeholders. How would you see the value of a joint tool? Would it be something desirable? Would it really help you with the transaction cost? Vraiment, dans le cas de la Guinée, est-ce que vous voyez que un outil conjoint de mesure de la performance du secteur serait quelque chose qui aiderait à gérer la diversité et la complexité du nombre d'acteurs et du nombre de choses qui vous sont demandées à la fois dans la planification et la mise en œuvre au niveau de votre pays? So maybe, en commençant par la Guinée. So we're starting with Guinea and then Liberia and then Sierra Leone.
OK, merci Agnès. C'est effectif, la Guinée est l'un des pays qui sort d'une épreuve assez difficile de la crise de l'épidémie de la maladie à virus Ebola, donc pays fragile par conséquent. Et au cours de la gestion de cette crise, comme vous l'avez si bien dit, nous avons eu des centaines et des centaines de partenaires qui sont arrivés dans le pays pour aider à nous sortir de cette situation difficile. Et chaque partenaire constituait en fait un projet en soi, donc qui vient avec son cycle de projet où l'évaluation est toujours un des éléments dans ce cycle. Donc, l'évaluation de base, les données de base, les évaluations pour la mise en œuvre, sans compter aussi les différentes recherches, etc. Alors, pour essayer de canaliser un peu tout ce flot, dans un premier temps, la coordination nationale Ebola a créé une unité pour appuyer un peu tout ce qui était évaluation et recherche. Mais parallèlement aussi, c'est au cours de cette période que nous avons élaboré notre plan national de développement sanitaire et le plan de résilience du système de santé, avec son plan de suivi-évaluation. Mais malgré que tous les indicateurs, tous les cibles, on a tenté de les incorporer dans ce plan, malgré cela, chaque partenaire a continué de travailler avec ses propres outils d'évaluation. Et donc, ce qui nous a amené donc à recevoir ou à réaliser beaucoup d'évaluations, comme la première présentation du départ l'a montré, nos équipes étaient très réduites, mais ils devaient accompagner chaque processus d'évaluation, parce que tous ces projets et autres qui étaient là, leur redevabilité, c'était beaucoup plus, les acteurs de mise en œuvre, leur redevabilité était beaucoup plus axée sur ceux qui leur ont donné de l'argent, à qui ils devaient
obligatoirement faire ces évaluations parce que ça faisait partie des projets. Donc, même si certaines données existaient, il fallait qu'eux-mêmes, ils se lancent dans ce processus d'évaluation également. Et aussi, il y avait très peu de concertation dans le domaine de l'évaluation entre les différents partenaires. Il n'y a pas eu d'harmonisation, chacun a travaillé avec ses outils et avec ses résultats. Et malheureusement, sur les mêmes sujets, on a vu pas mal de données inexploitables parce que les méthodologies peut-être n'étant pas les mêmes, on s'est retrouvé avec des données quelquefois qu'on ne pouvait pas exploiter parce que les données étaient assez contradictoires quelquefois. Alors, sur notre petite expérience, avec ce que nous avons vécu, ce que nous, on pourrait conseiller ou suggérer, c'est de voir comment on peut harmoniser les différentes interventions des différents partenaires, améliorer le dialogue et la concertation au niveau de tous ceux qui sont intéressés, parce que nous avons, en fait, on a besoin des mêmes données, donc on peut mutualiser les moyens et les efforts, et là, ça fait moins de travail aussi pour la partie nationale, pour qu'on n'ait pas l'impression qu'au lieu de faire la mise en œuvre, on ne fait que des cycles d'évaluation dans le temps. Et pour nous, un outil qu'on a proposé dans notre plan national de développement sanitaire, c'était le GENS, qui était une évaluation conjointe où tous nos PTF et nous, on peut se retrouver et que chacun puisse participer à cette évaluation. Juste une dernière recommandation qu'on pourrait aussi dire, pour ne pas qu'on ait l'impression qu'on est toujours dans un cycle d'évaluation permanente, c'est de voir comment on peut essayer de travailler sur la périodicité des évaluations, qu'on n'ait pas des évaluations à faire tous les mois, tous les 6 mois, etc. Donc, grosso modo, ce sont là les quelques réflexions et idées que j'avais sur cette question. Merci bien.
Merci beaucoup. Donc clairement, une reconnaissance d'un véritable problème.
Oui.
Et à la fois, ce que vous nous dites, c'est à quel point l'outil d'AHP, qui était donc l'outil conjoint d'évaluation des stratégies et plans nationaux, a été utile dans cette perspective. Donc vraiment, la conclusion qu'un outil conjoint aide, mais qu'il y a une problématique aussi de cycle et de périodicité de cet exercice qui est quand même lourd, n'est-ce pas? So let's move to Liberia. How could these assessments be made that satisfy so many partners? You think there is a way?
Well, I think there's a way. But before going to the way, I think it would be useful to just give you some information regarding our own experience and how we navigated that, to go to what we have today. The HSA in Liberia was driven by 2 important factors. The first one was that we had a post-Ebola situation and we needed a plan on how to address the situation moving forward. And then we were also in the preparatory phase of doing our review for the 10-year plan that we have for Liberia, which was developed in 2011. So while preparations were ongoing to review our 10-year plan, we had a situation of the need to do a post-Ebola plan. And so we had a huge challenge, just like Guinea and other people have said. The players were very many in a post-conflict situation, post-Ebola situation we had. And most of the players were emergency kind of focused. They were mostly focused on emergency. And this kind of posed a challenge in terms of the content and the scope of the kind of assessment we want. So you have multiple partners, their focus is emergency, and then you want now to do something, to be able to rebuild your system. How do you go about that? So from their side, from the partner side, they wanted a rapid assessment, and they wanted something that would be focused on temporary recovery, maximum 2 years. And from the government side, we were like, we needed to take advantage of the focus down that we had on our country and the devastation that Ebola had done to the country to be able to focus on not only immediate recovery, but also medium and long-term rebuilding efforts. And so there were two sides of the story we needed, you know, a compromise on how to go about the assessment, whether we should do something rapid, quick, do temporary fixtures, or we do real comprehensive assessment and focus on immediate repairs, but also do plans for long-term rebuilding of the sector. Now, the president had an advisory committee called the PACE, President's Advisory Committee on Ebola. And it was at that forum that we presented our cases. Our partners said, oh, you know, the situation is like this. We need to do ABCD. And we said, no, as a government, we need to go this way. And finally, our plan was endorsed by the president that while it is true we do immediate, you know, recovery, we need to focus also on rebuilding efforts. And so the plan should be comprehensive to cover not only the immediate needs, but also the long-term plan, and it should be complementary to the 10-year plan that was intended to end in 2021. So based on that, we proceeded, and then we had a challenge of the contents as well, you know. The assessment actually is like a diagnosis, and it is the basis for your plan. So if it is not done properly, the solutions or the plans you end up with will not be addressing the relevant needs of the country. So we had that challenge, and we had to go beyond the traditional WHO, you know, building blocks sort of regard for the contents. We went beyond that to include other elements that were very relevant to the situation at the time. For instance, a comprehensive assessment on the EPRO component, the community role, the IPC, etc. All of these were factored in our plan. And in order for us not to get, you know, not to sway away from the key agenda, I think the governments need to be very, very strong, and they need to be informed when it comes to what these assessments are all about and what they will mean for the country. We had a huge challenge, you know, when it comes to, for instance, the health workforce component of our plan, where we had our partners come with a huge plan that was extending beyond the term of the end of our 10-year plan. And we had to tell them, no, we need to align with our 10-year plan to go, I mean, for it to be up to 2021 instead of beyond 2021 or 2025, because that's just a segment of the entire health plan. So again, we had a technical working group that worked with the partners to make them to be sure that they are aligned with the investment plan. Now, what do we need to do? What do we need to do in order for us to reduce the huge costs, you know, and all of these duplications? I mean, I think, firstly, we need to realize that countries need to take ownership and leadership. And our partners come in to help us, okay? They come in to help us, and if they are helping us and they have agendas that don't align with our agendas, we should be in a position to tell them, you know, we need to go this way. And I think for the purpose of the UHC, harmonization is the way to go, because that's going to provide us with the necessary baselines. You know, most of our countries focus only on, you know, what the immediate needs are for the country. They don't go beyond the global. So we need to factor all of the different indicators, you know, that will help us to periodically monitor over time to know whether we are making headways regarding the UHC or not. So harmonization for me is the way to go, and I think we can use the current platform that we have where the IHP Plus, you know, focuses, for instance, on these joint assessments, joint, you know, evaluation and reviews, and I think if we go that route, we're going to help countries to actually focus on what is very, very important. Thank you.
Thank you very much. So a clear, vibrant call for a harmonized approach to health system assessments. What about Sierra Leone? How is it in your country?
Thank you. I want to just to the line of our two sister countries to say harmonization and a common approach would be the best way forward. But it has its own shortcomings. Because I was thinking, are we going to have harmonization and common approach based on country-specific targets or indicators? Or is this going to be global? Because we have as different country issues and problems. And for the Ebola in Sierra Leone, of course, it came when we're not even prepared for the emergency, not to talk of the different organizations that came in at that time. And we had different structures. We had initially the Ebola, the Emergency Operations Center, which was transformed to the National Ebola Response Center, and we had so many organizations coming in and out. We had the British, we had IOM, we had the Chinese, we had the Japanese, all different organizations coming in to assist us in responding to the Ebola. And so each of them have their own agendas. Each of them wants to look at their different indicators, because I know at the end of the day they will have to report back to their international organizations or report back to their countries. And so it became so cumbersome and time-consuming for our health workers that for every 6 weeks, because sometimes we have a turnaround time of 6 weeks for every personnel that comes and goes. So it means for every 6 weeks, you have to get ready to change some of the indicators that were existing to new indicators. So to us, it was a real challenge for us to be able to tackle the emergency and at the same time being able to report based on the different indicators and agenda of the different IPs or donors. And so I was thinking that harmonization is key, but also we have to be mindful that some of the indicators might be consumed in some of those indicators that people might think are the best. So we have to be mindful of that, and also be mindful of the fact that the tools might be very cumbersome. Cumbersome in a sense, probably you might want to combine certain indicators based on either the IPs or based on the donors. And of course, time consuming, you know, having so many indicators, because harmonization means you need to make sure you factor in so many of the indicators that you think are so important. And for a case that happened for Sierra Leone was the HIV and AIDS. It came to a point that we had to start harmonizing all our indicators in our Directorate of Planning and Information. And some of the indicators had to be left out. And these were very key indicators. You know, so harmonization is key, but we also have to be mindful that we do not waste too much time and it doesn't become too cumbersome for our health workers.
Thank you very much. I think, again, a very clear message that, yes, it would be a good thing to have a harmonized health system assessment, but we need to be mindful that it's not too heavy. We also need to be sure that it's flexible and adapted to the country. So a tool that remains light and has the possible, and that was sort of responding a bit also to the concern of the World Bank, that it needs to have that level of flexibility that allows to have a country-specific specific approch. So how does this resonate with the Global Fund on AIDS, TB and Malaria perspective, George? And what would be the added value for you to have that joint approach? And where do you see also that there would be risk? I mean, in the same way as Magnus was identifying risk. And I would push it a little bit further in your case in saying, well, if we would have a joint tool, a joint health system assessment tool, could it be the basis for actually triggering funding? Could it be the basis for grant application, which would actually allow the country not to have a duplication of processes?
Thank you. As a funding agency, the Global Fund very highly relies on analytical evidence and empirical data in order to prioritize investments and to support the interventions which are based on objective needs. And during the last 2 to 3 years, the Global Fund implemented a few changes in its business model, which I think are very relevant for this discussion, because these changes, I think, create the grounds which help generate demand at the country level for such joint assessments of health system performance. What are those changes? First, there is a shift from annual funding rounds to 3-year funding cycles. This gives countries more space and more time to generate analytical evidence. The second change is the shift from approve-reject business model to the iterative process. Countries do not have to compete with each other. Countries actually are given funding allocation and time to make the best usage of that money. So obviously the empirical data is useful. And then the third is the shift of health system strengthening investments from very narrowly defined single disease focus to more broad cross-cutting HSS. But what we see in practice is that funding applications for HIV, tuberculosis, and malaria are more often based on empirical evidence and analytical data than health system strengthening funding requests. And I think one of the reasons for this difference is that in the HIV, TB, and malaria space, there is a mechanism in place which countries use on regular basis for assessing the assessment of national disease programs. This is national disease program reviews. And those are joint activities. For example, in case of HIV, PEPFAR, Global Fund, UNAIDS, WHO, and others would assess national HIV program jointly. But those disease reviews, although they have some health system aspects in it, but they are not designed for cross-cutting health system assessment. So such a tool and such a mechanism would be probably very useful, and we would welcome this. Now, you also asked me about some risks, and I think there are some risks. We need to probably learn lessons from other tools and other experiences. There are quite a few other tools which are designed for joint usage, but because of the lack of accountability mechanisms and because of the lack of coordination mechanisms, their application, joint application, has been a challenge. One of those tools that come to my mind is the SARA, Service Availability and Readiness Assessment, which is a very good tool in itself, but because of the coordination and accountability challenges, its application has been difficult. Another risk is probably an agreement on the methodological framework, because health system assessment should be something that generates information for a broad range of partners. HIV, TB, malaria, but also immunization, probably mental health, neglected tropical diseases, and so forth. But it should also look at cross-cutting issues such as systems efficiency and equity and sustainability and probably, human rights aspects. So there are multiple questions which this exercise should answer. So the methodology can be quite heavy, can be quite difficult. So there is a risk of making it not user-friendly, but quite cumbersome. So the question is whether should we have one kind of mega exercise or whether we should have several targeted evaluations and then some kind of meta-analysis. And then the last risk would be how those findings which will be generated through these assessments can be used by partners. For example, how the Global Fund and Gavi and PEPFAR and the World Bank and others will then divide up the financial labor in order to provide support to countries to address the needs which will be assessed. I don't think we have a common framework for joint implementation of HSA support. Joint HSA tool would be a joint diagnostic tool, but then we need something for joint implementation, and hopefully UHC would also have a space for those discussions.
Thank you. Thank you, George. So I think we get from the panel, in my view, quite some consensus on where we stand on this collectively. One is that generally it's really desirable to have this joint assessment tool, yet it has to be done in the right way, with the right amount of flexibility at country level, with the right level intensity of the exercise and complexity of the exercise. But there is also, and I'm very pleased to hear that from both USAID, the bank, and the Global Fund, really some really appetite to use that tool and to decrease the transaction cost at country level that were very that the three countries have really identified as being a major issue today. So we have a bit of time actually to get the reactions from the audience. So I mean, now it's back to you. So any contribution or question to the panel? Contribution is better because we really want everybody to be there, but questions are also welcome. Yeah, I think you have. It's difficult for me to manage from here, but let me start with the country level. I see Mali asking, and then I'll move to the left. Le Mali peut parler.
Les panélistes, la discussion ce matin était très très intéressante autour de l'évaluation du système de santé. Je crois que tout ce qui a été dit autour de cette table est effectivement une réalité. C'est plusieurs évaluations, des multiples évaluations, des évaluations de toutes sortes qui viennent de partout, alors, et cependant, qui évaluent quoi? Qui évaluent le seul système de santé du pays et le seul programme du pays. Vous voyez, donc quelque part, quand je prends le cas du Mali, nous sommes un pays qui a un plan de développement sanitaire qui intègre tous les intervenants. Nous avons un programme de développement sanitaire et social qui intègre tous les intervenants et tous les partenaires. Donc vous voyez un peu, ça demande quelque part un peu de force, un peu d'autorité, bien sûr, du côté national, à vouloir vraiment discipliner quand même ses partenaires, n'est-ce pas? Je suis d'accord, hein, je parle entièrement de ce point de vue, parce que ce côté, vous ne le dites pas du tout, parce que quelque part, il y a une certaine fragilité, n'est-ce pas? Alors, du support national, devant l'influence partenaire, à garder ces principes d'uniformité et d'harmonisation de l'évaluation. Donc, je crois que ce matin, si cela sort de la position de chacun des groupes que je vois ici, mais moi je le note comme étant un fruit et je prépare fondamentalement, en tout cas, mes autorités et moi-même, parce que je suis directeur de planification et des statistiques, je m'occupe de toute la statistique sanitaire et de la planification nationale pour 3 départements, santé, développement social, promotion de la famille. Alors, c'est bien entendu. Alors, je note bien et je crois que nous serons en phase pour aller vers une évaluation et une seule évaluation harmonisée. Cela n'exclura pas du tout que pour des besoins ciblés, qui rentrent bien sûr dans la gestion d'une résolution spécifique d'un indicateur, bon, il n'a pas exclu de mener, comme quelqu'un l'a dit d'ailleurs dans la salle, de mener des approches spécifiques pour arriver à évaluer ça. Mais l'évaluation de ce système suppose l'intégration des outils. Et l'intégration des outils suppose aussi l'appréciation et une étude de ces outils-là. Que ce soit le JANS, que ce soit autre outil, il est très important de les étudier, de les intégrer, parce que souvent, ce n'est que des duplications et des formes. Donc, ça suppose quelque part une étude au niveau des maisons et des bureaux pour procéder à une très bonne intégration de l'ensemble de ces dispositifs. Je vous remercie.
Merci beaucoup. Je vais prendre d'abord les contributions pays.
Et merci de m'avoir donné la parole. C'est Dr Djibril Ba. Je suis le directeur de la planification au niveau du ministère de la Santé et de l'Action sociale du Sénégal. Donc, je remercie les panélistes d'avoir bien voulu discuter de ce sujet. Je dis qu'on tend vers la couverture universelle 2030, c'est notre défi et c'est notre objectif. Et ça suppose quand même qu'il y ait des systèmes de santé robustes et résilients. Et pour cela, nous savons que les évaluations sont nécessaires et que ces évaluations font partie de la gouvernance sanitaire, en ce sens que les résultats nous permettent d'apporter des correctifs et nous permettent aussi de nous projeter par rapport aux futures actions. Mais comme tout l'a dit tout le monde, on se rend compte qu'il y a beaucoup d'évaluations et qu'il y a peu de coordination, peu d'intégration, et aussi on a un problème d'utilisation des résultats. Et le problème aussi, c'est qu'il y a beaucoup d'outils et que ces outils sont changeants. Et les acteurs n'arrivent pas à se familiariser. Et la plupart du temps aussi, ce qu'on remarque, c'est une certaine dépendance des parties nationales vis-à-vis des partenaires. Donc, nous, ce qu'on préconise et ce qu'on aurait souhaité, c'est qu'il y ait des évaluations, mais que ce soit des évaluations globales, centrées sur la stratégie nationale de santé, et qu'il y ait un alignement des projets et des programmes. Quoique, même à l'échelon national, on voit que quand on évalue le programme SIDA, on évalue le programme paludisme, on évalue les PEV, et on trouve des bonnes choses sur le PEV, des mauvaises choses sur les maladies transmissibles. Je crois que ça ne facilite pas un bon développement du système de santé. Donc nous, ce que nous préconisons, c'est qu'il y ait une évaluation globale et qu'il y ait une certaine chronologie dans cette évaluation et qu'elle intègre tous les autres programmes et projets. Et que ça rentre aussi dans un cadre commun des résultats. Et que la stratégie nationale, qu'il y ait un cadre commun des résultats et qu'il y ait aussi une définition des indicateurs prioritaires. Parce qu'on ne peut pas tout évaluer, mais il faut qu'on s'entende sur certains indicateurs. Et ce qui dénote de notre part une certaine action, il faudrait qu'il y ait une appropriation véritablement de la partie nationale, parce que ce qu'on remarque, c'est la passivité. On est tout le temps dépendant des bailleurs qui nous disent il faut évaluer, il faut évaluer, il faut évaluer. Il faut qu'on se l'approprie et qu'on le fasse de manière globale. Et ça appelle aussi de la part des partenaires une certaine observance de bons comportements tels que édité par l'ISP+. Je vous remercie.
Merci beaucoup. Il y avait une autre contribution pays. J'ai vu la table suivante, non? Non? So Lola, please. You don't have a...
I think all the panelists have had very excellent contributions, but I look at this added value. And I hear from the panelists that one big added value that's not here is the added value that says we will conduct only one health systems assessment. And it's not about harmonizing our methodologies to conduct it differently or leveraging our complementarity and tools so that we can conduct it at different times. So is there an added value here that says we will only do one health systems assessments that will contribute to one national health plan or one process that it can be used? I'm not sure that we have mentioned that. Sierra Leone talked about the indicators and the difficulty that we have with indicators. I know that in the Health Data Collaborative, there have been 100 core indicators, 109 additional indicators, there are UHC monitoring indicators, there are health-related SDG indicators, and in the last tracking that we've done, those in themselves are about 500. And so when we then add program indicators to that, we're going back to business as usual if we're not careful. Will the health system assessment tool help us to work within those indicators alone, or how do program indicators come into that so that we know exactly which indicators we're going to use next year and we can collect them? This morning I had the benefit of sitting next to Ozaid, and it was interesting to know that there's a risk management profile that is allowing each one of us to do different studies. And people have to report to their parliaments, they have to report to their Congress. African governments also need to report to their countries. So there is and you have to report back to your donor. So maybe that is one of the things driving that is that each program is managing its risk independently and is not doing a joint assessment of risk that allows us to manage risk together. Is it possible that the UHC 2030 could also look at these health assessments and include risk assessments into them that allow us to have one risk assessment approach that can help to influence that political economy? Thank you.
That's certainly a very interesting proposal. We know several institutions, certainly the World Bank does a lot of these risk assessments, but they could really be sort of exported as a concept to a health system and could be very useful. Other contributions, I'm shifting to the left. Yes. So that table, the two contributions on this table first, and then I'll move to the next table.
Okay. Thank you very much. I'm Brad Hirsch from UNAIDS, and I think this panel is very timely. I think you're covering some important issues which affects all of the work we're doing. And I'd like to sort of echo comments by George. I think that I work in UNAIDS and I work in HIV, and we're closely with Global Fund supporting countries developing concept notes. And while we try to include HSS in every concept note, working with people from TB and malaria, trying to be comprehensive, we all look at the health system from a different perspective. But we all use the same health system. So I think that we've made a lot of progress through the Global Fund on HIV, TB, malaria, but we've not done a great job working together for HSS. I think this has been highlighted by last year. 20 countries were identified in the Global Fund, which take over half the money from the Global Fund per year, over $2 billion per year, which are having challenges implementing their grants. And the major problems were operational planning, HR issues, HIS, financing, procurement, supply chain management. So I think that having a common assessment of the health system would be very useful for countries to work together to develop evidence-based plans for HSS. I mean, we're all in this together, and the more that we can work together in doing a common assessment, and based on the assessment, prioritize what areas health system are needed improvement, that would help improve effectiveness, efficiency, impact, and sustainability. Thank you.
Thank you very much. Joe?
Thanks. Joe Cutson from WHO Health Financing. I wanted to pick up on something that was said by Magnus in particular, which is this distinction between, or in a way recognizing that what we might be doing globally is not a substitute for country processes and maybe be actually at cross purposes. And it might help to kind of break down some of the types of work that have been talked about into, I have 3 categories, 2 of which we mostly talked about, the other one we didn't. One is diagnostics, right? So this is kind of like the health system assessment, the work that a number of us are doing in different parts of the system. That can be relatively standardized, I think, as an approach for these things. And obviously, and as Lola Dari said, the idea of doing 1 rather than 5, very important, you know, in terms of being efficient at this. So that's one. A second is monitoring. And one concern I have is that somehow, you know, what should be monitored should be handed down from Geneva or Washington or whatever. Like in the SDG indicators, for example, to be relevant globally, it has to be a kind of least common denominator, right? It's not going to provide what is needed in your particular country. So in a sense, if you look at the service coverage component of UHC, there's going to be a mix globally of different communicable and non-communicable and other things. But if you're in Sierra Leone versus Kenya versus Cambodia versus Norway, the composition of what those services is should be tailored to what you need. So in a way to not let the global agenda overrun what you need to do and how you need to tailor things at country level. And last, and I think very importantly, which we often forget about, is we use the expression M&E when almost entirely we talk about M and we forget about E, right? So this is the importance of doing good evaluation and applied policy research. And this is not something that can be done globally. This requires very country-specific approaches to really learn from the reform experiences in particular countries. And so this, in effect, requires having capacity on the ground, people who can do this type of analysis. It requires that there's some demand from the decision makers to use this type of information. And thinking about the institutional platform that enables that work to be really responsive to country policy priorities while having sufficient distance that it can be independent and having a way to attract and retain national staff with the skills needed to do that. Very often that's hard to do within the core civil service So we need to be thinking about other types of arrangements. I mean, on one level, the Thai International Health Policy Program provides a very good example of that. But the specific model is going to vary, but we really need to focus, I think, much more on country-level capacity and systems to do applied policy research and not just more generic monitoring.
Thank you. Please, the following table just behind. Yes?
Thank you. Rosina Mistry from Civil Society. I'm a little worried. First of all, I'm worried because of the various anxieties and concerns that were raised over here. And also because one powerful statement that I heard yesterday from India and also from other people is about health is not inside the health system, health is outside the health system. So the relevance of the current HSS system to actually assess that particular component, that particular aspect of UHC is what comes to my mind. Secondly, at the global level, generally, a lot of investments have been made, and I was a part of GWAP and I was a part of Gavi, so I'm aware of all the sophisticated analytical tools that have been developed. So how easy would it be at the global level to move towards the new UHC-related, integrate new UHC-related indicators into monitoring system? And finally, my experience from my country is that when one-time epidemic or one-time crisis and one-time humanitarian assistance is fine, but when every year, at a certain time of the year, when you know that children would be dying because of diarrhea and because of malnutrition in various parts, then humanitarian assistance agencies want their MIS system, I would say, to be in place continuously. At the same time, the government wants to have their regular system institutionalized, and that is where I see that there is constant debate going on as to how to integrate the two, because the numerators are different, the denominators are different, the outputs that government wants to look at are different, the inputs that humanitarian assistance wants to look at are different. So these are all the other challenges that you have just highlighted, and I'm just adding to those few and highlighting that we need to incorporate people's perception and people-centric indicators in this new approach that we are taking, with more efficient and economically sound approach.
Excellent suggestions, yeah. The second person on the table, and then we'll move to the next.
Thank you, Remco, Medicus Mundi International. It's more of a reflection that in the changing role of aid, also the role of NGOs in this is changing at the country level, and that a lot of NGOs are more focused because of the financing. They're working in a more targeted way, I would say, that might not always be that coherent with national planning and assessments of that. So it's also a pledge to the NGO community itself to properly align with this kind of assessments. And you don't have an NGO representative directly on the panel here, but this is something also that the NGO and civil society community has to do to have its own house in order. So if there's a kind of modality that NGOs can properly link with these assessments both at the country and global level, then we would support that.
Thank you. Next table. Yes?
Yes, okay. Tim Rosen, Action for Global Health. Thank you. I want to make a reflection on, because this discussion is based within the UHC 2030, or IHP Plus for UHC 2030, to make a reflection on a universal applicable tool, and more specifically towards equity. It was mentioned that we need to make sure that we capture not only the performance of the system, and make sure that we capture as well the populations that are missing, that do not have access. And so I was wondering if that is something that could be considered, and there are tools that exist, whether from within WHO on health equity assessment toolkits, but also the European Union has health equity audits that take place within the EU that might be universally applicable. So I'll be a plea to include this within a joint assessment tool.
Very welcome plea to include equity as a dimension in the health system assessment. More in this table, otherwise the table just in front. Yes. Yes, go ahead. Go ahead. Yes. If it works now. Can you get another one? Yeah, it works.
Yeah, thank you very much. My name is Akashi from NCGM Japan. I would like to give some other aspect. If that means that we will focus on survey type measurement or surveillance type measurement. For instance, in Japan, we can get the one-time assessment to get a whole picture of the health system. That means that, for instance, the human resources, we can get the reporting from the facilities. So if we, for instance, the different donors supporting to the each system to collect the data, that can be also the part of HSS. So that is another way to get the measurement indicators. Thank you.
Thank you very much. There were, I think, still requests. Yeah, in the back, Walter.
Yes, thank you very much for this important contributions, and a lot of things have already been said, so I can be very short. Making the diagnostics and monitoring and evaluation is certainly important steps in our interactions at country level, but what then to do about it? I heard from one colleague the word of appropriation. And for us, well, we call it dialogue, and I think we are having a joint program with WHO to exactly strengthen that dialogue, and I would be interested to hear from the panel what, under the new UHC 2030, participants would like to see in terms of dialogue. I mean, once you have the diagnosis, how to dialogue in the most aligned and most appropriate form about remedial action. Thank you.
So a call for the tool not to be only a technocratic tool, but really be a policy dialogue tool that also guides process. Yeah. Ian?
Yeah, just a small plea to include the historical perspective in a health system assessment. How the system has got to the point that it's at now. It's not a point prevalence. There's often an evolutionary story. Many systems have had great success in that process. Many have had successes that have not been sustained. And the reasons for things not being sustained, I think, is always important to analyze. And many have been more fit for purpose at times in their history. For most countries here, I think we're talking about their post-independence history than they are now. And I think that we should all remember that if we don't learn from history, we may be forced to repeat it. Thank you.
Yes.
I'm Dirk Hormans from WHO, from the Service Delivery and Safety Department. Just in connection with this morning's session on multi-sectoral and global health security aspects, I wanted to flag that within the context of global health security, several assessments are also being done. Most famous for the moment, the JEE, the Joint External Evaluation, but there are also preparedness assessments. There is IHR capacity assessments. So wondering how this could link with the health system assessments and then partially with common planning. So it's a comment and for the moment still a remaining question. Thank you.
Timely and topical question about the linkage between specific assessments on very critical and urgent issues and the linkages with health system and how we bring it together. Certainly a very, very high priority agenda for this group that is going to take on this work. More contributions? In this case, oh, yes?
Kausar Afsan, I'm from Bangladesh. I'm just thinking that if we have some common indicators, anyway, you know, that countries, whether you develop common indicators or not, people would have many different indicators. But certainly we need to have some common indicators that should be decided. And every country, they have their MIS system, monitoring system, evaluation system. So that will continue. But I feel that in the era of ICT, we need to use the digitalization of all our data system, especially the MIS system. So that would be a revolutionary, you know, then probably it will also duplicate, triplicate, whatever, the resources. If we have a good MIS system using the digitalized, that means the ICT devices, that would be helpful for the country. And for the health managers, I'm just thinking, because mostly we forget about the health managers who actually follow all those data more or less regularly. For them, I think that would be very useful to have the MIS system. Otherwise, you know, the research or the monitoring, that will not give you the immediate report. And the health managers should also regularly follow up their own system, how it is performing, especially when we have been discussing about universal health coverage.
Thank you very much. So we're reaching the end of this session, which I think has been incredibly useful, at least to me, to really understand the views of everybody on this. But any reaction from the panel? Is there a particular question that you'd like to address or contribution? Une réaction par rapport aux contributions? Oui?
Yes. I want to react to the issue of prioritization. We know World Bank, Global Fund, all our donor partners have their own indicators that they're looking out for. And if we are going to prioritize, we want to harmonize and have common approaches. At the end of the day, what are we going to prioritize? We have to report globally. We also have to report to our health partners and donors. So how do we prioritize? How do we go about that? That's also an issue that has to be added, because no one indicator might be more important than the other. You know, so what do you prioritize?
I think you get a lot of approval from the countries in the room. So that's really a question I think we need to put in the terms of reference of this group that is going to work on this tool. As you know, if we have a tool that measures everything everywhere, what is the simple version of the tool? Yeah? What is the, so maybe talking about maybe a common framework and then maybe different ways of drilling down with different levels of depth. Sort of like, yes. So the sort of question between breadth and depth, that probably we want some breadth everywhere, but we may not be able to get some depth everywhere. I mean, this is a bit of a, but certainly we'll put the question of prioritization as a high priority question in the exercise. Any view?
Yeah, and there was an issue regarding how do we link the different assessments with the general maybe assessment for the nation, or the HSS assessment, so to speak. In most instances, you have assessment reports that you can use to feed into your general assessment for the country. You don't have to repeat what you did before. So for instance, if there was an assessment done on infrastructure or for HR, you don't need to repeat that when you're doing your assessment for your strategy. You use that result. If it is not very, very old, you use that result to feed into what you're doing. I think that can help, you know, to cut down some of the duplications that we experience, you know, as a result of these repeated assessments.
Thank you. Any reaction?
Just want to maybe respond or add to comments by Walter and by Dirk. Dirk, when you mentioned the IHR capacity assessment, this is really at the heart of this, of the harmonization work that we would have to do is to first see what is out there and then have a discussion jointly to see how we, where are the complementarities, potential duplications, and see how we can bring that together and to fulfill all of our objectives. And of course, first and foremost, the country objectives. Regarding policy dialogue, Walter, I think, you know, the different tools, I think, when it comes to content, there are few contradictions or issues that are probably very easily solved when it comes to the content and even terminology. These are all things that we can work through and solve. Where we probably differ is the methodology and approach, where and this is where the dialogue component comes in. And I think that's where we will seek to find a common ground and put a lot more emphasis on that, because that's just as important as the actual the assessment results.
Thank you very much. So I think it's time to conclude, and I just wanted to say that it seems to me that this entire discussion is a very good illustration of the added value of the healthy system, healthy life roadmap. It's like how you take a set of processes that are already there in different organizations, that are how you link it to a problem that is really acute, such as the problem of transaction cost and multiplicity and complexity of processes. And how do we take it forward? What is the roadmap to actually improve on existing processes, and how can we improve the efficiency of our collaboration through addressing the failure of collective action, the failure of coordination? And that's really the value of the proposition of the roadmap, that we have these different set of lines of work, these different pathways, different line of works in which we're going to improve. So here it is about having a common view of what is it that we measure in health systems. And I think what I can conclude from this discussion is, yes, there is an agreement that there is value in having a joint tool. We should move forward. That UHC 2030 is the right place to do that, probably because it also has this combination of IHP-grounded work on harmonization, but because also we need a common set. We need to agree that we will all be measured by the same standards. And that but at the same time, with this agreement, I think the risk being very well identified, but also already proposition on the table on how to manage those risks. One being having the possibility of having flexibility within the tool, that it should not be too heavy, that it should be tailored maybe through different contexts. The very important issue of prioritization, maybe with the answer being having different levels. But still, even I think this all looks like very manageable risks. And so that's really here this example of a process that has been going on for many years, that's been carried by different organizations, particularly the WHO and USAID, and that now, with this process of the roadmap, is actually be taken to the next level and in the production of global public goods. So thank you very much. Thank you to everybody for the contribution. I think we really have a very nice way forward. Thanks.
It's already lunchtime. Thank you, and thank you, Agnes, for facilitating that. It's an early lunch today. We have an hour, 53 minutes, and we'll be back at exactly 1 o'clock. Bon appétit. Maybe that's the relationship we're supposed to have. All right, everyone. It is 1:09, and this session is already a very short session. It's scheduled to be an hour long, so we've already lost 9 minutes. So let's not eat more into the session and make sure that we get the best out of the time that we have after lunch. Like I said, we start with who? Shh. Simon. Hey, it works. We'll start with people who are in the room. Thank you for being on time. Thank you for showing up, and thank you for being here. So I won't take any more of your time on talking about effective development cooperation, which has been a theme that has been sort of cutting across so many of the conversations, but at least now we get an hour to get deep into it. Aida, it's you.
Thank you. Thank you very much. So thank you all for joining us after such a wonderful lunch. I think that our organizers did it well to put to the program after lunch such an interesting topic which has been basically kind of glue across our program yesterday and today. So not to take too much time, let me firstly present today's panelists. We have Marjolaine Nicode from IHP Plus, Max Dapa, IHP Plus, Lola Dar, President of Chestrad from Nigeria, whom we hear and see a lot during the 2 days, which is good. Dr. Isaac Adams, Director of Research, Statistics and Information, Ministry of Health, Ghana. And Dr. Or Van Dien, Director General for Health, Ministry of Health of Cambodia. And Heiko Warnken, Head of Division Health Population Policy and Social Security, BMZ, Germany. Welcome all. And I immediately give the floor to Marjolaine to present us the IHP Plus.
We get a microphone.
I want you to stand.
Well, let's see.
Okay, we are going to present very briefly what IHP is about, because we've heard a lot about it, but we didn't have a chance until now to really provide you with a good picture of what it is about and what it's doing. And if you are interested in more detailed information, we have a more comprehensive presentation that we will upload on the website page dedicated to the dialogue we are having today. So on the left, you can see where we started from 10 years ago. It's quite disheartening. Who would like to sit there? Not me, and I'm sure not many of you, and unfortunately, sadly, we heard yesterday and also this morning that there are still too many of participants, even here today, being in this kind of situation, having headaches with too many reporting requirements piling up from donors, while at the same time, the people who are really needed healthcare services are waiting behind the door. So this is why the International Health Partnership was launched 10 years ago. It's a partnership bringing together countries, bilateral donors, multilateral agencies, civil society organizations, and the aim is really to try to accelerate better healthcare services and health outcomes by putting the principles of development effectiveness in practice in the health sector. It's based on a kind of strong process to get into it, because there is a global compact that needs to be signed, and it's being signed by ministers, so it sends a strong signal of political buying. And actually the champion behind that in 2007 was actually Gordon Brown when he was the prime minister. So a very interesting process. So, and today we have probably an opportunity to build on this good example. In terms of who is in, today we have 66 signatories. It started with 27. We can also see that there has been a lot of enthusiasm among developing countries, with an increase from 8 to 37. And the last to join is Liberia. It was earlier this year, so welcome to Liberia. We hope that others will follow suit. And what IHP is doing is very often referred to as the 7 behaviors. So basically the idea is that aligning behind one strategy, one plan to ensure that external assistance is aligned with national priorities requires all stakeholders to change the way of working together, not individually, together, collectively. So IHP Plus over the years has identified and codified the critical areas of action known as the 7 behaviors. And these are not new principles. Actually, they are the ones reflecting, decades of good practice in development cooperation, and then they've been embedded in the so-called Paris Declaration on Aid Effectiveness, and then the Busan Declaration for Effective Development Cooperation. So what do we do through IHP Plus as a partnership? And actually, the partnership provides some guidance and tools, but then it's up to individual members to walk the talk. I mean, IHP Plus is not an international organization. It's a concept. It's almost like like some guidance, a Bible, it provides like a roadmap. So in terms of what the partnership as such provides to help members, includes tools, such as the joint assessment of national strategies that we've been mentioning before this morning. We've also provided guidance for developing country compacts, and these compacts are very important at the country level to agree collectively among all stakeholders how we are going to work together, and they fix the commitments for various parties. They also fix the preferred modalities to channel external assistance, and also, more importantly, they also provide most of the time for monitoring and accountability mechanisms. Another tool is also providing guidance for establishing a single platform for monitoring and accountability at the country level. And we heard about this. It's work being now championed by the Health Data Collaborative. And we have also the work on promoting joint PFM assessments, and Max is going to talk about it in a minute. The second area of work that IHP has been strongly promoted is monitoring of the 7 behaviors. So we have a monitoring process which every other year try to take stock of where we are in terms of walking the talk, implementing the principles. And there is such a process going on right now with 31 of the 36 developing countries being engaged in the process, and then all the other partners. So it's a country-based process, and you will hear more about the outcome of this later this year when we have the findings. And later in the debate, you will also hear more about where we are and what we can do to build on, the evidence to take action.
Okay. So, as Marjorie pointed out, there are 7 behaviors that IHP Plus has been advocating that needs change, especially at the country level. And one of the critical behavior that we've seen is around financial management. And this slide just shows the financial flows from donors and as well as that of the government in one particular country in the health sector. So you can see the complexity of such an arrangement there. You know, different donors coming in with parallel arrangements and setting up their own funds flow arrangements really creates this almost very chaotic situation there. And what we see here is if you have this level of complexity with funds flow, then it increases the opportunity for double dipping, and also there's lack of transparency, and also an increase in transaction costs, for instance. So you have countries where in the health sector, instead of having, let's say, 1 or 2 audit reports, you might have 10 audit reports that are done because each donor wants their own audit report. And then in most instances, the issues that are raised in this DPX's audit report are not known by DPY. So this is the kind of problem that IHP Plus has been trying to deal with, and to see to what extent donors can work together to either align or harmonize their implementation arrangements around financial management. So succinctly, these are some of the principles that IHP Plus has been promoting at the country level. So one is to see to what extent donors can align with the country system, which is the ultimate. So everybody agrees that to the extent that donors are comfortable with the country arrangements, the expectation will be to use the country system to implement your particular program instead of setting up a parallel arrangement. Now, the second principle that IHP Plus has been advocating has been that assuming that the country systems are weak, and in some countries the systems are weak, so we recognize that, donors should look at the option of harmonizing their implementation arrangements. So harmonization is an option in instances where we have weak fiduciary arrangements in countries. So in this case, donors will agree to use common or joint implementation arrangements, which then offers an opportunity for donors to also work together in a joint manner to help the country to address the kind of weaknesses that causes the discomfort or the lack of trust and confidence that they have in the system. So harmonization is an option. And as I said, this should lead to some form of joint approach to be able to help address or remediate some of the weaknesses or risks that exist in the country system. And so after that, then you can transition to the use of country system again, which is alignment, which is where everybody wants to be. So I'll just give an example. Before I go to this slide, I'll give an example of some of the work that has been done, or maybe 2 examples of some of the work that has been done in this area. So if you take a country like Sierra Leone, and I know we have a representative from Sierra Leone here, in 2012, IHP Plus was approached by the Ministry of Health and Sanitation in Sierra Leone to do a joint financial management assessment of the health sector. So using the IHP platform, donors including World Bank, Global Fund, and Gavi came together to do a joint assessment of the entire health sector to understand what the strengths and the weaknesses of these PFM arrangements are in the health sector. And this assessment led to a series of recommendations, which then resulted in an action plan that was agreed to between the donors and the government. And one of the key recommendations and actions that have been taken is the creation of what is referred to as the Integrated Health Partnership, Integrated Health Projects Administration Unit in Sierra Leone. So as we speak now, this unit is functional in Sierra Leone. And what it does is this unit brings together all the fiduciary work for donor finance projects under one space. And so as we speak now, the unit is being capacitated to do the work. Some transition has taken place. Some donor projects have been moved to this unit as we speak. Now, quite recently in Liberia, there was a request that we received upon joining IHP Plus to do a joint assessment. And so IHP again organized this, and we had about 8 donors going in countries to do this joint assessment. So that offered donors a chance to look at the sort of the systemic PFM weaknesses that exist in the FM arrangements in the health sector and to propose recommendations. So that's just, these are just examples of what platform IHP Plus creates. So, so that leads us to where we are today. You know, I guess part of this consultation is to sort of find out if in this new environment that we find ourselves, which is UHC, where we have sustainable development goals underpinning the creation of UHC, as well as the inclusion of UHC in the SDGs, and emphasis on domestic resource mobilization. Do we think that such joint approaches, such as what I just explained in the area of financial management, are relevant? And what do we think would be the best way to sort of move forward on this agenda? Thanks.
Thank you very much, Marjolaine and Max. Thank you for showing or illustrating the complexity of harmonization and alignment. What I think struck most of us was the illustration also from the previous session, session 7, where we saw 15 staff of Ministry of Health and a large number of players in the field, 13 donor government program, coordination committees, multilateral agencies, international and national NGOs. So this brings me to question, what is it that we can work on more to improve the functioning of such a complex system in the field? And which takes me to Lola. So Lola, what do you think, do the IHP principles remain relevant for the new IHP for UHC 2030, in your opinion?
Thank you very much. When I got that question, I took a quick look at the global compacts for the IHP, and 3 things jumped to me. It says, use shared processes to support national health systems, and the whole House would say, yes, that's still relevant. It says, review policies and processes at the global level to enable better coordination. The answer is yes, even if I answer on everybody's behalf, that's still relevant. Then it says, make this a priority and have incentives that empower our staff to work at a coordinated level. Yes, that's still relevant. Governments say that they will enable national health plans and within overall development plans. That's still relevant. Involve citizens and stakeholders. That's still relevant. Be accountable. That's still relevant. So I think that, for me, the IHP Plus principles and the original compact remain, they resound around every goal of the Sustainable Development Goals, and they're still relevant to us. So I then tried to look at it. So we do have an unfinished agenda, because many of the things that are written in this compact are still yet to be achieved. So there is an unfinished agenda. We have learned, and so there are issues to resolve and things to revitalize, and we need to revitalize them. And then there are achievements to sustain. There are key things that the IHP Plus has achieved, and we need to either scale them, expand them, and sustain them. And the IHP Plus in its new configuration needs to take on new priorities. So I say, what do we need to sustain? JANS has been very good. It was very good. Partners did come across JANS. There's one monitoring and accountability platform. In the initial phase of IHP, we actually, as civil society at country level, owe to the IHP the capacity to engage in national policy dialogues and be part of that process. So there's quite a number of the financial management systems and maybe the IHP Plus behavior. I think IHP Plus has been very instrumental into ensuring the process and behavior part of accountability remains on the table, and I think it's something that we need to sustain. What are the issues that we need to either revitalize or rethink? The balance between investing in a national health strategy and a comprehensive, bold, integrated and inclusive national health plan remains unresolved. In as much as partners and programs can separate national health strategies from health plans, we're going to continue to have fragmentation. So do we need to bring back on the table the concepts of an ambitious and bold national health plan? The action required, managing expectations. Countries expected that after they invested in JANs were quite expensive for countries because they were not funded. And the expectation was that the donors would follow JANs and use JANs as a basis for decision of funding and financing and link that to domestic resources. I'm yet to find a country where that has occurred. And so is that something that we need to think about? 4 rounds of IHP Plus results, and there is a 5th round going on. The suggestion that across all the 4 rounds is that countries have actually done everything they need to do. They have been asked to do. They have done JANs, they have done new systems, they have done new strategies, but the donors appear to lag behind that in responding as agreed. So, for instance, public financial management systems were supposed to be developed, and countries have done that, but donors have not used those public financial management systems in their disbursements. So we might need to look at that. Civil society engagement and meaningful civil society engagement in IHP Plus as it reconfigures itself. It's very exciting to have the name IHP Plus for UHC 2030. Is that configuration the best configuration for a movement that is going to take forward the assets and is going to actually hold donors to account? Could that be the best configuration? I think not. But if it is going to be, it's going to need to rethink how it does things with civil society in a totally complete way, so that the IHP Plus results don't end up in shelves, and this report can be used by civil society to create energy and a movement. Then I looked at the last one and says, well, IHP Plus should transform from what it was before, the health part of MDG 8. It should become the health part of SDG 17, which is the global partnerships that we have. And so in mobilizing domestic resources, what's the role of IHP Plus in working with governments, not restricting it to public sector mobilization of resources alone, but also looking at private sector mobilization of resources, innovative pooling of philanthropy and community giving and charity. Multi-sector action for health. What is that multi-sector action for health, and where does it occur at the global level? Some say it should occur within the UN. Some say it should occur within the WHO. If it's going to occur within WHO, is IHP Plus 2030 the place for it? Health and human security. Again, a new concept and a new priority we need to take forward. And finally, accountability. Accountability in the new dispensation is going to be very interesting, because if domestic financing is going to lead accountability, we are not going to be, it's not going to be business as usual. Governments are going to ask for accountability of partners, citizens are going to ask for accountability of governments, and we're going to need to rethink the way we are looking at accountability. Is IHP Plus 2030 the best place for that? Probably, but I think we need to keep talking. Thank you.
Thank you very much. Thank you. So I won't be now aid effective, but time effective. So I'll cross to Dr. Isaac Adams, Director of Research, Statistics and Information from Ministry of Health, Ghana. Now, Dr. Adams, Ghana was one of the pioneers of swaps, and we know that evidence shows that swaps decrease transaction costs, decrease duplications on the ground, increase some equity and sustainability, and influenced positively aid effectiveness. Now, you did swaps before IHP. Now you're a middle-income country and a regional pioneer of social health insurance. So it would be very valuable if you could present us how did IHP principles helped you to move forward to being a good example in practice. And what are the lessons learned that you can share with us from this process for other countries? Thank you.
Thank you very much. Perhaps what I'll do is to put the country's experience within the context of the 7 behaviors. Let me start off by saying that once we all agree that domestic funding is very important, we also need to understand that perhaps funding from our partners and our agencies are also very important, depending on the way it is managed. Ghana in the mid-1990s, that's almost about 20 years ago, saw the need for us to coordinate development assistance within the health sector, and that led to the sector-wide approach And for those of you who may not know what the sector-wide approach is, let me reduce it to the simplest terms. It's about putting all our resources into one basket and developing mechanisms for managing that basket. And fortunately for us, we were able to do that for a long time. Issues of sustainability are still big questions that we are trying to answer. The common pot is not there anymore, but the structures to manage the common pot is there. And perhaps our experience has to do a lot with what we are going through with these structures that we put together. One of the things that we noticed during the swaps was the phenomenon of what we call earmark funding. That most of our partners, if not all of them, even though they contributed to the common basket, also held onto substantial resources that they call earmark funding. The earmark funds were used at the discretion of our partners, and there's a lot of debate around that. I would not like us to enter into that kind of debate now. But it presented a lot of challenges for us, and those challenges actually inform our current position on donor funding as a country. There were changes along the line during the swaps. Our partners, for instance, could decide whether to contribute to the common pot or not. The discussion with us were very minimal, and sometimes it happens with governments on the blind side of the Ministry of Health. So most of our partners, for instance, moved into multi-donor budgetary support without the proper consultations with the Ministry of Health. That, again, is another signal that I would like us to keep in our minds. There's also the situation where you have a lot of agreements worldwide, global agreements, the Paris Declaration, the Accra Accord, all talking about aid management. But whether our partners actually, I'm trying to be careful about the choice of words, but whether our partners actually agree to these declarations is a big question. Because we have these, we've all signed on to these agreements, and yet some of the issues that we claim or we see as part of the 7 behaviors are still not being adhered to. As of now, in Ghana, government is the biggest funder of the health service. We pay our staff, we pay for services, we buy the equipment that we need, and in fact, we enter into loan agreements to even fund some of these agreements. The important thing is that even though aid is coming down, it still has a very significant role to play in service delivery, sometimes because of the way it's structured. Sometimes it's all the way down to the district level where services are provided. And so it creates a lot of challenges for us. But to perhaps to cut short my presentation, I think that it's important. Aid is important, still important in the drive towards UHC, and it's important. It's only important if we look at it from we critically take a look at it. First, I think that we should, as a group, understand that or agree that aid, in whatever form it comes, should not or should be non-replacement. That is, it shouldn't replace what government provides and what other sources that we have for funding. Sometimes the danger is that once, depending on the way it's presented, it tends to replace what government puts in the system. it should not be disruptive. And I can tell you that a number of the assistance that we have, at the end of the day, tend to be a bit more disruptive than helpful. Sometimes monies come in with additional change of structures that we cannot even sustain when the assistance is withdrawn. I think that aid should also not be parallel. It should be supportive, but not parallel. Sometimes you go into a district and you have our 3 or 4 different donors running the same program, malaria program, for instance. You have different pots of funding, pushing towards the same program, and we think that that is very disruptive, and it should not be selective. We think that the governments have their health agenda, and all support should follow that agenda. Perhaps this is what I can say for now, and then we can take some of the issues in the discussions.
Thank you. Thank you very much. I immediately wanted to ask you to elaborate a bit more on what you just said, but let me firstly give the word to Dr. Van Dien, and then come later during discussion. I guess our colleagues will have a lot of questions. So what are your observations in Cambodia on the relevance of the IHP principles? What do you think needs to change going into the UHC 2030 area?
So thank you very much giving me the opportunity to share the Cambodia's perspective as well as the experiences that we have gone so far. If we talk about the effective development cooperation and the UHC 2030 role in it, in Cambodia, the new health strategic plan, HSP3, also focuses on people equitable access to quality of care without financial hardship, which is the basis principle of the UHC. UHC is about ensuring effective coverage by all diseases and public health programs with a notion of financial protection. Therefore, UHC is not only the health system strengthening, but it needs to have other attributes such as quality, efficiency, and accountability. If IHP Plus for UHC 2030 is meant to bring stakeholders working on HSS, there are already existing mechanisms and platforms for coordination that can be used to broaden the focus on whole health sector for harmonization, alignment, and strengthening development effectiveness. To realize the principle of effective development cooperation, 7 behavior change should not be on paper only. Action needs to be done to support country-led processes, strategy, and plans. In terms of operationalizing UHC 2030, it is not clear for me how this forum will help the country, whether we should spend more resources on global meeting and conference, or putting more resources to help country on achieving this UHC by 2030. Unless the UHC 2030 will have a power to influence the 7 behavior change, a little real impact may be expected. What the UHC 2030 can possibly do is to bring different donors and partners working in vertical program and have them commit to support HSS based on country plan and provide funds to support the countries. In Cambodia, we have Technical Working Group for Health, Technical Working Group for Health Secretariat, for Government and Health Partner Coordination, and health partners themselves have a monthly health partner meeting chaired by WHO and USAID, as well as other working groups focusing on different themes, including health financing aspects. UHC 2030 may play a role to promote result-based partnership, focus on strengthening the technical working group, serving as the principal mechanism for coordination and partnership dialogue, in which the joint monitoring indicator prepare to address both the managing for development results and the mutual accountability principle of effective development cooperation. UHC 2030 may play a role also in promoting efficiency in compliance with global commitment made in Busan Declaration 2011, with the effort of using country system, including the recognition of the role of private sector, non-state actor, South-South cooperation, and NGOs. In Cambodia, recognizing the important role to be played by its development partner, the Royal Government of Cambodia has formulated its Development Cooperation and Partnership Strategy 2014-2018 that identify the effective working arrangement, principles, and tools that are required to facilitate development effectiveness and result-based partnership among a wide range of development actors, including provider of ODAs and other forms of development finance, South-South actors, the private sector, and NGOs. Looking at the discussion held during yesterday and today, I think Cambodia moving on the right track, and I would like to express my sincere appreciation to our all partners that have been working jointly with our Ministry of Health. And now we are moving forward to the D&D, decentralization and deconcentration. So this, what does it mean? Empowering and capacity development of provincial and district management level, plus community participation and resource allocation to support capacity building. At this level is a very important element to be considered, which is a big challenge for us, especially in the time of progressing the expansion of health coverage to the target group of population, example, health equity fund for the poor. So thank you.
Thank you very much. Very interesting what we just heard from our three panelists. It's a kind of reality check showing us that there is still a lot of work to do, that we all jointly should work on in terms of improving effective development cooperation. Now, the fourth panelist is Mr. Heiko Warnken from BMZ. What do you think should be done? What are your experiences after having heard yesterday's panels and today and informal lunch break discussions? What do you think we can do better, and how to finally start to walk the walk and talk the talk?
Yeah, thank you very much for giving me this opportunity. I agree. I think what we heard this morning and now, I think clearly shows that there is still a need to stick to the IHP 7 behaviors. They are still valid. And unfortunately, I have to say, what I heard today, I think is really disheartening. When I see what has been reported from Guinea, for example, from Dr. Jan Sané, I think this is kind of shocking to hear that we still need harmonization, that we still need alignment, that you are not really sitting in the driver's seat. This is what we have all agreed upon in this Paris Declaration, and the Paris Declaration, unfortunately, is from 2005. So what we need definitely is, first of all, a long breath. It's a marathon that we have to run here. It's not a short distance. What we try to really do is to walk the talk. How can we concretize all these actions, all these areas that we have covered yesterday and today? And there we hope that this roadmap that has been mentioned also by Agnes Suka in the previous session, hopefully will be helpful. The idea is that all the different organizations, the bilateral donors, the multilateral donors, the funds like Gavi and the Global Fund, but first of all, definitely the partner countries, all the countries, will stick to certain principles. And when you look into to this paper, I will just read out what has been mentioned on public financial management, because you will find a lot of things that had been mentioned here by Max and Marjolaine. Only one point, because it's not only about principles. The roadmap idea is also to formulate some concrete actions, which will be then also later on, of course, measured. And one of these actions in the field of finance is, and now I quote, develop joint approaches to support financial management systems, including use of joint assessment tools. This is what we have discussed in the previous session, and design and management of pooled funds. So that is the point of the swaps, for example, and joint baskets and so on, aligned with national public financial management systems. And you find many, many other concrete points that has been discussed. So the idea is that we have now already in May, at the margins of the World Health Assembly, we have agreed on this first draft of the roadmap, Healthy Systems, Healthy Lives. Now we are entering into a new consultation phase until December. I hope that we might have a chance to have a kind of ministerial meeting on the UHC day on the 12th of December, and then we can finally launch the roadmap, because that later on will help us to really be very concrete. And for example, when we are working, we as a bilateral donor and a contributor to the Global Fund, that we can remind the Global Fund to be very concrete on all these different specific issues, and we can develop together indicators. Of course, we also have to do the same bilaterally in Germany, but I think it's also good support for the work in the countries and for the countries, because many other underlying issues are also addressed in the roadmap. There was a lot of mentioning of the supply chains, for example, cold chains, that we are not using only disease-specific logistical supply chains, but we use the systems for all the different diseases. The same is true, I think, health workforce yesterday evening, I think, was clearly mentioned, and many, many other items. Also, domestic finance was addressed again and again. So unfortunately, I'm afraid, even after more than 10 years, we still have to bring together the IHP world and the health world. And you were also addressing talks in the coffee breaks and so on. I was reminded by Jacques that what is different perhaps now is that we are now in the SDG era. And I think what is important in the SDG era is that we no longer, fortunately, have this north-south divide, but we are really working together. So it's really, it's a common framework, and I think this perhaps we have to think about all together, how we take it on board in the IHP. It's no longer a donor-recipient role, but we are all in the same boat. Thank you.
Thank you very much. I will immediately open the floor to colleagues for questions. I see the first one there, 2, 3. So let's start.
Thank you. My name is Jacques Madère, Global Program Health Swiss Development Cooperation. Well, I hear that for the countries or the representative of the country that development aid or development cooperation remains very important. I would like to know a little bit more, what do you expect? Because I think there's a certain disconnect between the so-called donors and the implementers or recipient, whatever you call, regarding Paris agenda. Because the reality is that the sector budget support is going down, the overall aid is leveling, and a lot of the aid remains earmarked. 60% of the aid goes for HIV, TB, malaria, maternal health, and children health, and it's earmarked. So that's a hard reality. So I would be very interested to hear, what do you expect? What can we change? Not that we are in this SDG period where we should really have a joint commitment to the sustainable development of health. What do you expect? Thank you.
I suggest we collect a few questions and then. Okay, the second one? Yes, please.
Thank you. I think people have made this reflection already that while some donors may have improved some of their behaviors in some ways, on the whole, there has really been very little commitment. There's no serious commitment, I think, from most bilateral donors or multilateral donors to improving the way that they deliver aid. And I'd kind of like to ask the panel, maybe Marjolaine, perhaps particularly to you, about whether the problem is simply the whole paradigm that we're stuck in. You know, we all can take a step back and critique the problem of voluntary donations controlled by an external government having an impact on a recipient country's health policies. And so isn't the task for the next period actually to put aid back in its place, which is a minority of health spending, and to be much clearer? You know, yesterday everybody was saying so clearly domestic resource mobilization is the agenda for universal health coverage, and that aid, a small part of it, must fit into that. So I'm not in any way decrying that we need to keep trying to improve donor behavior, but, you know, aren't we sort of flogging, this British phrase, flogging a dead horse in some ways, and actually let's get on the main horse, which is really governments taking on their responsibility, taxing people as fairly as they can, spending as much as they can, and standing up to donors and only accepting donor money when it fits with their priorities. And it's the governments that can say no to donors that are the ones that actually are showing a lot of the better progress in universal health coverage.
Thank you, and let's take one more question. Please.
I was just looking at, I'm Samuel Ogilo from Tanzania Private Health Sector, Association of Private Health Facilities Tanzania. I was looking at these 7 behaviors, and they look, they're good, but they look, they're at the national level, at government level. And means the government utilizing their resources well. But as I'm trying to look into it, I don't see where the other partners come into play and mechanism to encourage others to come in and play. Just one example. About 10 years ago, we had what we called human resources for health crisis in Tanzania, where we had less than 35% of the required qualified staff within the country. So it was a crisis. And everyone was trying to do something, but it seems there were no resources. So somebody looking at all these 7 behaviors, some external forces had to come in. And so we had to create better policies and environments to bring other players to come in. I remember I worked for about 1 year encouraging investors to invest in healthcare institutions. As we're talking now, over 60% of human resources for health are from the private institution, medical institutions, within 10 years. So I think we need, something's lacking there. Oh yes, we can build these capacities, but also we need to see a link with other non-government actors coming in and showing prominently on how we are going to have these behaviors. Now, talk about behavior. We know the policies that we have in different countries, the political alienation, and also how government work. We needed to allow other actors to come in, other than what we are going to work with. Thank you.
Thank you. I'll immediately pass on for the first question. I think it was Dr. Adams. Yeah, you can. Yes.
I think Donna will help, but let me attempt. I think that it's a very difficult question to answer directly. What is our expectation on the future of aid? I think that aid is still important. It needs to be put in perspective. Let me give you an example. We've had problems with our information management systems. And anytime we call on support to build our systems, the investment goes into buying computers. But computers don't produce health information. There are people who need to be trained. Systems need to be built. And yet partners refuse to support that area of capacity building. A lot of the aid that comes in, do not directly build the capacity of those who run the system. It's about providing material support, sometimes, to the detriment of the system. And that's the kind of approach we are looking at. That's the kind of dilemma we are in. We need to restructure such that it doesn't, like the 4 areas I mentioned, it doesn't become disruptive. It doesn't become a replacement phenomena for our government funding, and it doesn't become a parallel system. and it doesn't become a selective system. What it needs to do is to support the health program of the country. And I think that we've had that experience in Ghana when we were developing our first 5-year program of work. So Ghana now has a series of 5-year programs of work. What DFID did, oh, I'm sorry I'm calling, I don't know whether I'm supposed to call any names, but what our partner did at that time, you didn't hear DFID, did you? No. What our partner did at that time was to provide us with resources, go ahead and build your system. They did that without knowing what the outcome would be. And I thought that was very, very instrumental. They did that without knowing what the outcome would be. And at the end of the day, we had our first national medium-term health strategy, which is continuing. I mean, that's the kind of approach we think that we should be looking at in terms of building systems. Build the capacity for the system, not buy things for us.
I would respond to both Simon's question and your question together because I think they're related. We have moved from miasma to social determinants of health, but our funding mechanisms have not shifted in the same direction. And I think aid is still being implemented as if we're managing campaigns and we're still in the period of miasma. But we're in the period of development cooperation, and a lot of the determinants of health are no longer they're no longer responsive to siloed funding to end an epidemic or to remove yellow fever or to end smallpox. So as we have shifted as economies, we have shifted in epidemiology, the funding instruments are still very much behind that shift.
We don't have time, I'm sorry. Now, let's move to the second question.
Does it work? Yeah. Thank you for the question. Well, as an advisor, I couldn't agree more. And actually, yesterday, WHO presented its approach to development cooperation and this FIT model. And it's about this. I mean, it's about looking how to make the best use of development cooperation depending on the country context. I think we have something to start with. So I hope that within UHC 2030 we could have also a more strategic conversation about also the evolving role of development cooperation, taking into account different contexts. And from another perspective, I hope that we can also have another look at the overall aid architecture, and I will ask my colleague to put a slide that I had to dig out from a long time ago. And it's disheartening, it's sobering. I mean, it's where we were maybe 10 years ago, and I think it's still a lot more complex today. And we should revive these principles of think twice before creating something new.
Brief, just also to combine perhaps the two questions from Jacques and Simon. There's one principle in German development cooperation that was there all the time and which is really absolutely crucial, and this is country ownership. So we are only responding to the request of the partner countries. So it's up to you, to the countries, to tell us what to do, and it's not us to tell the countries what they should need. So tell us, please, also about the principles. So please tell us that we have to coordinate ourselves. When I was more than 10 years ago in Kenya, there was a donor-led harmonization, alignment, and coordination group, and the government was a little bit reluctant to be involved in all this exercise. It should be the other way around.
Thank you very much. I'll just add to this that according to 2030 agenda, yes, South-South cooperation, so we need to see how does South help to South and not the old paradigm of North-South. So the partner countries are the owners of their development. We align to their multi-annual indicative planning. We align to their priorities which they choose for multi-annual development, at least from to put on a positive side, just on behalf of the European Union. What we do is we have put very highly on agenda joint programming,
which means that we as a donors, as 28 donors within the European Union, 28 member states, embark on joint programming and division of labor among us when we go, when we visit the partner countries. We also support the WHO through our health system strengthening and technical assistance to WHO to work better and to support them with technical assistance on the country level. So there is a progress. Of course, lot needs to be done, and absolutely we need to sit together and discuss rather than being on different sides of the table. We are all at the same side of the table. So are there any more questions? We will steal at least 2 or 3 more minutes because we started later, 10 minutes later. Not my fault as well. So is there any, yeah, please.
Thank you.
Short, very short, please.
Very short. Okay. Tim Rosen of Action for Global Health. I wanted to ask a question to the panel on how you see to integrate the good use of available resources and therefore avoid waste. I mean, there's a Ritual report in 2010 that referred to up to 40% of waste. But then I wanted to refer to an initiative taken by Transparency International to tackle corruption. And so I want to ask, how do you see corruption/good governance included in the principles that were discussed? Thank you.
This question is whom would you like to reply to this question? Thank you. We had a question there.
OECD, and I just wanted to come in on this question of ownership and coordination and harmonisation. It only gets us so far to say, you tell us what to do because you don't do what you're told to do. This slide, I think, was put together 10 years ago. I would imagine there are at least 4 times as many partnerships in that. I think it's one district in Tanzania that represents. And actually, if you look at it, you'll see there's foundations in there, there's private companies in there. It's not just the donors, it's an unwillingness to be coordinated writ large. One of the lessons we learned from the evaluation of the Paris Declaration was that if a government passes an act in Parliament, an international aid act, that has more traction to get donors to agree to be coordinated. But it's a much bigger problem than just saying, oh, AID's irrelevant now, and anyway, those guys ought to coordinate themselves. The power of the donors in the governance of all these entities in this room is very strong. What we're trying to do in the OECD is come up with a measure which goes beyond aid. It both makes aid less the issue on every table, but it also looks at how we incentivise good behaviour among other groups who are also involved in this huge complexity, which if we can manage it, we can get a great deal of resources and knowledge and really help achieve universal health coverage. But at the moment, everyone's tripping over each other, and we can't just dismiss that. So we have to do something about that.
I see that this topic deserves much more time than we have. So let's just try to, the first question, any? Yeah.
Is this on? Okay, perfect. On the question of efficiency, there are a variety of areas where efficiencies can be gained. One of them has to do with PFM, which I just did a presentation on. If we have a scenario where donors are jointly supporting the country system, I think that it creates an opportunity to tackle some of the bottlenecks that exist in the system that causes inefficiency. So that's one way of enhancing efficiency and the use of resources that are available. Now, on the question of corruption, as we've all heard over these past 2 days, we've said that UHC requires a multi-sector approach. So whilst this issue of corruption is not only limited to the health sector, it will be important to acknowledge the role of other ministries, such as the Ministry of Finance, which has sort of a bigger role in terms of overlooking the macro PFM arrangements and helping to put in place measures that would address issues of corruption. So I think in this particular case, I see health partnering with other ministries, such as the Ministry of Finance, to tackle the issue of corruption more broadly. because it will not be limited to health. It will be a systemic issue that would have to be addressed across the board.
Any other comment? No?
Please. Corruption is important. Stronger governments make sure that there is no corruption in aid and there is no corruption in domestic financing. Efficiencies are important. Alignment would improve efficiencies, and domestic finances should not inherit the inefficiencies of donor funding.
And I think that the issue of accountability is also very important. Perhaps what we have developed along the line is holding governments and recipients accountable to the aid that they receive. I think somewhere along the line, we also need to sit with our partners to determine whether the areas that they intend to support, whether they are achieving the results that they are aiming at. That form of accountability is also very important for us.
Thank you very much. I think this discussion shows us how important this topic is and how much more time we should dedicate to open discussion on how to dig deeper into it, especially as Dr. Van Dien said about your program on decentralization, deconcentration. It makes me think of the impact of aid effectiveness to subnational level, which opens a lot of arenas for discussions. So I need to close here. I'm already threatened by our boss for right. So thank you very much all. Thanks to panelists, and please address your questions during the coffee break or after this presentation. Thanks a lot, or later, whenever. Thank you very much.
Thank you. Thank you all. The good thing is that this conversation is not over, and that the session that this is leading us to, which is another quite tight and quite short session, is continuing the conversation around effective development cooperation. Is David here? Hi. And your name is on the panel list, so please come, not just yours, all your panelists, please come on already. And this session should get us to think more specifically around the areas that can be improved around EDC. So, David Evans, I will let you take it from here.
Thanks very much. Can I just have one housekeeping thing first? When I was walking in, I stumbled over a little case with name cards in it. And so if you've lost it, can you please come and get it from me? If you're a donor agency and you've lost it, it's going to cost you. But otherwise, please come and get it. I was really worried about this session because I've got a very difficult task. And in fact, I was so worried this morning that I forgot to put my tie on. So I hope you forgive me for that. But what we've got is we've been allocated 1 hour. It's an important topic, and we've got a lot of people with a lot to say. So we need to give you time to reflect on some of the important questions. What I want to do is we want to say, okay, what is this transition from low to middle income status? What does that entail? And why is it an issue? Why are we concerned about it? Because as countries get richer, they can raise more money. That's great. At the same time, as they get richer, their eligibility and their possibility of getting external assistance and development assistance for health in some cases declines. And we've also got the idea now that a majority of the world's poor live in middle-income countries. So how do we make sure no one's left behind in this situation? This third question is, okay, if it's an important question, should UHC 2030 be worrying about this? It's got a lot to worry about. We've heard a lot over the last 2 days about very interesting topics. UHC 2030 shouldn't get so diffuse that it does nothing. So is this one of the issues that UHC 2030 should focus on? So without further ado, let me turn for an introduction to Dr. Ariel Pablos Mendez, who's the Assistant Administrator of the Global Health Bureau in USAID. And in fact, he's one of the reasons why universal health coverage develop from a nice idea into a really global movement. So Ariel is just going to introduce the topic. He's the only one with slides. I hope no one else has brought slides. And he's going to give you a brief introduction to the topic, and then I'm going to ask a specific question to each of the panelists before handing it over to you. So thanks very much, Ariel.
Thank you, David. And it's great to be in this session. Indeed, UHC has become a movement, and it's important that as we think how to create platforms, do not forget there is a more complex social process that we need to maintain and support and nurture. So that's whatever structure of the alliance comes out is in deference to that movement of the countries themselves. Can we have the first slide, please? Oh, I can actually do it myself. Very good. Okay, so this slide, which as we have gone through a financial crisis in our generation in OECD countries may seem a bit not quite with the theme. The fact is that when we look at the history of humankind, income per capita had been very low and flat forever. I mean, the world was poor. Despite some ups and downs, some places, the average was really flat. But in the last 50 years, there's been truly an explosion of GDP per capita. In preceding China, it goes beyond China. It's quite significant. Even during this period, in the last 10 years of a financial crisis in OECD countries, in the 30 countries where USAID has greater focus, poor countries, all of them, 30 of them, GDP per capita has been growing at 6% per year. So that this phenomenon is a very important part of what the new era in health financing is. So that since 2000, half the countries that were in the low income category had now moved to the lower middle income and middle income category, right? So the bottom part, the poorest countries are half as many now than in 2000. And one of the things that happen when GDP grows is that health expenditure also grows. And that's good news, bad news for the rich countries which are struggling with health expenditure, but good news for the rest of the world that as they grow economically, health expenditure actually grows faster than the economy and begins to contribute a greater proportion of their economies to the health sector. And as you can see from these slides, it happens in a very narrow band. That is, the R-square of around 90% is truly amazing, and there's no other policy or any other criteria that I'm aware of that adds statistically to this regression. So that, as you can see in this slide, you can identify countries there that have universal health coverage and countries with no universal health coverage, or we have universal coverage. They all spend what they're going to spend given their economy. So an important point here is organizing financing for universal coverage is not in itself a cause of increasing health expenditure in a country. And this sounds almost magical, but the data backs it up. It's how you organize your resources at each stage of development that matters. And in fact, waiting too long for that when the political hurdles and the fiscal hurdles grow makes it even more difficult than organize yourself early on. Now, and I think I heard this point earlier, as you can see here, countries in lower middle, you can see them, the World Bank sort of spread of the columns here, and then of the total health expenditure, how they distribute these. And as you can see, in the low-income countries where the donors account for about 20% of the total health expenditure, but half is already out of pocket. And as countries grow economically and the ODA gets either diluted or progressively withdrawn, unfortunately, governments do not grow commensurate with the surging demand for health. And as a result, you see an explosion of unregulated private provision paid out of pocket. And as you can see, the red part grows, what I call the ditch. And all countries, as they move out of the low income to the middle income, are condemning themselves to this ditch, which we're suffering because we know out of pocket is inefficient, regressive, and the #1 cause of impoverishment, unless governments can understand that they will have to increase their budgets for health or see their sector just be morphed into something they may not want. It takes a whole generation before they begin to reassert themselves back, as you can see in the upper middle and high. And then private insurance comes into the place as well. This is to be a typical thing, but important thing is countries should be prepared for this ditch, and the only way to avoid it is either increasing the public financing or regulating private insurance, which in many countries is not the preferable option. In USAID, we see, of course, the current situation, which is, this is one of the columns now put into a donut, and we see donor dependence, domestic pool expenditure, out-of-pocket distribution, and what we want to see is, of course, decreased donor dependence. That's happening already, regardless of IHP+, because of the economic growth of the countries. If the country's GDP has grown in these 30 countries at 6% per year, their government health expenditure has grown at 10% per year. And ODA is flat. So you can see how we are being diluted by the minute right now, and this is a new reality. And so I think IHP+, right, they worry too much about the shrinking proportion of 10, 20%, 5%. We should be helping countries understand this big transformation of the health economic space and reach a place where they do have less donor dependence, increase domestic pool expenditure, particularly public, and in doing so decrease the out-of-pocket expenditure. And in USAID, with that, we have been developing several initiatives. Clearly, the Addis conference last year, we put forward, the vision is domestic resource mobilization, but we are looking at many efforts. With PEFAR, actually, we're investing in tax administration capacity. It's hard to ask the Minister of Finance to put money if you don't help them raise more money, or the Global Financing Facility, the investors group of which is meeting tomorrow, a way in which governments can borrow concessionary loans to invest in the health sector. All of these are, and there are private initiatives, innovative financing, so many of these, but the most important is really pooling resources, public resources in particular, and that's why I think the world has been not only out of an aspiration for social justice, but actually as the right economics prescription, the right health finance path is to move to universal health coverage as the ultimate frontier for global health. And I want to thank Sinia, who helped me produce this slide with about 50, 60 countries which are more or less have universal coverage, another 50 or 60 that are halfway there, but many more who are asking. UHC should not be in a super ambitious thing. It's just the natural thing that we need to do. Organize the resources, is equitable, but it's also efficient at the same time. Thank you.
Thanks a lot, Ariel, for the introduction. Let me now turn to the panelists, and I'm asking specific questions on initially on the policies of large sources of external funding for countries in transition. So let me turn to Jona Jurlink, who's the Senior Manager of Public Policy in Gavi, with the question of Gavi has an explicit strategy on graduation. Can you tell us a little bit about what it is, please?
Thank you very much, David, and thank you all. As this is the first time I speak from this podium, I'd like to take this opportunity to thank all for a very inspiring and enlightening debate these past 2 days. You may be aware of Gavi's transition policy, which at the heart is our co-financing approach. It was created in 2006, where we request our partner countries to pay a portion of the vaccine expenditures based on their ability to pay. And with the growth of GNI of these countries, these portions gradually increase. So, for example, we look at low-income countries where we have a cutoff of 1,045 GNI, who pay 20 cents of the portions of vaccines, and then when we move to phase 1 of our early transition phase, those countries under their cutoff phase of 1,580, those increases are gradually increased by 15%, and then the countries enter the accelerated transition phase, where over a period of 5 years they are brought up to a full 100% of covering the vaccine costs. Once countries are transitions, we have agreed with the manufacturers that those countries can continue to access the Gavi prices for another 5 years to smooth that transition process, to make it not as an immediate strong cutoff point. And we've seen great successes in these stories. And what has been interesting in our discussions with countries in these transition phases is that it's not just about the fiscal space. It's often the countries who are more interested about ensuring access to affordable prices and how Gavi can continue to help to leverage its influence with manufacturers and influence markets further to make access to immunization affordable. But it's also about political will building. How can we ensure that we have the support and the institutions there ready to continue the efforts and the progress made over the past years? And therefore, our partners are extremely important because it's not just Gavi, the Secretariat, it's Gavi, the partnerships. So our CSO, for example, we've heard some great examples in Nigeria who helped to secure co-financing in Nigeria. But of course, our approach to health system strengthening, again in collaborations with our partners, is where we more and more take an approach and sustainability lens to ensure that we invest in the right areas and the right places to make sure that those countries are ready to take on the immunization efforts once transitioned out of Gavi support. Thank you.
Thanks a lot, Jona. So Gavi has a strategy, but there's also work with countries to help smooth that transition. Let me turn to the Global Fund now, and Michael Borowitz, who's the chief economist of the Global Fund. Michael, does the Global Fund have a strategy? What's its approach to this transition issue and the availability of funding from the Global Fund?
So thank you, David. I mean, historically, the Global Fund had not had a formal policy on sustainability and transition, but just this April, the board finally approved a new policy on sustainability, transition, and co-financing. So that policy draws on a lot of the experience from Gavi, and we've worked very closely with Gavi, but also from the experience of many other partners, including the Bill and Melinda Gates Foundation's project on Avahan in India, which is very applicable to the Global Fund, which is around funding high-risk populations in India. I think one of the things that we've learned from both Gavi and the Global Fund and other partners is that this process of planning transition takes time, actually. And so we're presuming that it's going to take on upwards of a decade. And so we now are projecting that when countries might transition from the Global Fund by component, meaning from HTB or malaria, and then we are starting to work with countries on transition. So we've developed a transition readiness assessment that would then actually help determine what our future funding would be. And that actually changes a lot of our policies also about health systems, because obviously critical health systems roadblocks, say for example in procurement and supply chain, would now be eligible for Global Fund funding. It's important to emphasize that the Global Fund eligibility includes both GNI or income and also burden of disease. So unlike Gavi, our eligibility requirements actually vary by the burden of disease. So upper middle income countries like South Africa are still eligible because of their extreme burden for HIV/AIDS. So we're not expecting to transition from many of the countries that Gavi transitions from. But having said that, there is a complex donor kind of participatory process with countries as you graduate from Gavi but are still receiving Global Fund money, and also that your allocation might decrease from the Global Fund. And so we've been increasingly working with partnerships with WHO, the World Bank, and Gavi to try to smooth that transition. And one of the countries that we've been doing the most work on is Indonesia, where I think we've made a lot of progress together in trying to work together with the government and with civil society to smooth that transition. I would say that the particular issue for the Global Fund is a bit more complicated than Gavi, because it's not just about commodities, it's about complex interventions like with civil society. And one of the particular challenges that we have at the Global Fund is contracting with non-state providers or with civil society organizations, which is often a critical roadblock to sustainability of Global Fund programs. And we will be starting a new initiative on what we're calling social contracting to try to solve that. But I think this is something that requires a lot of coordination. We also have a partnership with PEPFAR and UNAIDS, because I think that a lot of the PEPFAR countries, although not transitioning in the near term from the Global Fund, actually do face a significant decrease in global financing from both PEPFAR and the Global Fund. So.
Thanks a lot, Michael. So there is a new strategy. it's got more components to deciding when countries transition than the one we heard from Gavi, and there's a perception that this is going to take longer in some countries than in others. So it's a more it's not more flexible, it's a flexible type of approach to helping countries adjust to the transition. Let me now turn to the World Bank. And the World Bank is another agency that provides funding and also has the low-income to middle-income status is a World Bank categorization. So what happens in the bank as countries transition from low to lower middle-income countries? Magnus Lindelau is the practice manager in health for East and Southern Africa. Thanks, Magnus.
Thanks a lot. Yeah, so the first thing I guess to note on the World Bank is that in terms of our the transition issues, that the bank's support is not health sector specific, but it cuts across a host of sectors. We have two windows for financing. One is IDA, which is concessional resources, grant or concessional loans, and then IBRD, which is non-concessional lending. And there are two criteria that we look at in the what we call the graduation process. One is GNI per capita. I think the latest is around $1,200. But also the creditworthiness of countries. So even if you pass that criteria, but you're for whatever reason the country does not have creditworthiness to be able to access funds, they can continue for beyond that that cutoff, receiving IDA funding. Similarly with other agencies, there is of course a concern about when there is a graduation from IDA to non-concessional lending, that there will be a reduction in the access to financing for those countries. And this is something that there are various ways in which the World Bank is working with countries to mitigate. And it's a process that is a phased and gradual process that typically runs in a period of 7 to 10 years. So similarly to the sort of decade that was mentioned before. And partly by facing the steps of blending IDA and IBRD resources, partly by considering a broader set of criteria in making the final step towards graduation, so macroeconomic conditions, political risk, etc., are all factored in into the final graduation decision. And in some cases, there are opportunities for transitional support where IDA resources are extended beyond if there is a significant concern about a drop in resources. These criteria and the implications for countries is something that is reviewed regularly as we replenish resources. It's an issue that regularly comes up. It's reviewed, it's assessed. There haven't been significant changes, and the assessments have concluded that there wasn't really a need for that. Although there has been a recognition that there is a need for coordination with other partners, multilateral development banks and agencies. Having said all this, I think there's also a recognition that beyond sort of the bank's general approach, there are sectoral vulnerabilities, and health is clearly one of those. And recognizing that, we are working closely with Gavi, Global Fund, and others to look at not just on the financing availability of resources side, but also some of the issues that Michael pointed to on sort of institutional sustainability, of transitioning from parallel implementation arrangements to something that is government-led. And we have currently various mechanisms of collaboration with others to kind of both in terms of assessing and understanding these issues and supporting countries in making these transitions. Thanks.
Thanks a lot, Magnus. So often when, as an outsider to the bank in my youth, I used to think that when a country hit low income, when it moved from low income to middle income status, that was it for the IDA, the concessional loans. But as we've heard from Magnus, it's much more complex than that, and there's a lot of flexibility around how that transition occurs and how countries are helped through the transition. So we've heard enough from external partners and sources of funds. I'd like to turn to Caroline Moeni, who's the Deputy Head of Aid Effectiveness of the National Treasury of Kenya. Kenya last year moved from low-income status to lower-middle-income status. So what does that mean? You heard from Ariel that low-middle-income country status gives you more opportunities to raise more domestic funds for health. Is that the case? And is it what is the possibility of losing concessional sources of funding from other sources of development assistance to health? What is the impact on Kenya?
Thank you very much, David. Firstly, as he indicated, we graduated to a middle-income country. And in addition to that, based on the FFD event that took place in Addis, there is a change in landscape whereby most of the financing is become scarce and it's dwindling. So therefore, as a country, we saw the need of having innovative and sustainable means of domestic financing. And in that, the government of Kenya has gradually allocated or rather increased funding in the health sector to ensure that the health financing strategy is aligned to the UHC. Based on our strong leadership and ownership on this process, the Ministry of Health, in conjunction with the National Health Insurance Fund based in Kenya and other multi-stakeholders, established a unified framework for management of the healthcare services for the poor, especially at the grassroots. In addition to that, as you well know, our First Lady of Kenya spearheaded and launched a very great initiative called the Beyond Zero campaign, which basically improves the maternal and child health care within the country. And with those initiatives, we have brought in other players apart from the normal or rather the traditional development partners. We have the private sector involved in it. We have the foundations, and basically this has helped bridge the gap when it comes to the shrinking of donor support. Secondly, based on our domestic resources, we are trying to strengthen our tax administration so that we collect much of the revenue that will be used for better services within the health sector. And in addition to that, we are going to encompass the elderly and the disabled groups within the country. In addition to that, or rather finally, being a country that has embraced the devolution and decentralization, we together with the county governments are linking together so that we can have mobile clinics and other health facilities or other expansion within the different parts of the country so that we can achieve the UHC as that has been launched yesterday. Thank you.
Thanks a lot, Caroline. So the government has already allocated something more to health, and there are steps in place to try and think of how to mobilize more domestic funding over time if external funding goes down. So thanks a lot. Let me turn to a bilateral partner now. Ikuo Takazawa is Deputy Director General of the Human Development Department in JICA. What's JICA's view and role in all of this, please, Ikuo?
Is it on? Okay. Thank you very much. First of all, thank you very much for inviting JICA for this important meeting. And as an implementing arm of the Japanese ODA, we are fully committed to promote the UHC agenda globally and also country level. Regarding our kind of principles for supporting the middle-income countries or countries moving up toward the middle-income status, I think we have kind of three basic principles. One is to support policy and institutional reforms which have long-term impact on achieving and sustaining universal health coverage. We have to remember that achieving universal health coverage is expensive, but maintaining universal health coverage is more expensive. And you have to expect, aging of the population, increasing the NCDs, the changing expectation of the populations, and also the technological development. All those have cost implications, and the countries need to be prepared. And important thing is that the countries need to install institutions, solid institutions, to be prepared to those financial implications in the future. So I think there's the opportunity for foreign assistance like ours can come in to support the country effort. And increasingly, we are using loan assistance of ours. For example, in Kenya, we have just extended the loan to support the country's effort to promote universal health coverage, like around the $35 million. I'm sorry, $35 million. And it's, of course, it depends on the currency conversion rates, but and that's the kind of support we are trying to mobilize for middle-income countries. And second principle is to support capacity development of countries, combining both financial assistance and technical assistance, because as I said, in order to promote reforms, they need a substantial amount of financial resources, but they also need technical resources. So we are trying to, as much as possible, to combine the technical assistance and also the financial resources. And then thirdly, I think this is the most important thing, is to try to harmonize the government policies and priorities, and if possible, long-term vision and strategies. In Kenya, there is a government-led coordination mechanism called UHC Steering Committee, where World Bank, USAID, KfW, and JICA is regularly participating. And also in Senegal, they recently introduced what they call a UHC platform. And in one of the first meeting, all the major donors, including like a representative of Global Fund and Gavi, was there. So when the government is taking leadership, the partners are willing to cooperate. So I think that is important movement. And then we are high expectation for UHC 2030 movement to promote those country-led coordination mechanism. Thank you.
Thanks very much, Iko. So funding doesn't run out. There is some funding available for middle-income countries. And Iko also raised the important issue of building the capacity, the institutional capacity to deal with this changing status. So I'll turn now to Aminu. Aminu Magashi is the coordinator of the African Health Budget Initiative, where they try and track government budget commitments to health compared to the promises. And from his perspective, are countries actually moving to provide more for health as they get richer in the countries in which he's moving to? What does he make of all of this discussion? Please, Aminu.
Thank you very much. Let me give example of the Nigeria that has recently joined the club of the lower middle income country. So in 2014, Nigeria joined the lower middle income country. It declared a GDP of about $500 billion US as a GDP for the country. And in 2015-2016 budget to health, which one of the speakers here mentioned, sometimes the budget of the health sector is not commensurate to the GDP. That's exactly what's happening in Nigeria now. In 2015, we have a budget of about 5% of the total annual budget, and this year actually it also shrink down to about 4.1% of the total budget. So this is an interesting scenario in the country, which the political actors are even trying to understand. What is the implication for moving from a low-income country to the lower middle-income country? So one of the discussions we're having in the country is that there's a price to pay. If you move to middle income, there's a price. The price to pay is that, like the Gavi example, there'll be co-financing, and there's also going to be a transition whereby by 2021, Nigeria is going to face full vaccine procurement. And based on what has been happening in the country is not ready for that. And also, I'm sure you're aware of the biggest source of revenue for Nigeria is the oil. And also the oil price has crashed. So a lot of complex situation whereby this transition is going to be very tough, and the political actors are not also aware of all these implications. Beyond the Ministry of Finance, even the Ministry of Health, they are struggling to understand what does this transition means to the health sector, because we have a bigger GDP, but the health sector budget is going down. So now the country now is also thinking towards other alternative source of financing the health sector. So two things on the table is to establish a trust fund and to also improve taxation through telecommunications to see whether money can be raised from these two sources to complement the budget overall and also for the health sector. But I just conclude that there is a lot of panic in the country that we will actually go back to our low income status if we couldn't actually maintain this status of the lower middle country.
Thanks a lot, Aminu, because I think it is important to point out that countries that rely very heavily on the resources sector, the energy resources sector in particular, have much more dramatic fluctuations in the government revenues, etc., and that poses particular problems for this transition phase, that some flexibility is really necessary in this. Let me now turn to Joe Cutsum, who's the coordinator of health financing policy in WHO. You've listened. You've heard that the partners don't necessarily cut off funding. They're helping countries transition. The countries are working to develop sustainable domestic health financing strategies. Is there anything more to do? Are we there in making sure that no one is left behind?
We're done. No, I think there is something to do. And really, I would say we have to open, it's important to recognize two things. One is to recognize that there's a very important health systems issue here, and also to take what is happening with this transition discussion and see it as an opportunity to do things that long should have been done on the domestic agenda. A big issue first is to get the question right, and it's important that we don't treat this discussion of transition and sustainability purely as a revenue issue. Okay? We have to look at it both at the revenue side and the issues of managing expenditures better, being more efficient with the resources we've got. We sometimes say you can't just spend your way to universal coverage, even if more money is needed. So this issue can't be simply framed, and especially from external funders, as saying, well, you know, we're pulling out now, so please improve your domestic resource mobilization so you can keep these programs going in exactly the same form that they have been established. Or the idea that each disease or program needs its own dedicated revenue stream. That is not the way to move. And what this means is, in a sense, looking at the system through what might be called a UHC lens, which is really to say the unit of analysis is the whole system and not the program. So you could see, for example, if you were looking program by program and saying, well, we have a very well-run immunization program and a very well-run TB program and a well-run HIV program, that's fine. But if they each have their own procurement systems, their own supply chain, their own information system, then when you add them all up, it becomes very inefficient and very difficult to sustain at country level. You remember the picture that Max put up in the last session about these very convoluted revenue flows. And I think one thing we might set it as an objective for UHC 2030 is to deal with the reality that there's often an inverse relationship between a country's level of per capita income and the complexity of its financial flows, right? And so we need to really address that. So I think what transition means is that it's an opportunity for reform to get more efficient use of resources in the sector. It's a domestic agenda, right? Critical to this, and something we can really try to emphasize, is to get the objective right. So the objective is not to sustain this program or that program. It is to sustain the effective coverage or an increase in effective coverage of priority interventions. And that might have some implications for how programs are organized. It also requires balance, because sometimes people hear efficiency and think cost cutting. This is not cost-cutting, and the balance that needs to be struck is no compromise on outcomes, but streamlining the way that we get there. And that is really important. Something we're working on now at WHO, doing what we call a cross-programmatic efficiency diagnostic to look at these issues of duplication and overlap across programs. So I think the issue for UHC 2030 is to keep the pressure on agencies, including my own agency, to avoid things like pushing for separate budget lines for their program or their intervention, or having separate dialogues, because we know talking to the Ministry of Finance is very important, so 6 different programs go and talk to the Ministry of Finance, rather than a coherent budget dialogue around all national priorities in health. The last thing, I think, one question that also David mentioned to me was, in this process of transition, how to ensure no one is left behind. And I think on the financial side of this, there's one thing which I think Michael hinted at as well, which is coordination amongst the partners shouldn't mean that everyone has the same schedule for exit and drawing down their funds, or else you're going to fall off a cliff. So one of the challenges, I think, globally is to say each agency might have its own criteria, but there needs to be some adaptation at country level to make sure that there's something that fits with what's needed in the country to smooth this transition. And the last thing I'll say is just that this is the issue of not leaving anybody behind. In many ways is not a financial issue, it's a political issue, right? So we need to have the courage, both again at the agency level, I think it's there in many civil society agencies, to say that you don't talk about universal coverage while at the same time practice discrimination or exclusion. That's not consistent, that's not UHC. So we have to be able to have the courage to say that, including ourselves. And this is a clear role also, I think, for the partnership going forward.
So let me pick out a couple of the points that Joe made to tie it in for the discussion, that we're talking not just about raising money in this question of transition. We're talking about using the resources better. We're talking about keeping a focus on what UHC is about, making sure that there's sustained increases in coverage with priority interventions, with financial protection. But when we're talking about that, something Joe didn't say, but let me add, that we're not just talking about a package of personal services, we're talking about public health interventions as well, the population-based prevention and promotion, the monitoring and evaluation, the crisis preparedness, etc. So let me now turn it to the audience, and thanks again to the speakers for keeping very closely to time. As I hinted in my introduction, we've heard in all of these sessions today and yesterday people speaking very convincingly about a particular topic that was a technical topic. Is it possible for UHC 2030 to pick up all of these? You know, this is maybe something for the final session today, but if you were going to tell UHC 2030, the steering committee, what are the 2 issues that they need to focus on in addition to the old IHP plus donor alignment and harmonization, etc.? What are the 2 issues that you would really want UHC 2030 to focus on as well? Would this be one of them? Okay. Now, I don't want to restrict your discussion to that, but let me throw it open with that challenge to you to say, can we provide some guidance that this is obviously an important issue? There's a lot of things going on, but people are doing their own thing in a little way. Is this something that UHC 2030 needs to get involved with? So let me hand it over to you. And if I've totally confused things so that no hands go up whatsoever, we can have coffee. So right at the back, there's
but thank you for talking about transition. But thank you also for widening a bit the questions to what are the priorities. Let me just bring in one priority from a donor agency perspective, we are all hungry for results. We need results to demonstrate to our taxpayers that the money we put into development aid is worthwhile. And I think in these kind of technical discussions that we are having here with a lot of engaged health people and a lot of country focus, there is a tendency to forget that. So we are hungry for results, and we like to claim them as our results, the agency's results. And now I think partner country governments receiving aid can help us, and we can help countries. And I make a concrete proposal. Countries can help us if they become better on results reporting, better quality data, more relevant data, more timely data. And we can become better in health system strengthening and more relevant in our support if we stop reporting results as the results of our agencies and report them as results of the system. So first of all, the system produces the results, and then at the system level, which usually would be the country level, we agree on dividing up the results that have been produced by the system and all its finances, and then we can take these home and report them to our constituencies. This is not what we are currently doing, but this is one of the proposals that we think from a development agency and from a funder agency, UHC 2030 could help working on that. We need results, we need information on value for money, and we need to make that point into the whole collaboration. Thank you.
Thanks, Walter. And I forgot to say, can people introduce themselves? So Walter Seidel from the EC. Next comment. And sorry if I misled people. I'm not trying to have the discussion of the final session now. I still would like to focus on the transition question, but try and put it in the context of the bigger picture, the issues why we're here. So please, at the back, and then I'll come to you. Yeah.
Hi, I'm David Hipgrave from UNICEF. I wanted to ask whether UHC 2030 or the IHP for UHC 2030 also saw itself as having a role in the context of this discussion beyond health and beyond the Ministry of Health, given the important multi-sectoral and social determinants of health. So UNICEF obviously has a focus on children and the multi-sectoral determinants of child health. And I think the point has already been made in this meeting before, earlier, that in many regards, child health is the canary in the health sector goldmine. If your child health is doing poorly in a country, that suggests that overall the health sector is not doing well. But as we also know, it's not just the availability of health services and the efficiency of the health system that impacts on child health. It's also these kind of things that happen vertically in government, such as whether the Ministry of Water or the Ministry of Works has made sure that there's a good supply of water, or the Ministry of Electricity has made sure that health facilities have power. I think in some countries a majority of health services don't have power. So does UHC 2030 have that kind of advocacy role within other sectors and other ministries that have a major impact on health outcomes?
Thanks, David. One more. I've been told that we have 5 minutes left. So Remco, yeah.
International. I've heard several ways of transitioning and how to do that. We'll go back a little bit to the basics. If we, from the evidence, know progressive taxation in combination with social health insurance, way forward, I have not heard so much to have more effective tax revenues, how to transform tax capacities, how to work with other agencies that are able to transform that in countries. It's at a domestic level to do that, maybe in innovative ways, because that's what the current time asks, but also to do that in coherence with a global alignments and to ensure that there is sufficient revenues available to eventually make that transition for universal health coverage.
Thanks, Remco. We've got room for one more before I'll ask specific members of the... Come on, Simon.
Primarily for Jonna. Obviously, both the Global Fund and Gavi are looking at their sustainability for their results. But the issue that we've talked about already briefly, because we just blogged about it, Gavi is trying to measure its sustainability by increasing domestic resources for immunization, but has not taken an issue around trying to build broader health resources. So all it means is capturing more of those limited domestic resources for immunization, whereas the Global Fund, as I understand, is measuring itself by increasing the overall pot of health resources in a country. So kind of there's a bit of misalignment there, and I wonder whether Gavi has any thoughts about how they can make sure they're not undermining universal health coverage.
Thanks a lot. I think I have to cut it there. And again, I can't give each of the individual members of the panel a chance to respond, so I'm going to ask particular panelists to respond to the different questions. Let me start with the Gavi one, and that's an easy one to take because it was directed at Gavi. It gives me a chance to think who will take the other ones. So.
Yeah, it's an interesting question, and it's currently on the discussion with our board members. So there's multiple views on this, and I think what is important to understand is that, as we say, is that often immunization, as we see it, is the backbone of broader public health services. If you can get immunization right, meaning that if you can get a child to a health worker, have those health workers in place and educated, you can have so many broader services to deliver. So in that sense, there's an overall implication and benefit to universal health systems. So we don't see that we're very siloed in that approach. I think also comparing it with the Global Fund, it's a different scale of investment. So that's where I'm not sure if the comparison is actually right. But I think it's important to understand that getting immunization, and we use the canary and the coal mine as well when we speak about immunization. I think it's broad to understand that there's a wider impact on the overall health expenditure and services.
Thanks a lot. So let me just turn to the Global Fund, because the Global Fund also mentioned something about strengthening capacity of taxation. Michael, I keep getting signs that we've got 1 minute left for all of this. So
first of all, just a comment on the previous thing about disease-specific spending. It's an issue that we struggled with in our new counterpart financing. And under the earlier counterpart financing requirements of the Global Fund, we did actually require minimum thresholds for disease programs. And what we discovered is that there are no standard rules for how disease programs are presented. So it partially depends, like, for example, what's in the budget, usually of the central part of like the AIDS program, which might just be program management, it might be the pharmaceuticals, but it doesn't capture the system level costs, like at the service delivery of people delivering AIDS services or tuberculosis. And because there's no standardized method for that, those people could put in almost anything into their minimum threshold requirements. And so I think that's one of the reasons that we widened the scope actually to cover broader health financing, because we think it's actually very difficult to actually get that kind of very specific health financing, and it's better to look at the health financing more globally. And then specifically on the issue of tax collection, so as part of our new health financing strategy, countries that have low levels of tax mobilization will be targeted for broader multi-sectoral health financing strategies with other partners, including the World Bank and the IMF. So countries, I'm sorry to say, but Kenya would fall into that category, would be actually targeted for broader, sort of a broader approach to trying to solve some of these health financing problems that we know are not actually, unique to the Global Fund and are something that we can't address by ourselves, actually. So,
even though I've been told to stop definitively, I'm going to abuse my chairmanship. I'll give two more responses. Ariel wants to say something about the tax policy in particular, and I'd like to ask Caroline if she's got any thoughts on the multi-sectoral nature of moving forwards as well from a country basis, or whether you'd prefer to. But let me talk to Ariel first.
Thanks. Sure. Certainly, tax policy will be very important, and regulation as well. I mean, you can do it through your own public resources or regulating the private space. And the Addis conference was all about this. And although it's worth reminding ourselves that half the countries in sub-Saharan Africa will still not be independently to cover the basic health services by 2030. So we're not just dropping the countries, right? Very important. But many, as we're hearing, will. And tax administration capacity, we don't even need to raise taxes in the levels of taxes, but ensuring that they get collected. Lawyers, clerks, IT systems, all of that is very, very important. Stopping energy subsidies, another big source of resources in the public sector, very important, as well as the other side of the tax collection. So the Addis tax initiative is about this, and USAID and many other partners are part of that effort to help countries build that administration capacity for tax collection. But on the other hand, in the health sector, we have experience with the community-based health insurance, and that has the virtue of not counting in the budget allocation to the health sector, and yet the ministry can really marry their policies with the community-based health resources that have been successful in Rwanda or are now gearing up in Ethiopia and so on.
And so finally, we should finish with the country. So, Caroline, any reflections on what you heard?
Thank you very much. Based on all that I've heard, generally the issue of strengthening the tax administration is very key, and including the billing capacities, especially in the tax, in terms of tax. In addition to that, as a country, we are trying to broaden the scope so that we can now focus on other sectors like the informal sector. As I speak here, I don't speak in terms of health sector only, but broadly on all other sectors because of the issue of focusing on domestic resources. Thank you.
Okay. Thanks very much, and thanks particularly to the panelists for keeping to time and being interesting. So thanks.
And thank you for keeping to time. Thank you all. It is coffee time. However, don't worry, you will get your coffee, but where are my notes? As I announced this morning, there is, for those of you that want to show proof that you were here at the beginning, that you participated in creating this process, that you were here the second day of the rest of our lives, there is a photo opportunity now. So you still look great, by the way. You all look great. No? Thank you. I tried. Please walk out. You know where the stairs are right after the coffee spot? Please nod if you do. You know what I'm talking about? So you will not get lost? Let's go now. Let's all go quickly. We will not wait for people. If you don't want to be in the picture, we can't force you. But please, let's go now. I'm told. Fill the steps at the bottom. Tall people at the back. You know how this goes, right? And last thing, on your way there, remove your badge. It just doesn't look good on the photo. You can hold in your hand. Go. 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 Keep going. I saw Brenda recently, and I don't have my glasses.
They've got to be under a sheet of paper.
Unless I left them.
When last were you wearing them? They're not in your bag.
It's time. Are you facilitating? Brenda is facilitating.
Brenda.
Yeah, I am looking for Brenda. I don't have my glasses, so I'm sorry I can't. Agnes? I see red. No, but that's not her. Janssen and Emanuele. Okay, I have to go find my glasses because I really can't see and I don't know where I left them. We're just going to get started now. I think somebody stole my glasses, so I couldn't actually name and shame anymore because I can't see anybody. But I see people that are standing. Everybody that's standing, please come in and join. We're almost at the last session. This is the second, or the last session before we actually do a wrap-up. Thank you so much. Aha, I see you all. Thank you. This is the last session before we wrap up and try to make sense of all of the great contributions and the points that you have made throughout the day. And it's continuing on the discussion that we've been having the entire afternoon, but now with an actual focus on fragile states and seeing what does that mean for those countries in terms of the development cooperation. And Brenda is going to take us through that session. It's going to be for an hour and a half. So hopefully that gives a little bit more time for content, for discussions, and for people to give input. And I will just stop there and let you take over.
Thank you very much. Very pleased to be moderating this session, very important session. I think it's where we really look at whether we can make sure that we leave no one behind with universal health coverage. We're going to look at approaches in some of the most difficult and most needy situations. So approaches to development cooperation for effective health system support in conflict-affected and fragile settings. We all know how important it is that service delivery is in place, that we can demonstrate that there is a state, that there's nation building in place, that we adhere to the peace building and state building goals.
but it's also an extremely difficult arena to work in. It's very challenging for everyone, development cooperation partners included. And certainly speaking from the OECD, where we host the International Dialogue on Peace Building and State Building and the New Deal for peace building and state building, I can say that we've certainly not got it right, and I hope that in that spirit we can look at what we can learn and what we can do together using this Alliance for Universal Health Coverage to help us reach out to those who are most in need. I'm very pleased to have with me on the panel today, I have colleagues from the World Health Organization, from the Global Fund for AIDS, TB and Malaria, and from the government of Guinea. But to get started, we have a keynote address by Nigel Pearson, who is going to set out some of the challenges that we face in this area. Over to you, Nigel.
I think I'll present from here. So we have the exciting task of thinking about fragility. I know we're coming at the end of a very long conference, everyone's tired, it's my job to try and get your attention. Alors, ça revient à moi d'attirer votre attention. Nous sommes désolés pour nos collègues francophones, but we'll try and make it animated and participative. We will have an exercise for the last half hour or so when we're going to discuss some of these key concepts. So please stay alert, stay giving your full attention, because we want your ideas later on. We will be discussing in 4 different groups some of the key ideas I want to talk about during my presentation. So we're talking about lots of things, development cooperation, we've said a lot about that. We've said a lot about health system support, but this context here, the fragile context, is something that we need to get to grips with, because if we want UHC, if we want to get good health systems, if we want to have an impact, we have to work out a methodology of how to get it. So what I really want to talk about is how do we get results in the tough places. And that means we need practical ways of working. And that's what I do with most of my work, is trying to advise on health systems in places that are really fragile. Now, how do we describe fragility? Let's have a look at the next slide here. I think every country potentially can be affected by fragility. And those of us, no prizes to guess my nationality, but for me today is a very terrifying day. Partly because I may lose my European Union citizenship, partly because I have no idea what will happen tomorrow when Great Britain might go off into the sunset. But for me, this is an absolutely terrifying prospect that also has other repercussions on all of you who are members, European citizens, and other people. So just to remind us that when we look at fragility, we all can be affected by fragility. And I think in the discussion, what I like is these indexes of fragility and stability. What I don't find at all helpful is this term fragile states, which sort of sticks like a label to countries. And I've never been able to go to a Minister of Health and say, how is your fragile state doing? Because I think it's quite insulting. And so we need to look at the language and our approach to some of these places. If we were to go back to the Roman world of Emanuele's ancestors, we would see this kind of a map of lots of countries separated by a big sea in the middle. Notice that our ancient Britons were barbarians at that point and had not yet been civilized by Emanuele's gracious ancestors and forced to learn Latin. But if you were standing on the shores of Carthage here, you'd suddenly realize that Rome wasn't as far away as you may have thought. And so we get a map like this, which shows the main transport networks across the Roman world. Suddenly, what we thought was a big gap in the middle becomes the highway. So in those days, the sea was the highway. That was the M1, the main autoroute du Soleil that joined up those parts of the empire. And so to go to Carthage, that was just a couple of days in a boat. Whereas to go from Rome inland into this vast interior where it was very dangerous and very difficult was a much harder task. Maps are important, and we're going to start with maps. It's about how we look, how we get a visual impression of a place. What is this a map of? What is this a map of? Okay, but what is Somalia? I've done lots of work for Somali people, and not once in anything I have written have I been able to use the word Somalia. This is what happens in this area that we call Somalia. We have, down in the southwest, we have the new Jubaland state setting up. We have the interim Southwest Authority. We have Galmudug, which was created recently out of two regions, a new state. Up in the north here, we have Puntland, we have Somaliland, which is fiercely independent, and in the middle, we have a disputed area of Sul and Sanak. How do we work in all these areas? But we can't just take this narrow country model. We need to look regionally at the common problems that are affecting Somali peoples across the region, in emergency, in crises, with refugee populations here, and I've been to visit many of them with my work with UNHCR. We see huge populations of displaced people who all need good health care. And if we want to find good models, we cannot just stick with a simplified model of this state. We need to work out how we can get to places. I was working with a team on the essential package of health services back in 2008 and 9 in the Somali areas. And of course, we couldn't use this word Somalia, but we used the adjective Somali. And I was hoping we would get away with just having the one. In fact, we ended up having two. We had Somaliland and Somalia, which was fine. But actually, the package was the same. What was amazing is, as health actors, we were able to get everybody around a table and to discuss and come up with a really decent, coherent policy for the future. I might mention some of the aspects of that a bit later on. Last year, I was working on some national treatment guidelines. Now, we have to use the words very carefully. So again, everyone was happy with the word Somali, but we managed to get most parts of the country to agree to one series of booklets for hospitals, health centres, and primary healthcare units. At the last minute, the Somaliland government said, no, we need our own books, so that I had to kind of re-edit all the introductory sessions, which took me hours. And you have to check for consistency, you don't make any mistakes. But we will then have, published by WHO at the moment, we will have separate guidelines for Somaliland. But actually, it's the same thing, and everyone's agreed to it. So us medics together, the clinical people, we've got together and said, actually, we can agree to a common set of guidelines. So it kind of works. But there isn't a Somalia essential package. There's not a Somalia national treatment guidelines. We have to break it down into its component parts. Let's look at a couple of more maps. This is a very important, you can't see the details, don't worry. But I think this is one of the most important maps, because what I want to know, if I'm doing health services, is how can I get around? And if you can't see the details, but green was the sort of roads that were open. This is a WFP map from May 2016, quite recent. The yellow areas were pretty difficult to travel. The green was still okay, although this changes every week. So this area north of Mogadishu has been very lethal recently. But look at these red roads. So these areas are really difficult. If you were to be designing a procurement supply chain for all these areas, you have to be very flexible in how you think about it. And personally, I think you need to think for every region, you need a different procurement supply chain, because you can get drugs in the port here, you can get some from Ethiopia there, you can get stuff across from somewhere else there. So we need to be really flexible when we think about these large national strategies and break things down into their component parts. So our thinking when we approach fragility, we need to be very flexible with the terms we use, and we're going to be inviting some of you later to think about the terms that we use. Do you like using fragile states? What terms do you want to use? Particularly the countries who are with us today. How does that appear if someone says you're a fragile state? But on the other hand, what terms can we use when we're addressing the difficult, challenging situations that we are in? We need to think cross-border. We need to think regionally. We need to follow the people. This was an idea we discussed recently. So we don't forget the refugees. We don't forget the displaced. We don't forget the migrants as they move across all of these borders. We need to describe the situation as it is, and above all, find out what works and who gets it to work. So who are the partners who are getting results already in that country? We need to study it really carefully. How can we get access? And take opportunities as they arise. So that means that, yes, we may have a 5-year program of engagement, but every year, perhaps every quarter, we review, we reset, we find out different ways, and perhaps have to change the partners if a particular partner is not able to get in, or use a different part of the government, or governments, as the case may be. In Somalia, we're dealing with about 7 different ministries of health at the moment, although there's a lot of consensus in the centre around the federal government. We need to innovate, we need to be flexible. We took a look, this was a piece of work I did with DG ECHO, looking at their humanitarian ways of responding to the crisis of drought vulnerability in the Western Sahel. And at that time, it was just shortly after the food crisis in Niger in 2005. Now, ostensibly, you think that's a problem just for Niger. But actually, what we found by reading some of the studies that had been done was that food production caused by a slight decrease in rainfall only decreased by 10%. The cause of this food crisis and the malnutrition crisis was the fact that Niger was exporting all its grain to the neighbouring countries. The market people were hoarding the grain, and at the same time, Nigeria, Mali, and Burkina Faso shut their borders to exports. And so imports into Niger of grain went down by 60%. So unless we look regionally, we will not analyse and find out the causes of food crises, of health crises. We have to set the country in its region. Another example, if we're looking at what's going on in northern Nigeria, we can't just look at that map that stops along this border here with Borno State and Yobe State. We have to reset the map and look at this corner of Nigeria in the context, the Lake Chad Basin context. The problems are very similar. When I went to visit Dife here on the border and went right up, I got to Lake Chad where this guy was, we found lots of Nigerian refugees, but also lots of Nigerians coming across to health facilities in Niger every day. So how do we finance that? How do we work across these borders? We need more flexible mechanisms. And the same would be true in northern Cameroon, which was fine until recently, but it's had quite a few attacks. Things have got worse. Another example from this border of Myanmar with China. Now, for 20 years, people have been responding. These are the ethnic armed groups who have been fighting in opposition to the government, particularly the former government. If you were trying to do a health program there, who would you use and where would you go from? If you were trying to run a health program along these border mountainous areas, along this border area, where would you do it from? So there's a very simple answer. You would do it from China. And that's what this NGO did. It's a British-based NGO, but they had permission by the Chinese authorities for the last 20 years to operate a very successful program in 5 different special regions. And their staff were all Mandarin speakers, which was a huge advantage, because in this part of Myanmar, people do not speak Burmese, they speak Mandarin. And so, again, a flexible way of working. And this program is having a huge impact. And again, we might just touch on that a bit later. But think outside the box. In fact, this map doesn't show it, but what we really need is the map of China. China was very grateful because it wanted to control disease spread across the border. There's lots of epidemics that move between this very, very long border with China. So approaching fragility, we need new words, we need new language, we need to dissect and to look at countries, but also look at parts of countries. For example, in Nigeria, a huge country, but what's going on in the north? It's very different from what is going on in the south or in the Niger Delta. So we need to have very diversified, decentralized approaches. We need to realize that what we're dealing with is risk. We need to do better risk management. And then in terms of the language we use, we need to have a language that is just going to be more useful to us. So this came out of a big piece of work we did with the Global Fund, advising them on their work in countries affected by fragility. And so we had to come up with new definitions. In the end, we came up with the term challenging operating environments, because it was all about operating. How do we operate in these difficult places? I'm going to show you 2 slides now which illustrated that. So when we looked at the different countries we felt were harder for the Global Fund to work in, we came up with a list. We looked at all the different indices of fragility, and in the end, we used the Fragile States Index, which isn't perfect, but it was the most robust one we could find at the time. Since then, they've gone on to use their own mechanism, which is fantastic. But when we looked at what were then called fragile states, there were about 45, depending on whose indicators you used, we found this. And this was a private security company called Control Risk that they do their own analysis. And we found that at that stage, the top, it was the top 16, and then we added in countries affected by, well, severe war, and Egypt at that stage, back in 2013, was kind of on a precipice. We weren't quite sure where it was going. Mali was still in the throes, well, it still is now, but it was still very much in the throes of the civil war that was going on. So we get this map which looks at the risk. So it had 5 risks, of which for us, perhaps most important is the security of getting to places, the operational risks, and then some of the political risks as well. Travel as well as relevance. If you can't travel, if you can't get to places, how do you do a program? So if you analyze the risk, you can then, I think, you can make some inroads. But look at the difference between the top 16 plus 3 and then the next 20. There was a stark difference. And so it became very clear to us that some countries, if we go back to this list, were much, much harder to work in. If we then looked, actually, at that stage, Nigeria was on the list, and we looked at Nigeria, and it was completely different in different parts of the country. So down in the south, it was yellow, it was green, but in those northeast corners, it was this dark red and the dark brown color, which has pushed it into this category. Pakistan was the same thing. In the central areas, they're fine, but when you're up in Khyber Pakhtunkhwa, you're in a completely different world in terms of your operational risk. So one of the conclusions was manage the risk better, find partners who know how to manage that risk and get on with things. So the challenge is about understanding the context. We know about what was in these challenging operating scenarios. There was conflict, there was lack of access, there was very weak governance in some areas, but it was variable, and some countries had certain capacities. But what we found was that every situation was different. And if we go on to approaches, which we'll talk about in a minute, we realize that for every scenario, we need this kind of tailor-made approach, something that Gavi talked about with their work on fragility. It's something that the New Deal talked about, the sort of the tailored approach for either country or even parts of country. Part of what we need to do is these assessments. We've had lots of talks about joint health systems assessment. But if we're working in areas of fragility, then we need to do, as the New Deal recommended, the fragility assessments. We need to do the risk assessments, the PFM, the political economy. And if we were to look at the political economy of South Sudan at the moment, just coming out of a terrible protracted civil war, we would realize that it's still in very, very early days, and in fact the government are trying to suddenly go from 10 states to 28 states. As I found out, so Terekeka is a place north of Juba, in the picture here. They're just creating 2 new states, Terekeka and Jubek states. And what they've done is they've done it along ethnic lines. And so the Mundaria are in one state, the Bari people are in another state. These are people who've been living relatively peacefully for the last 20 years. There was conflict that emerged there last week between these 2 people along this newly created fault line. There's all part of the political settlement. So the politics matter. They really affect all that we do. We have to be very wise and understand the context. And a really great quote there from my quote of the week. It's not ethnic identity, but it's the politicization of ethnicity and the militarization of politics that has devastated the country. Sober thoughts from the country, the new country of South Sudan, which had so much hope. So approaches, I'll leave you to read some of this afterwards, so we won't have time to cover all the slides, but we've mentioned the first one, the idea of partnerships working together. We need national health strategies, but we need the flexibilities to work separately and in different ways in different regions. We get where we can, we go across border, we find more flexible ways of working. I think a lot of this you know already, so I won't go into it all, but a lot of this comes from the sort of 7 behaviors and DAC principles of engagement. They're all relevant, and we need to put them together and really have our thinking hats on. In terms of universal healthcare, can we do universal healthcare in a country affected by open conflict? Can we do universal healthcare in a country like South Sudan, which is emerging from a terrible civil war? I think yes. I think we need to break it down. What can we do? And this will be a question we will be asking one of the groups to look at. Was, my way of looking at it our way of looking at it would be, starting with an essential package would be brilliant if you can, because that's all part of UHC, and it's a part of a political process to say, actually, people have a certain right to a basic set of health services. If that doesn't buy, then at least try and get a bit of MNCH, 3 diseases, vaccines, and then build up into a package. It's not always possible, but I think the ideal is a whole package. I think the next step is then to advocate which core services can be free, like Sierra Leone did recently in making health services for women and children free, a great step forward. Niger, after the 2004-05 food crisis, they suddenly got rid of user fees for young kids and for women. It had a dramatic effect on bringing down infant, maternal, and young child mortality. Really, really effective. So let's keep on to these things, but let's divide UHC up into its parts and build up slowly. Diversify revenue sources. I cannot emphasize this enough. These countries are very resource rich. We mustn't go in with an idea that we're going to finance everything for the next few years. This health center in Salahi, it's in southern Somaliland, near the border with Ethiopia. I was amazed to come across this community that had just built a hospital that had cost them $200,000, and these were the plans for the next phase of building. It was mainly diaspora funding, but some of the money came locally. When we designed this Somali Essential Package, we built into it the diversification of revenue sources. And we said, look, local government needs to contribute. Local communities need to contribute. Not necessarily with out-of-pocket user fees, but with other resources that were available locally. We can do much more with this domestic revenue, but not just centrally. We have to think regionally and municipalities and very locally as well. So that's just something that I think is really critical. I've proposed sort of how we look at health system design. I'll leave you to look at it because it's quite a complex map, but we need to build, we have the 6 building blocks, but we need to think of the dynamic aspects of health system design, things that will move us from a fragile health system to a sustainable health system in which accountability and legitimacy are there, where instead of having parallel state, community, private facilities, we bring things together with much stronger regulation from ministry or ministries of health, with much stronger citizen participation, with the private sector somehow coming in some kind of way. So again, we can be much more flexible. This, I won't go into detail, but one point here on this dynamism model is the ownership. I think we talk about participation all the time. I think we get good participation if there is ownership by local people. And that might be a diversified ownership where the local municipality, with the local community, where the national government, the Ministry of Health, they also brand the health facility. So we need to look at our ownership models. And if we have good ownership, then participation almost comes, that becomes as a secondary step to that. But get the ownership right, and then I think we solve many problems. State building will leave you to answer. I've suggested some ways of having a positive impact on state building, and that was clearly one of the DAC principles, and I think it's key. But we need to look at state building at a local level, at a regional level, not just at a central level, much more a model of a citizen state and what it may look like when the health facility committee are involved in talking about, in expressing their political agency, in making decisions, identifying health problems. So just one last thought here about refugees, migrants. People move, we need to move with them. We need to build these people into our plans. And there's some successful examples of that with the Global Fund recently. We need to not treat them as people who don't fit into the concept notes that we make. We need to count them in, whether they're refugees, whether they're asylum seekers, whether they're migrants. And a lot of this work comes from stuff that I do with UNHCR, that we need to be thinking of really integrating their healthcare into national systems. And there's a couple of references. I've given a list of sources at the end of this presentation. So just to bring us back to our first point about fragility, as Britain teeters on the edge as they go to the polls today, a rather horrifying prospect. And we either go to this fantasy land or perhaps we drown and sink. So thank you very much.
Well, thank you very much, Nigel. I think some really important points there about working with what's there, working with communities, being flexible, not seeing everything through the structures that we first see, but looking at the structures which actually matter in the situation. So now I'll turn to our first panellist, Agnes Suka, and ask for your thoughts, 5 to 7 minutes, on some of the approaches to health system strengthening that WHO advises in fragile and unstable contexts, how these are different from other approaches, and how can UHC 2030 help?
Thank you, Brenda. I wanted to start a little bit starting from where we left it this morning and about the presentation of 3 types of strategic approaches depending on the context. But I want to first say that where I'm coming from is different from the fragile states point of view, which was just presented by Nigel. What we're coming from is from a strategic point of view, that there are different ways we can approach health system strengthening, and those strategies, it is for us to determine, depending on the country, which one is the most adapted. And it's not necessarily at national level. You can actually have different strategies in the same country, depending on the problem identified. So where I'm talking from is not from a fragility point of view, but from a health system assessment, health system fragility point of view, which may be different, because you may have countries that started from a starting point where they had a good health system, but they have political fragility, and that's the case of many countries. I can think of Iraq or Syria, for example. Syria certainly started from a very strong starting point in health system. The second thing I wanted to say as a preamble is that we really see the investments in health system are both an outcome and an input into the formation of a state. That it's I think it has often been approached from the point of view that the health system is the outcome of an investment in state building. Whereas I think we need to recognize that it may go the other way, that actually investing in service delivery at local level may actually be a contribution, a brick into the state building process or on the stability process. The delivering services may be a way to reduce fragility. That fragility may actually be caused by the lack of services, and not necessarily the lack of services being the cause of the consequence of fragility. So if I can move to the sort of how this translates if you remember, we presented our fit for purpose health system strengthening strategies, and you see that we propose that we have really 3 types of strategies: building the foundations in countries that really don't even have those foundations of health system, don't have human resources, don't have a financial management system, don't have a supply chain, don't have even the minimum of infrastructure. And then the next step is into strengthening institutions. And for more mature health system who already have a strong institutional setup, then a strategy can be transformation, which is about really changing profoundly the way this institution functions for different results. And we see really this as a continuum in the development continuum leading to UHC. So it's a bit like, you know, this kind of electrical plug diagram in which you really have these concentric layers, and you progressively build a strong pillar of state building, which is the health system and the production of UHC. And of course, there are other pillars, and education can be one, and inclusive infrastructure another one, and human rights another one. But that really health and the production of UHC, we will be starting from those small, fragile pillars, and we build and we strengthen them over time, and they are really the foundation of stability. So when we talk about the foundation strategy, we're talking about those countries that really have almost nothing in terms of health system, in the sense that very low density of health workers, very high percentage of facilities that don't have water or electricity, very unstructured local governance systems, no information system, very limited supply chains, and no financial management systems. And of course, there is a fair amount of overlap between what is considered highly fragile countries, if I don't use the fragile states terminology, and this type of countries. For us, we identify as those countries who need that kind of strategy as a prime strategy. And clearly, the countries that were affected by Ebola, Liberia, Sierra Leone, Guinea, are clearly those countries that didn't have these foundations. So what we're proposing here, and it is a fairly new proposal, and we fully recognize that we don't quite know how to work in those settings, as you rightly said. It is a very modest contribution in trying to sort of, starting from the premise that maybe what we've been doing in the past was too expensive as a proposition, and we need something that is more focused on the critical problems. It's a bit the lessons from Ebola, that maybe we were trying to do too much without attention to these fundamental investments. So we started a process of technical discussion and consultations within the WHO and with partners, and we identify 6 gaps for which we think there is really a need for investments in those contexts. And those 6 gaps, we try to organize them around the building blocks. They could be organized differently, but this is sort of for easiness of reference and understanding. So these 6 gaps are really these 6 areas in which we really would strongly argue as WHO that we need horizontal investments, that it's not something that can happen with through a typical disease-based program, but would require really an agreement between different partners that we're all going to do this together. So that's really a focused proposition that it was presented this morning by Max, that in terms of financial management system, and he was giving the very good example of Sierra Leone, we need to build one strong national financial management system instead of relying on 7, 12, 17 financial management system. Pre-service education is the same. If we don't have even the minimum number of nurses or assistant nurses in a country like Liberia, we need to invest together in that. Supply chain is another one. We still have countries that have, even for antiretroviral drugs, 3 types of supply chain, 1 per funding agency. Health information systems, local governance system, and here I'm really fully in line with you that then when we're talking about leadership and being in the driver's seat, we're talking about country leadership, not necessarily central government leadership. And that country leadership can be actually local governance systems with communities, with provinces, with districts, depending on the context. And then finally, some fundamental investments in infrastructure and equipment, because we're talking a lot about the potential of mobile phones, the potential of all sorts of new technologies, but if we don't have basic access to energy and water and connectivity, this is really not going to happen. And I'll just finish with just one point here. I'm presenting this table. So this is all the references that relate to these six gaps. There's been really extensive diagnostic that this is the problem, these 6 gaps. And this is a list of what the inputs are. And when you look at it, you really see that this is really a lot about 2 things. It's about infrastructure, particularly electricity, connectivity, and IT infrastructure and systems. And it is about human resources. But not only health workers as we typically see them, but also accountants, very important, epidemiologists, statisticians, and this is really the core of what we need to invest in if we really want to have the kind of minimum platform of health services if we are to deliver on health security, and that kind of minimum package that you were talking about for at least the majority of the population. Thank you.
Thank you very much, Agnes. And I think a clear message there of we identify what we need to do, we start right, we get the foundations right, and particularly on infrastructure and human resources. But now I'd like to turn to our second panelist, Dr. Mohamed Lamine Yansane, who is the Conseiller Politique Sanitaire du Gouvernement de Guinée, and ask, what does this look like from your point of view? So from your experience, what are some of the approaches to health system strengthening and coordination that are most appropriate and useful in an unstable context? Do you agree with the framework that has just been set out? So over to you for 5 to 7 minutes.
Merci très bien, je suis entièrement d'accord avec Souka. La Guinée est l'un des pays qui a été rendu instable à cause de cette terrible épidémie Ebola. On n'avait pas un système de santé résilient qui a pu faire face à cette vague. Alors, la solution passe obligatoirement par le renforcement du système de santé. Et tous les blocs présentés ici nous semble assez convenable pour y arriver, mais le gros problème réside dans la coordination des intervenants qui doivent participer à la reconstruction du système de santé. Avec une telle épidémie, nous avons eu des centaines et des centaines de partenaires qui sont arrivés sur le terrain. Au-delà des bailleurs de fonds traditionnels, on a eu plusieurs acteurs de mise en œuvre sur le terrain. Et malgré qu'on a fait un plan national de développement sanitaire dans lequel on a tiré un plan de résilience sur les 3 premières années avec des cibles bien définies, des indicateurs bien définis, on se rend compte que le problème de coordination de toute cette assistance, de tout cet argent qui est annoncé pose énormément de problèmes. Il y a eu un plan de résilience, je peux dire à peu près de 1,3 milliard, dont plus de la moitié a été mobilisée. Mais quand on voit les blocs qui ont été présentés ici, très peu d'argent mobilisé rentre dans la reconstruction du système de santé. On va dire que l'essentiel va dans l'assistance technique et les partenaires choisissent 2 ou 3 choses et tout le monde fait la même chose. Je prendrai juste quelques exemples. Comme la gestion des déchets était un problème, tous les projets que nous avons eus sur le terrain ont mis l'achat des incinérateurs comme leur priorité. Donc, il y a eu plus de 150 incinérateurs achetés pour le pays. Et au moins, là où je suis assis là, il y a peut-être les 2/3 qu'on n'a pas pu installer. Et ce qui a été installé, plus de la moitié ne marche pas. À cause de... Tout le monde s'est tourné vers les investissements. Personne n'a rien prévu pour faire fonctionner cela. Et on a des problèmes de maintenance. C'est la même chose pour les véhicules. Quelquefois, vous allez trouver des districts qui ont des véhicules, mais soit ils ne peuvent pas payer le chauffeur ou ils n'ont pas de carburant pour faire marcher les différents véhicules. Donc, c'est un problème réel de coordination et on a l'impression d'une part que ceux qui financent tout cet argent, un, ils ne se parlent pas entre eux et deux, ils n'ont aucune redevabilité par rapport aux pays qu'ils assistent. Les opérateurs de mise en œuvre, en tout cas c'est l'impression que les pays ont, sont beaucoup plus redevables de ceux qui leur donnent de l'argent et on a l'impression que chacun finance un projet entier au lieu de financer le plan national de résilience ou le plan national de développement sanitaire. Donc la coordination est, à mon avis, un gros problème et je ne suis pas sûr que c'est spécifique à la Guinée, mais pour arriver au schéma présenté par Souka, il faut vraiment qu'on puisse se parler et que l'argent qui est mobilisé puisse être orienté vers ces priorités qui sont là et qui sont les priorités du ministère de la Santé. Si on mobilise, après une telle crise, je ne suis pas sûr que la Guinée va mobiliser autant d'argent dans le futur, mais si cet argent ne parvient pas à modifier le système de santé guinéen, c'est que l'objectif n'est pas atteint. Donc il y a ce problème de redevabilité. L'argent doit servir à améliorer les services de santé et dans ce cadre, il faudrait que l'ensemble des partenaires puissent s'orienter vers les priorités définies par les ministères de la Santé et par les différents gouvernements. Donc c'était là vraiment ce message que je voudrais lancer et de faire en sorte qu'on ait une certaine harmonisation. Parce que si vous avez 50 ou 100 partenaires, chacun vient avec ses modes de gestion, personne ne veut s'aligner sur ce qui est prévu au niveau national. On a l'impression que les 7 comportements de l'IHP+, sont encore une certaine théorie, mais que de passer de cette théorie à l'acte, c'est difficile pour tout le monde. C'est en tout cas un message assez fort que je voudrais lancer à l'ensemble de tous ceux qui veulent nous aider. Nous avons défini des priorités, nous avons des enfants à vacciner en routine, il nous manque des médicaments dans les centres de santé, les infrastructures et les équipements, on veut les moderniser et il faut que tout cet argent qui vient des contribuables divers puisse servir au bénéfice des populations guinéennes. Merci.
Merci bien. A very strong rationale for the approach that was outlined, starting with the foundations, and a strong reminder that the Paris principles of aid effectiveness, the Busan principles of development effectiveness, and the 7 behaviours of the International Health Partnership are being broken on a daily basis, and that's something that we should all be concerned about. So, not to put too much pressure on you, turning to my final panellist, Emmanuel Capobianco from the Global Fund. This is clearly a challenge that we all face. Everybody in this room faces this challenge, and it's been a challenge for some time. So we'd like to hear from you about how the Global Fund is working to address this, how you're working with governments and partners in countries and areas affected by conflict or fragility to ensure a coordinated approach to state building and health system strengthening. So over to you.
Thank you, Brenda. Let me be brutally honest and share with you that in 2014 there was a technical evaluation, independent review of Global Fund work in fragile states, and actually the leading researcher is sitting on that corner. He came very strong against the Global Fund, basically saying that the Global Fund didn't have a clear strategy on this, didn't have the right people in place, wasn't targeting the refugees and IDPs, and wasn't really tracking how things were going in country. After that, there's been a lot of work to try to correct, and I'm happy to be here today to share that under the leadership of our board, the Global Fund has now prioritized not fragile states, but what we call challenging operating environments, recognizing the sub-regional and the regional dimension of fragility beyond the national dimension of fragility into the next strategy for the next 6 years. We now have a policy on challenging operating environments approved. We now have refugees and IDPs as one of the critical focus. And we have also set up different type of financing mechanism that allow us to respond to acute crisis through what we call an emergency fund and more chronic crisis. So there's been a lot of work, and while this work was done to reposition our institution, a lot of work has been happening in country to try a new approach. The three elements that characterize the new strategic approach of the Global Fund are flexibility, innovation, and partnerships. So to give you an example of how we are trying to change as an institution, we have the colleagues from Sierra Leone in the room, and in Sierra Leone, during the Ebola crisis, one of the biggest problems for people affected by malaria is that they were not reaching the facility. So working with partners, the Global Fund was able to finance through an emergency fund, a grant, a mass drug administration against malaria, reduce a lot the weight on the health systems, and reduce eventually the mortality for malaria. During the next few months, the Sierra Leone was supposed to prepare the concept notes for the next round of financing for HIV and TB. And they had tried to meet the deadlines 3 times. And I think there we understood that it was not going to happen. People were busy dealing with emergency. We couldn't just impose our own mechanism. So there were flexibilities and waiving of requirements that allowed the extension of the grants without the need of new concept notes. What I think was most interesting of this story is that at the end, towards the end of the epidemic, Sierra Leone came up with the health recovery plan, and the Global Fund with other partners was able to support the financing of this health recovery plan on a joint platform, which is not only a financial management platform, but is really a programmatic platform. And for the first time, the Global Fund gave incentive financing for an HSS proposal in Sierra Leone. And what we are coming in is on laboratories, on human resources for health, doing it also in I think in a smarter way, for instance, supporting community health workers program, but putting a condition that the ghost workers that have been detected in the system will be cleaned, and that will be able to do that with a plan for further absorption in the longer term. So to me, that is a smart way to approach, working very much with all the partners. I wanted to add a couple of points that are general. Fragile context, challenging operating environments are the future. I don't know how many of us will be around in 15 years when we'll discuss IHP 2050, but we'll be left with these issues, this context to deal with. And so they are incredibly important. For us as a Global Fund, 1/3 of the disease burden is in these countries. 1/3 of our investment, 4 billion per year, go to these countries. So top priority. Second, there is an enormous heterogeneity. So we should be staying away from one-size-fits-all approaches. The context of Syria is very different from the context of Somalia, is very different from the context of Ukraine. Ukraine is different in the east, where you have active conflict, in the south, where you do have a region that has been annexed by Russia. Third point, these are very difficult areas to operate, and we should be realistic. If we are not being able to build sustainable systems in countries that are much more stable, it's going to be even more difficult to do it in this context. So first, ensure service delivery. Second, build on resilience. And then only last, thinking about sustainability. It will come, but let's do it in a modular way. So let me finish on what I think should be the way forward. We need to learn, document, and share. And IHP can do that, can help us experience what is working, what is not working. At the Global Fund, we are now conducting a review of our investment in systems for health in fragile states, and we're going to have a consultation with partners on the 15th of September, to which who is interested will be invited to discuss what we have learned and how we can improve jointly that approach. The work that Agnès has started is absolutely critical. There is the need to focus on building the foundations. We look forward to working together. I think we should invest on that heavily, with the idea of coming up with tools that can be used. We need assessment tools. We need to agree on service delivery packages that we can adopt and tailor to different countries. We need to try to work on the data, as was mentioned by Nigel, so that we can work on those data and improve. So I think this platform has an enormous opportunity. We should use it smartly and effectively. So thank you.
Thank you very much. I think a useful reminder that let's use this platform where there are challenges, where if we can find ways where we can move collectively, we can change behaviour in the right direction and learn about things which are very heterogeneous and challenging. Now, talking of challenging, we're going to make you work. We have a number of questions to be taken forward in groups. Can we have the slide with the questions? Now, what we're going to do is divide you into 4 groups, and you'll each just take one of those questions so that we get a bit of a mix of responses, and you've got time to look at things in enough detail. So these questions come from Nigel's presentation, but also we've had a lot of insight into these from the presentations we've just heard. First question is about what should be, how should our approaches for health system strengthening for UHC, how should it be different in context of fragility and in challenging operating environments? Second question is, are there features outside of the building blocks that we heard about that we need to think about for innovative design of the health system for sustainability in context of fragility? Third question, how can we incorporate state building into the design of health system strengthening interventions in fragile and unstable contexts? And I think the peace building and state building principles have been placed on the table, so you have those with you. And then the fourth question, what approach would you advise on the language for fragility and unstable contexts? What ideas do you have so that we are working in a more constructive way? Now, looking at the way the room is set up, I may actually propose that we do this in line so that we get enough people in each discussion. So I'll propose that, maybe starting with the left-hand side of the room, the 3 tables that are against the far wall, and we'll include this table slightly in, it's the man that just turned around and looked behind him, that table as well. Can you look, so those tables, you look at question 1. Then question 2, I'll propose this table at the front and the 2 tables immediately behind. Yes, the man putting his hand up, and Jana, your table as well. And let's put this one in the middle in with that group. So you're looking at question 2. Then this line, nice line in front of me here with 3 tables, plenty of people on them. You look at question 3, and then this row along the far side here, you will look at question 4. We'll give you 15 minutes. Can we run over a little bit? Or Okay, 15 minutes, knowing that we'll then probably end up with more, longer than that, but you've only got one question each. So 15 minutes to answer those questions. I'd also like all of you to give an idea of what are you going to do differently after this discussion, after this event, because this has been about changing behaviours. I'm going to ask the panellists to answer that as well. So answer these questions, but also think about the lesson that you're taking away about what you're going to do differently after the discussions over these last 2 days. Okay, so we'll give you until 4:45, and off you go. You can go mingle, and then we'll pull you back.
Where? Oh.
My computer.
Yeah, discussion time is up.
Okay, so can people finish up, decide who is going to report back? I'm very pleased to see that you're all discussing very energetically. That's a good sign. But we need to get to the stage where we can report back. Okay, I see one table there is still discussing. Can you bring your discussions to a close? Yeah. Well, it's just that if they are actually closing up, then it's good that they're having a discussion. Well, I think it's Maria's rapporteur, isn't she? She's taking notes. Yeah, good. Okay, I've given you a couple extra minutes because it's good to see people discussing energetically. Just want to check. Maria, are you doing rapporteur for this session? So,
very important to capture the ideas.
Are you capturing? Are you going to capture the ideas that come out in the feedback? Sorry? Yeah. Good. Thank you. Okay, so who's ready to report back from their discussion? We can be linear and take question 1 first. Is there anyone who wants to report back on question 1 on this table here?
Hello. Thank you very much. I'm Dr. Azimi from Ministry of Public Health, Afghanistan. So our group work on the first question, what should be different, our approach for health system strengthening for universal health coverage in context of fragile states. As we discussed, so as I'm from Afghanistan, and Afghanistan is also a low-income country with fragile context. We have been experiencing 3 decades of conflicts and war, and the situation is extremely bad, and the health indicators are worse due to this situation. So, based on our experiences as we in Afghanistan, that is contracting out mechanism is one of the good approaches that we involved CSOs, NGOs to service provision in the provinces, and also community participation through these NGOs. So, and also the other approach is that we're developing minimum service packages. In Afghanistan, we have a basic package of health services and also essential services for hospital. These packages is helped us a lot for provision of the health services to the provinces in the remote areas. And also, we agreed that flexibility in terms of regulations is also very important when especially when in an area that there is the security is not good. For example, In Afghanistan, in south part of the country, the situation is very bad. So during the bidding process, when we select the NGOs, so we had very good organizations that worked in this area. They established very good connection with the community, with the oppositions. So they were able to provide the health services. But during the bidding process, because of some score, very small scores, they lost the projects. A new organization came there. So the new organization, when they got the project and they start working, they faced with challenges. So the people, they were not familiar with the context and faced with many problems. So the government or the ministry should have such flexibilities when award the projects to CSOs, especially considering their work experience, whether they have the ability to work in that situation or not. And also building mechanism for trust between.
Yeah, so if you can bring that to a close, and we can get round the room. If there's, well, finish your last point, and then I'll move on to the next table.
Okay. Another approach is establishment of coordination mechanism, different coordination mechanism that can be applied in these provinces or states. Thank you.
Thank you very much. The table behind.
Is this working? Yes, okay. So we just wanted to note, this will be brief, but the dialectic between the humanitarian response and the development response. And we've heard about flexibility, we'd repeat flexibility, but also the need to be able, especially for partners and donors, to be able to think creatively about bringing the emergency part of their response and the development part of their response together. And so when we talk about having basic packages, we need to have basic packages which are installed in more of the sense of an ongoing development approach, but also be able to have an emergency approach. And I'll just also note that, I mean, we, again, thinking about the donor-partner perspective, the ability of donors to work cross-border has been problematic over the years because of the way that they are internally structured frequently. And so in this context, needing to think again more creatively and flexibly about how donors structure their own portfolios to be able to meet some of these particular kinds of needs. Thanks.
Thank you very much. And the table at the back of the room, any observations from there? I see lots of heads looking at the table. Did you guys discuss this at all? Silence. No. You're in a different group. Okay. Well, let's move on to a different group then. But just actually, just to summarise, there's some good ideas around how to actually tailor the response. I think drawing from the experiences in Afghanistan, working with communities, how to do that, and giving government the right to ensure that the approach that's chosen fits the needs of the country. Having a basic package, we've got to get progress on coordination mechanisms. What we have at the moment isn't working. The usual issues around linking humanitarian and development, but I think also then looking at whether donors can put this into place. Are there internal restrictions that mean that something which we know will work can't happen because of bureaucratic rules within the donors? So moving to the second question, are there features outside the building blocks that we need to think about? And that was this line, the next line. So who wants to answer that? This gentleman.
This on? Oh, good. I'll do my best to summarize our discussion, which was quite open. We tried to be a bit creative, but it's a difficult question, but we tried to really sort of focus on a few areas. We started by discussing it's really important to understand the context. understand the political economy of what's happened, and why the government cannot provide services, cannot govern, and really to understand the context of fragility. What are the major factors? Need to be practical to do what is possible to provide essential services to the population, health services, but at the same time, do no harm. Don't make things worse. Your overall goal over time is to help rebuild institutions which will be sustainable, can provide services over time. But to do that, you need to empower individual and communities to deliver essential services toward UHC. And using the goal of UHC as a means to an end to build institutions, to build the infrastructure, both the people plus the software plus the hardware. And we concluded by talking about the critical importance of NGOs in helping build institutions and providing services to communities and population in these fragile states. I'm not sure we've found the answer, but we identified several factors which could be useful in trying to respond to fragile states and ensuring the provision of essential services and moving toward strengthening the state and reducing fragility.
Thank you very much.
Anything I missed? Everyone's nodding.
Any other comments from that row? I think you all got together, didn't you, in a very efficient way. Very good insights there, again emphasising the need to work with local communities, with NGOs, being realistic, not assuming we can sort everything out. I think the principle of don't make things worse is something to keep in mind, but also an aim to empower communities and actually deliver something over the long term. So UHC as a means to an end, I like that conclusion, that we can use it to build the institutions that are needed to build states and build peace. So moving to this row here, I think you were looking at incorporating state building into the design of health system strengthening interventions. So who wants to answer that question? I see a lady there with her hand in the air, so I'll ask you to start.
Speaking on behalf of these three tables here, we discussed third question, although as I look at what we have as our summary points, we go between the first and the third question. So we started with what do we mean by fragile states, how do we define them, and a consensus that let's not use the term fragile states, let's call them fragile contexts, fragile settings, unstable contexts. And in terms of what classify as fragile contexts, it could be, are these countries or regions at war, just after war, countries, regions affected by in-country disturbances due to left-wing extremism or right-wing extremism for that matter, high-income countries affected by financial crisis where the systems have collapsed. So all these should be identified as fragile contexts. And when we go into these regions, we need to start with understanding the context, and that has to be done along with the local people, with the local communities, which is what I think the last two groups have also stressed, involving the local people in that, and also involving the government, since we are talking of the state building, involving the government in that process of, so that helps in building trust and doing it through a democratic process. Understanding the diversity in the population, there may be different kinds of groups in that population, different ethnic groups, different caste groups, different tribes. So understanding that diversity. See what is existing. There may not be a functioning system, but there may be individual providers who are working there. So identify those and leverage them. Build the capacity of the local communities, their leaderships, understand them, and try to build the system from within the community and within what is already existing. If there are multiple agencies working in a context, then coordinate through one mechanism so that the community and the government have one point of contact. And also this working in fragile context could also be used as an opportunity to build and revamp the whole system in the country, as the example of Liberia was given. Thank you. If I've missed something, group members can add, please.
Okay, thank you. And I think that's echoing a number of themes we keep hearing about, working with local communities, understanding the local context, and the fact that this work can help build institutions and build the state and the nation more from within and through UHC. So, final set of tables. Who wants to take a crack at answering the question about the language for fragile and unstable context? We've already heard a few of you mention this already. So, who wants to answer that question? You did appear to be talking to each other, so I assumed you were talking about this question. Who wants to answer that one? Okay.
We started, thank you, our discussion here looking at the need to be realistic with the language and focusing on describing the situation as opposed to creating a name. And so, but at the same time, not being disempowering through the use of the language. And that means taking an asset-based approach or contextualization to what we're saying, recognizing that there are skills, capacities, and resources even in the bleakest of situations and contexts, and that's what we need to be working at building on. And in that sense, I think one of the little anecdotes that sort of summarized our discussion is looking at the phrase, is your glass half full or half empty? And it's not the empty or the full that's the important part, it's the half. That's the description, and that's what we're working with, and that's what we're building from. So I think that's our sort of quick summary on that. But the end result is, yes, fragility, the situation, the context, that's what we're describing, and those kinds of terms are the appropriate ones to use.
Yeah. Thank you. Anyone else who discussed that issue want to chip in this table here?
Je crois que dans notre groupe, c'était une table, nous avons aussi réfléchi par rapport à la terminologie. Et nous avons suggéré que cette terminologie soit adaptée au contexte et soit aussi adaptée à la situation. Et que nous avons analysé beaucoup de mots. Il y en a parlé de sensibilité, d'état fragile, de crises sanitaires majeures, d'insécurité, d'état d'urgence sanitaire et zones d'instabilité. Mais après synthèse, ce qu'on a retenu dans le groupe, la table, c'est parler d'instabilité. Et ça nous amène par rapport à une situation, et dès que cette situation est réglée, ça va nous ramener vers la normalité. Voilà. Merci.
Merci. Thank you very much. Okay, so I think we've heard other messages then reinforced there about understanding the context, understanding local communities, and choosing phrases which show there's something there and we work with that. I asked you and I asked the panelists, what are you going to do differently after this session, after these 2 days? Anyone want to chip in? Just a few of you want to say, what are you going to do differently so that we meet what we've all been asked to do for UHC? I mean, certainly I can say that I've realised through these last 2 days and through this discussion on situations of fragility that the aid effectiveness battle is far from over, and we've got to get down to looking at that in OECD. I've also realised I need to start talking to my colleagues in the tax directorate to start looking at how we take that knowledge, how we make progress on some of the efforts to improve tax transparency and stop illicit financial flows so that we can bolster the resources in countries so they can spend their own resources and sidestep some of these problems of donor coordination by having more own resources for health. So that's something I'm taking from these 2 days. Ask Mr. Yasande, any observations from you that you will take back?
Ce que je garderai surtout de cette rencontre, c'est qu'on est tous conscients qu'il y a des problèmes, mais qu'il y a une réelle volonté de part et d'autre pour surmonter la situation actuelle et d'aller de l'avant. Donc, la couverture sanitaire universelle, c'est un idéal, c'est un chemin à atteindre, et on ne peut l'atteindre que si on va ensemble. C'est ça vraiment le message que je ramènerai en Guinée. Merci.
What came out strongly in this discussion is the role of civil society and communities. So in this context. And what I will take home is a fight to make sure that when we talk about UHC, we talk about systems for health that include the health systems and the community systems. And I'll make sure from my side to push that is the way this is approached, and also with WHO making sure that in the 6 blocks fundamentals we do have communities and CSOs clearly there, so we don't take a health system, purely health system, the 6 whole blocks, but we have that element in. And if I just can make one comment related to the Roman Empire, Rome wasn't built in a day. So what you need on day 1 to build Rome is not what you need on year 5 or year 10. So we'll have to be very careful on not going for a one-size-fits-all. Also remembering that Emperor Nero burned it in one day. So that's a big risk when you work on this endeavor. So.
Good use of Roman terminology to remind us of the situation that we're in. And yes, any thoughts from you?
Yeah, I'm very happy then when we get guidance from all civilizations, which have disappeared. And I think what I really take home first is I think 2 things. One is really how much we are a community with a common destiny, and how much there are common themes. That what is happening today, and that's been very much the lesson of the Ebola crisis, what is happening in Liberia and Guinea and Sierra Leone affects all of us. What is happening in Syria today affects all of us. We are one world. And it is really, for me, really the sense of building this new movement together is how do we bring all these different efforts. We are all working every day towards very concrete outcomes and trying to change certain things in different space and different groups, but how here we can have together elaborate the common vision, the vision of the common destiny. And the second thing is really that we need to work differently. Hopefully we've learned something. And that's very much the case here when we talk about fragility and the difficulty in working, and the fact that we don't know, and we are just at the beginning of starting to have an idea about what we don't know, and a few things that work. And we should really not hesitate to work differently, because there's no point in repeating the same old mistakes. It's much more interesting to make new mistakes, and maybe by making new mistakes to be able to actually at some point be onto something. So that's really my 2 cents.
Thank you. And finally, I'll turn to Nigel, because the audience were too shy to tell us what they were going to do differently after this discussion. So maybe, Nigel, you can tell us what you think we should be doing differently.
I have one observation and one plea. The observation just comes out of the ideas from the table, this idea of really understanding diversity and the glass half full, that all these contexts and countries, they have immense capacities that we don't yet understand. So I think that really understanding that and then translating that from the UHC point of view into where are we already at. So breaking down UHC, rather than thinking we have to have a national health insurance scheme tomorrow, what do we already have, and what are those resources that are available locally in terms of human resources and whatever that can create it. I have one plea, and that is the language. Because if we go out of here and we say, I've just been looking at IHP Plus for UHC 2030 for HSS, nobody outside this room has a clue what we are talking about. We have to get the language, as we discussed with fragility, we have to get good language. I think something like universal health, or something that people outside this room understand, we have to think again, because if we just talk in bunches of acronyms, unfortunately, our message will be lost, and I'm sure our communication colleagues will tell us that loud and clear. So let's think a bit more about some of the language surrounding it as well. Thank you.
Well, thank you very much. Thank you to you for working so hard. Thank you to my panellists. Thank you to the moderators over there who are now very angry with us. But let's give ourselves a round of applause.
session. So interesting. Please stand. Everybody stand. Yoga. Unfortunately, I am no yogi. So, Yamin, is there a stretch that you want to encourage us to have as we go into this wrap-up, last, concluding session of the 2 days? If no, actually, wait. Are we just going to stretch again, upwards? Huh? Let's see how long you can stand on your toes. Stretch, come down. One more time. We can, no, come on now. I didn't sing Kumbaya yesterday, we're not. All right, thank you all. You can have a seat. Because the more I do this, and then I'm going to complain about not keeping my own time. We're now coming to the end and trying to make sense of all of the input, the contribution that we've had. Before we actually go on and present what Lara has spent the past 2 days just busily capturing and making sense of a lot of the things that you've discussed, may I ask Marie-Paul Kenny to come up to give us just a few words before we actually start looking at some of the elements that we're taking out of this room. Marie-Paul, who's joined us, thank you for joining us, is the Assistant Director General at the WHO. Thank you. We haven't been very good at clapping. Can we just try welcoming her with a strong clap? Thank you.
Thank you very much. It's a pleasure to be with you today and to have this opportunity to address you, even though very briefly. So it is not yet the time to close this very interesting meeting, but I would like to already on behalf of the bank, of Tim Evans and WHO, I would like to thank you all for your participation in these 2 days of discussion on transforming IHP Plus into IHP for UHC 2030. So I have been here at the inauguration at the beginning yesterday morning, and I've spent the afternoon with you, and I was impressed by the high level of energy and enthusiasm that was also visible during the time of a family picture that we took earlier today. So I believe that the ideas that you all have put forward will go a long way to help us shape the thinking on the functions of a new IHP for UHC. So we will, of course, continue to, this is only one step in the journey, we will continue to consult through several avenues as we want to travel this journey with you together. So we welcome the continued support of IHP Plus partners in this journey to the transition. At the same time, consistent with the broadened mandate of UHP for UHC 2030, we hope to be able to further engage with middle-income countries, with private sector and others who have not been part of, previously been member of IHP Plus, in order to see how we can together shape this new platform that we want to create in order to help all countries achieve UHC and health for all, of course. So I would like to thank you all again. There has been inspiring discussions. I was very impressed by the quality of the discussion that we have had all together today. And for this, I would like to thank you. So thanks a lot, and I wish to have an opportunity to continue seeing you often here and other places as we move forward on UHC 2030. Thank you very much.
Thank you so much for that. One of the things that in meetings like this, there's a lot of presentations, it's a packed agenda, and sometimes we don't actually pay attention to how much content you're all putting on the table. And sometimes you put out a word and it's been captured and you're not actually necessarily conscious that it's being picked up as some of the things that will be fed into the process moving forward. And over the past 2 days, Lara has brilliantly been doing that. What we'll do for this last session is she will present for 15 minutes some of the key highlights that have emerged. And we will go back again and have quite a bit of time for you to identify, are we missing things? Are there things that were not adequately captured? It is not necessarily trying to summarize and say, this is the agreement, it's really to capture for a consultation. So it's not to have an argument about whether this is right or this is wrong. It's really taking what everybody has to bring to the table so that can be fed into the process. So, Lara, are you ready? And is the presentation ready for that? So just 15 minutes, and then we'll open again. So you've all been listening and you've all been paying attention. So continue to do that. And a clap. Come on now.
Thank you. So the session was, I think, called Conclusion and Recommendations. We certainly don't have a conclusion yet, and we don't have recommendations. They're what you've all been saying for the last 2 days. And we need more time to digest and synthesize that wealth of information and ideas. So this is just a snapshot of some of the things we've heard and are hearing, and we will spend more time going through, and particularly today's afternoon. I'm sorry that a lot of that rich conversation hasn't yet been captured. I need a pointer. Sorry. It's there. So we are listening, and we do hear you, as the slide tries to say, and a few captures of your faces, speaking, looking, attending this meeting. What we've heard is that the needs are many and they are very clear. A few ideas as to things that are driving this need. Country coordination is a massive agenda. It's a big, urgent priority. We've heard, I'm not going to read the full slides because I've only got 15 minutes, and your eyes can follow the slides while I talk. But we've heard the urgent need for this. We've heard the experience of countries that receive development assistance shouting loud and clear, we need to do this better. We need to be more collaborative and coordinated in the way that we deliver external assistance. Whose priorities, targets, and indicators are we responding to? Countries have said loud and clear again that they want to lead. Partners have expressed their willingness to adapt and align. How do we shift incentives for behaviors? And how do we make sure there is this mutual accountability? We've also heard a lot about the political nature of universal health coverage, the political economy of leaving no one behind. These are crucial in thinking about what UHC 2030 should be. UHC is underpinned by the social contract between citizens and states, and fairness must be our consideration and our compass for assessing progress. So we need accountability, we need transparency, and we need participation. Oh, this clicker isn't doing it for me. We also have an opportunity for change. Now is the time to act. We've heard various people making this point. UHC is not business as usual. This is the first day of the rest of our lives. Well, now it's the second. We have a renewed commitment to do business differently, and we must act on that willingness that we've expressed here. So what is the potential added value of this international health partnership for UHC 2030 that we've been talking about? As I said, we haven't captured a lot of what you've been expressing these 2 days, but we've tried to capture some of it. It is a platform for collaboration and coordination. It's a partnership of the willing. It's not just about integration. In fact, it's not at all about integration. We're not talking about taking on board and encompassing the other partnerships and networks that exist. We're talking about a flexible and nimble approach to working together, adapting to local needs. We need to map what's going on where, who's doing what, and in what ways. We need to explore different models for working effectively together. We don't have all of these answers, but the questions have been raised, and they're important for us to address during this consultation phase. We also need multi-sectoral engagement for policy coherence. We heard that very clearly today. We haven't elaborated on that point here because the synthesis was already, we didn't have time to capture a lot of the points there, but we've heard it loud and clear. We also need the UHC 2030 to be a platform for learning and exchange. People have asked for a global repository, a portal, an evidence hub. We need to facilitate peer exchange and review. What about the accessibility of evidence, language, format for different audiences to be used by the multi-stakeholders involved in UHC reform? How do we complement and leverage existing initiatives? We've heard a bit about the Joint Learning Network, about Health Systems Global, as mechanisms for bringing together some of these stakeholders involved in the evidence agenda. And how do we strengthen in-country capacity for implementation research, health systems research, to influence policy and make sure that we're driving change with the evidence that we generate? And accountability has been mentioned numerous times. In fact, it's spanned, I think, most of the sessions that we've had on different topics. What do we really mean by accountability for universal health coverage? We need to further unpack. But some of the things that have come through loud and clear again are the fact that IHP has been committed to the issue of accountability, to this agenda from the outset, but it needs to do it differently and better. We have had an effort on monitoring development assistance, but now we need to expand that access of accountability to be much more around the relationship between citizens and their state. We need to broaden this agenda beyond just the behaviors of IHP to the agenda of health system strengthening in UHC. How do we make sure that all stakeholders are working towards that common vision? We've seen the example of the Health Data Collaborative as an effort to apply these principles into practice, changing the ways in which we work. This is specifically around the agenda of data, which is a crucial part of this agenda. However, it's not sufficient. We need to make sure that evidence comes with a purpose, that evidence drives change. Do we need tools to enable that, such as syntheses and scorecards of evidence? How do we bring a human face to those who've been left behind? We also need to make sure that review happens for accountability in a way that brings the independent voice to the center, that considers the multidimensional aspects of universal health coverage. We need to ensure inclusion and participation. Who should be around that table? How do we ensure effective representation? And we need to drive remedial action. This is something that I don't think we've managed to tackle very well these 2 days, and I think it's a very difficult question. What are the incentives that change behaviors, and how do we influence them? Advocacy is one way in which we may be able to influence those incentives, and we've heard a lot about this being a movement that needs to have people at the center. We need to build and maintain political momentum for this agenda. We've got a lot at the moment, but how do we sustain that through the next 15 years? Mirai Chatterjee said that we need to build the movement from below, and I think that captures a lot of what this should be about. It's about people and amplifying voices, as Lola said. So we need to empower citizens. We need popular awareness. We need demand and ownership of this agenda by people. We need to strengthen capacities for evidence-based advocacy and effective participation in political and technical debates. And we need persuasive messaging and communication to bring along the masses with us in this movement. We need tools and approaches that UHC 2030 can deliver. These are global public goods for this common approach. So some of the things that we've talked about today are the health systems assessment. I was here this morning for that conversation, and we captured some of the points around that help to inform the way in which we might think about taking this forwards. We also need a common approach to transition process. We need to think differently and collectively about how do we deal with health systems in UHC and support countries that are going through complex and fragile circumstances. And we need a flexible approach is what I think the key message has been through those sessions. So how do we be nimble and flexible, but also be coherent and collective? Are there other tools that we need to consider developing? There was a recommendation for, fine, we can assess health systems, but how do we work more collectively on implementation of health system strengthening support? And we've talked quite a lot about multi-stakeholder engagement. We have said from the beginning an IHP Plus is a multi-stakeholder platform. UHC 2030 should reflect a broader multi-stakeholder constituency base that is defining the SDG area. So we've talked particularly about civil society here in these 2 days, but I think we need to think a lot more proactively about how and what do we do to engage the private sector, which parts of the private sector. These are not homogeneous entities. They're very complex constituencies with very varying interests. How do we engage parliamentarians and support them to be that interface between citizens and their governments? How do we engage the media effectively in this journey, in this movement? And similarly with academia, how do we support them to be that nexus between evidence and action? So I think I will stop here. Am I on time? Wow. Got plenty of time. So, and this gives us more chance, I think, to hear from you. I'll hand back.
That deserves a stronger clap than that. I hope everybody appreciates how difficult it is to not only capture some of these ideas, but make them make sense and summarize them in a way that actually has categories that we can actually see what some of the core issues that have emerged have, and to be able to do that in barely 10 minutes. Impressive. Are there things already that you're seeing are missing? Things that you think have not been captured, things that you feel should be captured, that we should include in there? Anybody wants to get started? Oh, I thought you were going to say everything's been done already. I see you, Sam, starting first. No, and I'll go to you, and I'll come to you. So yes, please, go ahead.
Thank you very much, and I want to thank the previous presenter. I started by thinking about what is missing, but at some point my mind shifted to who is missing in this whole process. And actually towards the end of the last presentation, there was a mention of a lot of discussions about civil societies, the private sectors, and so on. And as I looked through this room since yesterday, I was wondering how much this group that we are talking about is present or missing in this room. Different continents have different players in the health sector. Different countries have different players. But I know for sure that the continent I come from, that's Africa, for example, the faith-based subsector is very, very significant. And while I work for the church, I am probably not here officially, representing the church, but I bring all the ideas that I know there. And I see this faith-based subsector is not officially in this room. Is there any other opportunity for constructive engagement with them? I so happen to be a member of the board of directors of ACHAP. ACHAP is the African Christian Health Association. And so I can assume to be representing them in this forum. In general, I would say let's look out for people we have missed in this consultation. So when we talk about we, who are we? The second comment is about the multi-stakeholder, approach in UHC, or multi-sectoral approach. This is very important. And for me, one of the things that it brings to the table is not only looking at universal health coverage as being sort of health for all, aiming at health for all, but also aiming at all for health. Bring everybody to the table for health, including the users of health. However, I just want to leave a caution that when we push this forward, there are countries where people will say, yes, at last we have come to recognize that even if we are perhaps giving a small budget to the health sector, we are in fact putting a huge budget for other sectors that are determinants of health, infrastructure, energy, and all the rest. And yet we continue to argue that the health sector must have a bigger budget from the national governments. So what do we need to do? I think we need to start putting a case to governments and to the other sectors that without the health sector, there is a negative effect even on the other sectors. That the health sector plays a big role, and that's important for the other sectors.
The other argument is about...
Can I also ask you, because other people will add, can we, I don't want to stop you, but can you go a little bit faster, because there's a lot of additions from other people as well.
Okay, thank you. Maybe finally, I just want to just stop with one. We talked a lot about health system strengthening. Can we unpack health system strengthening so that we make sure that we avoid duplications, that we create linkages between the different efforts that are being made in health system strengthening, and we don't have absentee landlords.
Okay,
thank
you. Samuel, yes.
Thank you. I think the presentation really tried to structure a lot of the conversation that's been done yesterday and today and did a very good job of it. But I think the next level of tasks, more to be done by introspection than can be possibly done in a consultation, would be to then filter what is it that the IHP Plus for UHC 2030 can best do. Because many of the consultations and messages were about UHC as a whole and things that the whole universe needs to do for universal health coverage. But within that, I think what we need to now look at the next step in our thinking is how do we prioritize where UHC 2030 is the best fit and where is it that our best value lies, looking back at what has been the best achievements over the last few years of working as IHP Plus.
Okay. Thank you. Just before, I'm staring at you, Max, now, because right after this piece, we're going to look at what next, and hopefully that will shine some light onto how those steps are going to be taken forward to make those choices that you're talking about. But thank you for that. And yes, go ahead. Yes, you. Yes.
Hello. Well, Dr. Wiloj is perhaps expecting me to say something. I'm replacing him at this meeting. You have pretty much covered all the added inputs that I have written down for him, and but I would like to add on the learning and sharing group issue that you have proposed. From my observation of the Thai health reform, I think it would be helpful if you can identify key UHC implementer or mover of the target countries to and include them into this sharing and learning loop. This implementer or mover can be the expert themselves, or otherwise a mechanism will have to be established to select the right person to do this job. Thank you.
Thank you so much. That was the first round. I know I just saw a second round, but I want to also give the opportunity and use the fact that I have the mic and that I can, to go to another Sam, because in the beginning you spoke about private sector and whether or not private sector was part of it. And I just want to find out if there's anything that you want to add to it, because your co-Sam did mention who was at the table. So I just want to sort of flag that, as that was one of the last points in this session. But I'm calling on you. You weren't prepared, so I know it's going to take 30 seconds.
I think I've so much to say, but I'll stick to your time. We really need to look into this issue carefully now, because we are looking here at what is happening, and we're saying that need country-driven agenda. But also we need to see who's going to finance that. And that's where the important part of financing is coming. All actors have got to finance this. Domestic resources, that taxpayers' money, plus the private sector, that employs up to 50 to 80%. And that also is very important to make sure that the employers are getting what they need. We need to build a business case to talk with the private sector, to see the added advantage of coming in and joining hands and saying, look, when everybody comes in, you're going to pay less for the insurance for your employees, and then you can see what you're going to get as benefit. All private sector need to see business case that will help them to see the need to join hands. That's very important thing that I'm saying here. But I'm also seeing something here that as a comparative advantage and strengthening that at the moment, what we need, we don't need agendas that are driven and data are taken to different countries. We need to build our own data, use our own data in the country, and try to build a business case within our own country. And that needs sitting together, all of us as partners, and working together.
Thank you. And I know your neighbor has been wanting to speak. Yes? So while I'm at that table, I'm at as well.
Thank you very much. What have we missed? Well, the first one I would say how to avoid falling into the traditional donor-recipient habits. I mean, and do justice to the SDG because we are supposed to have changed the paradigm, so we must really be serious about it, which means joint responsibility. Another thing is how do we ensure that countries which moved recently to UHC and have a lot of experience are coming and sharing and join these initiatives. The third one is how do we foster a real movement and avoid the bureaucratic or technocratic trap. And then how do we approach the political issues of equity in access to health resources? There was a slide of Professor Bump on that, which was quite interesting. For instance, taxation issue at global level, IP regimen, financing research and development for neglected tropical disease, and many others. Then how do we address all the determinants, the non-health system or health service or health sector determinants? And finally, once we have solved all that, if we manage, the overall governance of this alliance. Thank you.
Lola, I had seen you, and then just can I see a show of hand who wants to speak after her? We'll have a bit of time. Don't worry. I see the two of you over. Ooh, this is becoming overwhelming, but I will manage. I'll just ask everybody to be short so that we give everybody a chance. So I'll come to your table, I'll come to you, I'll come here, and then I'll come to you. Yes. Did I see everybody? That table, your table, this table, and this table. Yes? Okay. Lola, go ahead. Please stand so that the microphone operators can see who's speaking. Yes.
Quick things. Health systems were very, very extensively discussed. I think we should have health systems in there, added there. We also discussed domestic resource mobilization from different options and different sources. I think we should have that in there. And UHC 2030 as a movement or a program or a concept also needs to be there. Thank you.
Yeah, thank you. I'd like to see strengthen the concept of representation, not just participation, but representation. I think it's particularly needed if we want to go beyond the usual suspects, including on civil society. You did refer to members of parliament potentially, but if we want to have that bottom-up, member-driven organizations and mass organizations, the notion of representation at country level and within a UHC 2030 would be essential. Thank you.
Yes, thank you. Well, thank you for the facilitation and everything. To move forward, I think we should challenge ourselves to indeed move beyond the health sector and the actors we're working now and tie it to work on the Sustainable Development Goals and the high politics that is. So really see it as a foreign policy issue for stability and peace and sustainability. So link it quite closely to security, economic, sustainable development, as well as addressing inequalities, social protection, those actors and those ties, and it's important for countries all over the globe to come into this compact. We can be much more bold about that's the aim of UHC 2030. And then we move away also from this traditional donor-recipient kind of logic where we really need to go. So that ambitious aim and the communication to it and talk about that in a way that we all feel comfortable with is something we could still develop.
Thank you, and thank you very much for everybody, and especially the core team for your great work. There is nothing missing, but I think I want to add one thing. Is what does it mean by go beyond our usual business? One way I can propose is that we should go beyond our own narrow interest or narrow circle of interest. Sometimes we tend to compete for the resources or by the initiative. So because people want to be the top of their all leaders, but in this new era of SDGs, or to achieve this ultimate goal of UHC, we must go beyond our interest. We must think about the broader public goods and to achieve UHC. So we may have to change our philosophy itself for developing assistance. So that's what I want to say.
Thank you. And there was, yes, go ahead.
Thank the meeting organizers for putting together a great program. I think this meeting has been really incredible. We've really covered a lot of topics. We haven't solved all the issues, but really a very important meeting. 4 quick takeaways. Max's slide on the complex architecture, health architecture, with all the players, all the initiatives, very complex, very chaotic. IHP UHC 2030 has the opportunity and obligation to move towards simplicity, increased collaboration, increased synergy, increased impact. This could be transformative and a game changer for many initiatives by having us work together. It could be the glue of many initiatives. The critical, I think Nigel's talk was great before on fragile states which are with high fragility, highlighting the critical importance of governance, country ownership and leadership in all phases of fragility. And finally, this meeting reemphasized the critical importance of non-state actors, including NGOs and the private sector, moving forward. Thank you.
Simon, and then I'll come to you. And oh, there was 2 at your table. I'm sorry.
It was my twin, yeah. Thanks a lot. I think the proof of this in the end will also be whether we actually manage to provide some quality services. And making those concrete. So to me, I want to go back and actually think about what is that health system bottom-up level. And the health system actually, by some definitions, include the household and the community as opposed to health services. So if we're in that first mile health system, as I like to call it, it's not the last mile, it's the first mile from where I live, and building from the basic community up, maternal, child health, etc., getting quality into the services there. That to me is a critical takeaway. I'm less worried about the advocacy, moderately worried about the financing.
So I'd just like us to leave with what I think I've heard from everybody over the 2 days, which is a commitment to try to build a political movement for universal health coverage. That's what we've been talking so ambitiously, and it will take that. And that's different to what the IHP Plus has been doing, and it's different to WHO's technical assistance to countries, although both should be part of it. But to do that, we need to build a very broad partnership.
Thank you. And yes, go ahead. Can I see if there's burning, just to have an idea? If there's none, there's somebody that I'm going to actually target just because I can in a minute. I'm just smiling at you so you know I'm coming to you. And she smiled back, so she knows I'm coming to her. So yes, go ahead.
Yeah, thank you very much. My name is Akashi. I would like to emphasize the UHC is not always happen by the authority. That means that the voluntary, community voluntary activities can be one of the trigger. For instance, in Japan, one mother started to clean up the town to avoid her children's injury, and also the one company, factory workers start their mutual for mutual aid. They put the small amount in the kind of bank, and then to support the injured workers from the no payment. Yeah.
Excellent. And the last 3 speakers have gotten the real good transition in terms of just pointing back at the communities that this is supposed to serve, at the people that this is supposed to serve. And Mirai, did you have any thoughts, any additions at this point, any things that you think in terms of what was captured that was missing, particularly looking at that aspect or others? You need a mic. There's translation, so you do need a mic. Okay.
think it's exciting. We're coming together, and I do see that there is potential. Movement seems like a big word, but at least the first step is an alliance or a coalition to push for UHC. I think one thought I'd like to leave is how we can translate UHC into simpler language. It has been spoken about several times, so that women, informal workers, and others can begin to understand what it's all about, and that it really is about them, and it starts with them. And I commit to trying to help in that process.
Fabulous. Already commitments are being put on the table moving forward. I'm not going to attempt to do what Lara just did, but just to capture some of the categories of things that have been put on the table that many of you are agreeing to. On the one hand, this notion that it has to be about impact, and it has to be about people, and it has to be beyond the conversations that are about networks, but that we have to focus on what impact this process is going to achieve. That will come in two ways. On the one hand, through building this political commitment around universal health coverage by 2030, but also beyond the political movement, making sure that we are looking at simplifying who are we targeting, who are the people that need to be benefiting from it, and that's everyone. But that will go through ensuring that in not only the conversations and the language, but in the work that is done, it's clear, it's simplified, it's prioritized, so that people actually be able to do those things and do those things well that are going to be able to get that. Then there are two other categories that have emerged. One is the acknowledgement of how political this process is, and political at every level, political in the notion of equity that this is pushing, which is not something that everybody agrees with. People might agree with it in theory and in words, but in reality, it might be a challenge. That it is political in the relationships, whether it's between donors and recipients, that it's political in the relationship at country level, that it's political in who sits at the table, that to acknowledge all of the different political dimensions, which may or may not be challenging. And then finally, which is obviously linked to this political dimension, but not only, is who are we bringing along this path? And everybody that is along this path has different roles. There's obviously the role of being a strategic partner of the process, but beyond that, people can be the key that are bringing the real movement from the ground, others that are making the argument for the business case, because it's been clear how this makes business sense. And that the funding for it, which is not only political, but even in terms of practical implementation of this process, is important. So really ensuring that all that it affects everybody should be at the table. Knowing who plays what role at the table is important, and being able to support the contribution that everybody makes in representation, but not just participation because it needs to be a wider group, but the participation that really looks at what everybody brings to the table. So these are just, I know other people have been capturing in detail, but those are some of the categories that have just emerged from this conversation here. I hope I have not misrepresented, not adding, misrepresented. I have. Please correct me.
I just beg that we don't take the word political as political itself. We can call it political, social, economic movement, but not just take it as political movement.
Okay.
Thank you.
Point taken. Another point taken. And this contribution that a lot of people have made into language. So thanks for contributing to that, but not just language in actual names and words, but even in the language that is used. The notion of fragile states was something that brought in language, so thank you for that. Are we okay? Yeah? What happens after here? Does anybody know? We go home. We do that. But after we get home, there's still work to be done. So I'm going to call on Max to come share a little bit what are the specific next steps moving forward, so that you know that all of your work and your hustle and your long days and nights have not gone to waste here.
Thanks, Valerie. So it's been a long day, so obviously this is going to be very short. It's one slide. So what are the next steps? And I think Samuel touched on that briefly. As we said from the beginning, that this is a transformation process that requires a lot of consultation. So we see this as one of the series of consultations that we should have. So after this, we plan to have a public consultation online through the IHP Plus website, focusing on key questions that we would be open to the public for them to comment on. Another way we would like to, we hope to consult will be targeted outreach to constituencies that have not traditionally been part of IHP Plus, such as middle-income countries, high-income countries, parliamentarians, member-based CSOs, etc. We would also attempt to do specific consultations on the CSO engagement mechanism. There was a presentation that was done about it. This is really special, so we would like to have some special focus in terms of consultation on that. Next step would be to also refine and update the work program for 2017. So as we say, this is perhaps the second day of our lives. We need to have a work program to work on. I'm sure this is where the meat is, so that we can actually show some traction in terms of what UHC 2030 can achieve going forward. So that's something that the core team will be working on very, very hard after this consultation. We also hope to update the Global Compact to reflect the new reality of UHC 2030. The old compact was premised on IHP Plus. Obviously, we now have a much broader mandate, so there will be the need to revise the compact. Now, how do we do that? There is a transitional steering committee that will be put in place. This will build on the IHP Plus steering committee with the inclusion of representatives from different constituencies, such as some of them are middle income, high income, and other private sector organizations that have not traditionally been part of the IHP Plus, to make sure that this new constituency reflects the new face of UHC that can take a crack at the compact and make it more comprehensive. And then there will be other events that we hope to be able to capitalize on to provide update on this transformation process, and also keep up the momentum, because we really need the momentum to keep going. And so we will target events such as the UNGA and others to provide updates on what is going on this new partnership. And finally, hopefully, next year during the World Bank and IMF spring meetings, as well as at the World Health Assembly, there will be an opportunity for new members who would like to join the new IHP Plus for UHC 2030 to join. So these are the next steps, and we'll continue to stay engaged and keep you in the loop. All right? Thank you. Any questions? Yeah? Did you want me to take questions?
I don't know if there are clarification questions. I mean, crystal clear?
Everybody's tired. They want to go home.
Going once.
I can escape. All right. Thank you very much.
All right. Thank you. We might actually finish on time. Ha, ha, ha. We have 6 minutes. I don't know how... Ermin, we have 7 minutes. I don't know how long it will take us. It might be a little longer than that, and we'll allow for that given how great everybody has been. To give us closing words, I have the pleasure of asking Ariel Pablos Mendes. I saw a hand. Somebody is wanting to clap early as you're coming up here. Who's Assistant Administrator at USAID, to give us closing remarks. And from that moment on, it will be the end of our talking. So
thank you. Thank you very much. And thank you for staying till the end. That's great. We can see who are the real champions. Universal coverage is indeed a concept that is old. But the global movement for UHC is not. It's something that many of you may recall how it all was born and has evolved in the last 10 years. 2005, the World Health Assembly resolution on health financing for the first time mentions the idea of universal coverage. I authored a paper in The Lancet in 2008 calling for all for universal health coverage. When I was at the Rockefeller Foundation, the World Health Report 2010 that David Evans and the team led was very important. It really opened the door big time, that movement. Then the UN resolution in 2012, when France and the US co-sponsored, calling all member states to move in this direction. Big discussions in the SDG, in the lead up to the SDGs, ensuring that UHC also became a formal target for the SDG for the world 2030. We talk about SDGs being universal. Well, universal health coverage is the most, because all countries are in this game. Nobody has perfected the game. And we are very happy, of course, with the leadership of Japan and the G7, a positioning UHC in an incredible way. I mean, just like in 2001, Japan led also the way with the Global Fund. At the time was the right prescription. Now it's a different world, and so it's appropriate to call for a different way of working. It's I do stress the term a global movement, and we can be economic and social and political. Indeed, UHC is all of the above, and Simon stresses that, understands that. And as we, as a community, plot new platforms to keep driving this momentum, monitoring, accountability, we need to do it with great care. There's always a risk that we over-engineer things. And when you have an actual movement, it's hard to try to bottle the ocean. But we have many opportunities, of course, regularly engaging the World Health Assembly, the World Bank's meetings, as we heard, as the follow-up, very important, the G20, UNGA, follow-up to G7, of course, and many other forums. It has been good for WHO to bring together many of the pieces within WHO on health systems to try to, because in the end, UHC is about the true north, as the Toyota engineers call it, for health systems. UHC is the true north. That's what health systems are about. And so it's good to see many of those pieces aligned. And I also stated repeatedly, as many of you know, that it's very important to ensure that we also continue to engage the World Bank, ILO, and many of the other sectors and global partners, and the UN itself. UHC is rarely only or mainly driven by the Ministry of Health. Actually, that's the exception. And we need to continuously work on what will be a more democratic governance of this global movement, and we heard expressions of that also here during the afternoon. Civil society, the private sector that accounts for half of the health sector and so on. Last decade brought many top-down initiatives. It was the time for PPPs, and we had many, small and big. They were all top-down efforts to help the poor. It was a different mindset. The next decade, it will be different. It will be more robust complexities of mixed health systems, and we are moving from what was global health to what is going to be a new world health. And all models will not fly. So we can learn a little, but we need to be very, very creative as we move forward. Universal health coverage is really about countries and domestic resource mobilization, not so much donors and ODA. As I explained in my presentation, that's going to be a small part of what happens in the future. And I do want to say that in the Global Health Leaders Group that meets twice a year with the heads of agencies, the bank, Margaret Chan, and so on and so forth, there was a discussion of this. And I think that while UHC personifies many of the principles of IHP+, too explicit a linkage in the communications may actually be hurting both of them. And I want to just offer that to you. That is about UHC. Let us move in a direction. In the soul, the principles of IHP+ have to be there, but not make the UHC movement so as a place to litigate what are the lessons of IHP+, how do we evolve it. Just at the very least, consider that from a communications perspective. I personally signed IHP+ Compact for USAID 3 years ago. But for people in the street and for heads of states, universal health coverage means a lot. Paris principles, they don't know about. And so I think it's important from a communication point of view. So let us harness the energy across many key global institutions and, more importantly, the countries themselves. And we all know it, but we sometimes just get carried away with the global. And it is, UHC is in the end very grounded in the local political economy and the actors there. So we should keep the global alliances light and nimble, as Lara was noted. Build the evidence, focus the energy in support of the country champions and systems. No country is exempt of challenges, and in that, UHC is truly a global movement and makes us all, traditional donors and developing countries, really more equal. As such, we should not worry too much about the new global structures, but leverage and align institutional mandates and support country efforts, including the Joint Learning Network. I mean, that's been a great South-South learning platform that requires attention and support as countries advance to UHC. And as noted by Lara also just now, we need to keep this alliance simple and nimble and consider it a work in progress is most important. I guess I sense that we need to lock the design. We don't have to. Keeping it open, engaging actors will become very important. Cohesion is needed, but let us not over-engineer it. Stay flexible, as Lara also pointed out, and keep your creative juices flowing, because we will need a lot of creativity, because things will be changing. And one of the big bets we made in this movement is that the economic transition that I described will provide the fertile grounds for reorganizing health systems towards universal coverage. But they all depend on the political spark of an election, a post-crisis situation, and those are totally unpredictable. We need to be ready as a community to jump with technical and political assistance to support those champions locally that appreciate those opportunities for transformation. And I think if we do so, we will be successful to maintain the fantastic momentum of the last 10 years, supporting countries' advance of their health systems to universal coverage. You can count me in to keep this moment alive and thriving to 2030, and I want to thank you all and the organizers for this great meeting. Thank you.
Thank you so much. I was handed a mic at the beginning of this meeting. I completely abused of my power. I enjoyed the mic greatly, but I'm going to now hand it off back to, who gave me the mic, Finn? I don't remember. Did I just take it? I just crashed your meeting and you didn't even notice. But on a more serious note, I need to stop. Hey, I've been told everything I need to, but thank you all for being so agreeable. And I know Airman has been sort of a sight to see, but beyond showing you where to stop has been quite useful and helpful in taking some notes and helping make sense of some of the transitions when you went from a session that I didn't understand to another session that I didn't understand. But very quietly, just thank you all for being so graceful about your moments where you were asked to stop talking. And I will really hand over the mic now. If somebody doesn't take it away from me, I won't give it. So have a good night, enjoy yourself, travel well. And I don't know if IHP Plus, the core team, wants to say something, wants to send people away, wants to say goodbye, or you just want people to just... Here, somebody take it from me. Here, bye.
Okay, sorry. I want to thank a lot of people who have helped in this. ISP Plus is a partnership. UHC 2030 will be like ISP Plus. We count on our partners. We try to be as inclusive as possible. So the sessions has been prepared by a lot of different folks, not the core team and partners. And I really want to thank the session organizers, the teams behind the sessions. I want to thank all the speakers, all the people who have been contributing, the people who have been chairing, moderating, and so on. I certainly also want to thank our two overall facilitators. It's been fantastic, great. When I was asked to lead the organization of this meeting, the first thing I did was to get in contact with Valerie and get her to come here. I think for me, the biggest takeaway here is I met a lot of old friends. We have all met a lot of our old colleagues. But the most important thing, I think, is that we have met a lot of new partners in this endeavor of going forward to reach universal health coverage. So thank you very much.